Today, every business needs a website, unless this is what your business looks like. But if it's not,
Okay, greetings. Who's going to moderate? The sound is not very good.
Shopify helps you sell at every stage of your business. Sell it online, take it in person, and go big, like 1 million orders big. Whatever your stage, businesses that grow, grow with Shopify. Sign up today at shopify.com/YouTube audio.
Okay. Are you there, Chris? Thomas, are you there? I don't know what the plan is. Hello, is anybody here? Thomas, are you here?
Okay, guys, we're going to go ahead and get started. Can everybody hear me? No, you can't hear me. How about now? Is that better?
Yeah.
Okay, great.
Yes, we can hear you.
Welcome, everyone. Good morning, Drenda. Welcome, everybody, to I think this is the 8th annual Innovations in Cerebrovascular Science Conference. We're really excited that you're all here. We're ready to get kicked off. It's a big year for us. We're celebrating our 10th anniversary as a program. And so there's a couple of special touches this year and surprises that you won't want to miss. So we want you guys to stick around. If you can join us the other 2 days, please stay. But we're really glad that you're here today. Thank you for taking time out of your schedules to join us. So schedule of events for this week. I'll have a couple of announcement slides popping up shortly, but schedule of events today is all nursing and allied health. Tomorrow is going to be ischemic stroke. And then Friday is all things brain aneurysm and neurocritical care in the afternoon. So a couple of really cool talks tucked in here and there. And we really appreciate everybody, all of our speakers. The lineup this year is outstanding. So we're really excited that you're all here to hear all of the latest in all of these topics. A couple of words of thanks for our vendors and our sponsors. We have, none of this is possible. This is a really big event, and none of this is possible without the support of our vendors. And then obviously a big thank you to our conference planning team and committee. You guys have done an outstanding job, and we're really excited for this year's meeting. So thanks to all of our attendees this year as well. You guys are why we do this. So we hope you get a lot out of this week. And we're going to go ahead and kick off. So without further delay, I'm going to introduce Dr. Savageau and Drenda Vajjuk. Drenda is one of our survivors, but Dr. Savageau will give a quick intro. But we're really happy that you guys are here this morning and look forward to hearing your story.
Thank you, Wendy. Good morning, everyone. It's always nice to see people outside of the hospital. most of you look much better in your non-hospital attire. Some of them, it's even hard to recognize. So again, it's great. Thanks for being here. Thanks for being here, Drenda. As physician, a lot of time, I mean, you guys, all seeing the patient to part of the process. As physician, we have the privilege to kind of be able to see usually the patient through the entire process. A lot of those stories really are spectacular. We're privileged, we're fortunate to be able to meet people and to get to know about them better and be part, be witness to their story that a lot of time is pretty remarkable. I had the chance to, I mean, I'm not sure it's a chance for her that she had to meet me, but she'll tell you her story. We had the privilege to treat her at Baptist. Obviously, she is a happy ending. And through what has happened to her, she decided to use this new platform to really educate people about stroke, which is so important. And we could all do a better job because still a lot of people won't recognize the symptoms of a stroke. So she's done a tremendous job to do that. And on top of that, like if it was not enough, she decided to put a lot of effort in philanthropy. For people who are aware, a lot of the work we do in the OR with the angio suite, it's use a biplane, so a complex X-ray machine. We start 10 years ago, so it's like the iPhone. I'm pretty sure nobody has an iPhone that is 10-year-old right now. The new model are more efficient, they use less radiation, they're better, and our machine are coming to an end of life. So through our philanthropic effort, she basically allowed Baptist to purchase a new machine that will be installed in the near future. So again, thank you very much. And we're really grateful you're here, and thank you so much. Okay.
You. Can I do this? I don't know. Okay. Can you guys hear me? Yes.
You're not here.
He just got up, got his cell phone, called 911. The dispatcher had him ask me something about seashells, which I can't say to this day. And she agreed that I was having a stroke. Within just a few minutes, the EMTs were at my house. And yes, they concurred, I was a stroke. They put me on an ambulance, but they, as you guys know, time is brain. They decided the best option was to helicopter me over to Baptist Stroke Center. Well, the helicopter actually wanted to shave off even more minutes. They landed a state park like 5 minutes from my house. The ambulance took me there, put me on the helicopter. I came across the water. I landed on the helipad. And I don't think I ever told Valerie, Dr. Savinjo this very wonderful nurse who I knew when she was in nursing school. She used to work at a restaurant near me. Her name is Jamie Juneau. She's not in this department. If you guys know her, she's wonderful. She actually said, I heard that name and Vigics don't grow on trees. It had to be you. So she actually came over and said, you know what, you're going to be just fine. We'll take good care of you. And she was right. So from there, I was actually taken inside. And this is something I don't think I ever told Dr. Savinjo. I didn't realize at the time, I guess I developed tunnel vision. I thought, why is this place lighted like a medieval castle? You think they'd have some bright light that they're going to operate on me. But anyway, from what I've been told, I do remember some of it. Dr. Savinjo got me on the table, and within 26 minutes, he had plucked the blood clot from my brain. I started talking right away. and I haven't stopped since. I kind of like being up here in case you guys hadn't noticed. But I am just so blessed. Everything worked. I didn't have to have any physical therapy at all. And it's all due to you dedicated people and your training and the quick action of everybody around me. I am the most blessed human being on this planet. I'm enjoying my life, which, you know, it could have been totally different. I was a category 4 stroke, which you guys know more what that means than me. According to Dr. Savinjo, it should have taken out 90% of my right hemisphere of my brain, which would have devastated my left side, and I am left-handed. But thanks to this wonderful human being sitting right there and everybody around him, I'm here. And you guys are fantastic. So thank you, thank you, thank you. That's it. Thank you.
Okay, I think it's part of the problem here. As a lot of time, as being the physician, we get a lot of the credit. And again, what we're doing is what we're trained to do. But what is really important in our story is that everything took the responsibility and everything act really quickly. So at the end of the day, what we're doing, we could do it at a good time and help her being up here today. You know, the people, the EMS recognized was a large vessel stroke. Instead of bringing her to Nassau, you know, they took the decision to bring her to the beach where the helicopter land to bring her directly to Baptist. So again, if they were not appropriately educated, if they had not, you know, made the decision there, she would have end up on the Amelia Island, which again, the hospital is giving good care, but the delay, when the people are brought to the wrong hospital, you lose at least an hour and a half. So again, this was super important for her to have the outcome she had. Same thing, the team, when, you know, arrive in the hospital, the technologists are in the hospital. You may be aware, some of you, until 11 at night. The reality is that some of those nights, they're probably watching Netflix. But the hospital made the decision that we cannot have wait for people to show up if the patient are showing up. So again, financially, it's not an easy decision for a hospital to make, but this is the right thing for patient. Everybody would agree with that. So again, all those things are in place so we could treat patient on time and, you know, have them have a great outcome. So again, thank you so much for sharing your story. You know, we're grateful that as a team, we could take care of our community and people like you. So thank you very much.
Thank you, Drenda. That was incredible. I love to hear you tell your story. It gets better every time. You're such a great speaker. We really appreciate you coming to share with our team. That's so meaningful to us. It's hard to follow that, but I do have a couple of announcements for this. Can you hear me now? It's okay. All right. I have a couple of announcements. Again, we're celebrating our 10th anniversary. So thank you guys for all of you. Have any of you been here for the full 10 years? Anybody? Awesome. That's really incredible. Thanks for coming. We really appreciate you guys. And, you know, it's been a really incredible decade of innovation and bringing excellent care to our neighbors and our friends and our community. So thank you, everybody. We want to say thank you to all of our sponsors. None of this is possible without your support. So we really appreciate all that you invest in our team and our educational initiatives. Schedule, we kind of went over that already, so I'll skip it, but I do have some important announcements regarding continuing education. So if you're an APP or a physician, you'll use the QR code that's on the back of your agenda. So make sure you have a paper agenda. It's right at the bottom on the back side. You'll just submit that once at the end of the meeting. If you're a nurse, if you're a Baptist nurse, we need you, well, if any nurses, we need you to sign in every day, full name, license number, If you're in Florida, that will be reported to CE Broker, or if you're at Baptist, I can't remember if you're at Baptist, it's reported to CE Broker, but it will be reported to CE Broker. If you have questions or you need a certificate, please see us. I did include Susanna Tedrick's email address at the bottom. If you have any questions regarding nursing continuing education specifically, give her a shout. And if you have any questions regarding continuing medical education credits, you can reach out to myself or Chris Kemp, and we'll get you situated. So I think that's all for announcements. I'm going to introduce our next set of speakers. These are two of our stroke coordinators at the Baptist Jacksonville campus. They're going to come talk to us about what's coming for ICH. So we've got a lot going on for stroke. We've kind of done a lot to perfect that process here, but now we're going to talk a little bit about intracranial hemorrhage and what's coming down the pipeline soon.
Okay. Yeah, we got it. Perfect. Is that our clicker? I'm assuming.
Well, good morning, everybody.
Good morning.
We have a hard act to follow. Anyway, everybody can hear us okay?
Awesome.
All right.
Everybody in the back can hear us.
We're gonna figure out how to do the clicker and then we'll move on. Let's see.
I think they're loading our slides still. We're a little early. I don't know the soft shoe, so. Not working at all. How was everybody's morning? Awesome. How was the traffic? Well, this is what happens when you go first, right?
Mhm.
We're going to work
Yeah.
all the kinks out for everyone else. So it'll go very, very smoothly for everyone else who has to speak.
And Sam and I worry about speaking too quickly because we're both from New York, but
Yeah.
now we're taking up a little bit of our half-hour time.
Yeah, so we'll be able
okay.
to like rapid fire information. I mean.
Oh, I think maybe
Here
it's
we
coming,
go.
right?
It's here, but it needs to go there.
Okay.
Hello, yay. Thank you. Thank you for our IT team. We appreciate it.
Okay, ready, guys? Yeah. All right. Anyway, this morning we are going to speak about code ICH. The time is coming.
So the cool part is you can see here, this is our concern. We have no conflicts of interest.
Okay. No conflicts of interest. Okay, Sam, take it away.
All right. So as you can see, our objectives here, we're going to talk about intracranial hemorrhage, gain the knowledge of the latest clinical practice guidelines. There is new data out there. There's new information. So we want to just share that with everybody. Overall, you're going to see repetitive information because we want you guys to understand the importance of blood pressure management with these particular patients, and the importance of reversal agents. Also, we're going to implement an idea of putting it into a code situation like we do with our acute ischemic strokes for best practice and also better outcomes for these patients.
Okay. So as you know, out of about 795,000 strokes, probably about 80,000 of these are ICHs. ICH has been reported to be higher in the lower socioeconomic population, as well as the Black and Mexican American population. Stroke is usually defined as one of the deadliest forms. ICH, I'm sorry, is defined as one of the deadliest forms of stroke, and with early term mortality between about 30 and 40%, with no trend of improvement.
So it's kind of scary.
Yeah. So now what we're going to do is we're going to just take a brief look at the guidelines overview and pair them with the code ICH guidance to minimize hematoma expansion and improve our outcomes. Okay. So this first one is for blood pressure managing. And what you'll notice is it is not a class 1 recommendation. So really, there's still some conflicts on the best way to acutely lower blood pressure.
So here, the recommendations for ICH blood pressure management, we're going to go over 2 of the trials that they discussed. The ATTACH-2 trial, which suggested us to address the blood pressure management within 2 hours. And the Interact-2 trial, which suggests within the first hour to manage the blood pressure and maintain that blood pressure management for a continuation of 7 days. And this was known to reduce the risk of, evaluate the risk of death and major disability. For the more severe ICH patients, we have to take into consideration the cerebral perfusion pressure, and that would be more of an ICU type patient that we have to make sure that we have an EVD in place to evaluate for that.
Okay.
So now we're going to go into the 2 trials really briefly because I think it's early yet. Digestibility, right?
So 2 research trials that we're going to look at here to determine the ideal blood pressure and what that really should be. The results are really that we don't have a specific goal. Okay. The Interact-2 trials show that if blood pressure was treated within 6 hours, there's no real reduction in the risk of death. But however, it did show that the treated group did have better functional outcomes suggested by the modified Rankin score. Yeah.
So the ATTACH-2 trial here asked if patients with large ICH volumes would benefit from rapidly reducing that blood pressure. They looked at blood pressure that came with patients that came in to a target of 110 to 139. This is a much lower than the 140s that we have been talking about. And we actually found out that, well, the researchers found out that it was of no benefit to drop them that much lower. It actually caused more cardiac issues and more disability for those particular patients in that population. So again, keep in mind, the blood pressure management does not reduce the death component of this patient population, but it does help improve the disabilities of these patients going forward.
Okay, early anticoagulant reversal. This is a class 1 recommendation for our ICA patients. It is to be performed as soon as possible after diagnosis to improve survival. So my little plug here too for anticoag reversal is how important it is to get the medical history, right? For our patients, we don't know if there's any underlying conditions that might affect their coagulopathies, any liver diseases, right? Hematologic malignancies, those kind of things, as well as their medications, right? Their current medications, they're listed when their last dose was. The reduction of hematoma expansion is the main goal here, right? To reduce the potential of rapid deterioration and poor outcomes. Generally, the treatment suggestion is to be given based upon the type and timing of anticoagulant medication. The best timing was noted to be as soon as possible post-validating your CT scan. So what we kind of mean here is like when we're doing a post-stroke and we're going to do TNK, right? We'll do the scan and we stop and we'll
No
give
blood.
right? No blood. We'll give the TNK. Then
But in this case,
right. For this case, what we would do is we would scan them,
see blood,
stop, right? Coag reversal, obviously blood pressure management. Okay. Just as a side note, the PCC, we wrote it in red over here, is superior at rapidly reducing the anticoagulation, nearly 8 times as effective as FFP. You know, the FFP you give usually a large volume. and you can have a volume overload or pulmonary edema.
Potentially.
Mhm.
Okay, so we have a lot of class 1 recommendations out of these guidelines. So here's another class 1 recommendation for encouraging standardized processes. And that's why we're having this conversation today, right? So number 1 recommendation for overarching is to have a set process and how you're going to care for this patient population in situ. Another class 1 recommendation for this is our mechanical DVDs. So SEDs are very, very important for this patient population to help reduce the risk of DVT prophylaxis, put those in. And also it's noted that giving sub-Q heparin or low molecular weight heparins within 48 hours on is not considered problematic for expansion. And it's actually a benefit for that patient.
Okay, nursing care. Nearly 23% of ICA's patients had a neurological decline in the ED, and nearly 70% of the ICA patients had a neurological decline within the first 24 hours of admission. So think about that, right? 23% in the ED and nearly 70% within the first 24 hours, right? So neuro decline is at its highest risk between 12 and 24 hours post-onset. The most universal evaluation, as we know, was the Glasgow Coma Scale. And it has been noted that in the pre-hospital setting, this patient population is more likely to have ultra early neurological decline at a rate of about 31% as compared to the ischemic stroke patients that have that ultra early decline at about 6%. Big difference.
Right. So first responders, like if you have a patient that you pick up stroke symptoms and you see an ultra early decline, most likely consider the fact that this potentially could be a large ICH.
Mm-hmm.
And in that vein, they say that the majority of the, oh, we just skipped right. There was another piece, but all right. There is, all right. There also in that vein, as far as the evaluations, it's noted that the bedside nurse's assessment overall has reduced the risk of, actually it's helped determine going to surgery or not 55% of the time, where only 46% of the time the imaging encourages us to go to OR. So the bedside assessment is key here. So the nurses, you nurses are like the key to make sure that these patients stay safe. So we're not asking you to do repetitive assessments for no good reason. It's in the guidelines.
That's why we drive it home.
Yeah.
Right, right. Class 1 recommendation for glucose management and temperature management really is the same as with your ischemic stroke patients.
Yeah.
Okay.
And another class 1 recommendation here is not to just preliminarily treat these ICH patients with anti-seizure medications. It's actually proven adversely has an adverse effect on these patients. You want to make sure you only are giving anti-seizure medications to these patients if they show seizure activity.
Okay, early minimal invasive surgical treatment. Sam and I are laughing because as we were practicing, this was like a tongue twister for us, and we kept on saying it. And I said to her, forget it, we just have to read this right from the slide. For those patients with an ICA of greater than 20 to 30 cc's of volume, with the GCF scores between 5 and 12 is considered reasonable and may prove effective to improve functional outcomes as compared to conventional craniotomies.
Right. So overall, we also have to consider that interventricular hemorrhages occur in about 30 to 50% of these patients, which can lead to hydrocephalus. So it's evident and important that we consider EVD placement to offload these patients.
Right?
Yeah.
Okay. All right. Let's talk about best practice now. So now we're going to get into some code ICH stuff,
Now we'll
right?
give you all the details. Now let's talk about the what we're going to do with
And
it.
you'll hear, as Sam said too, this is just, there's a lot of repetition because of the importance of it all. Okay, a group of ICA researchers did the work to develop a protocol to bundle care to rapidly treat the ICH, right? class 1 recommendation in similar fashion to the code strokes. Specifically targeting the therapies known to improve outcomes in the patient population. Bundling care similar to what we do with our ischemic stroke patients is our future.
Oh, sorry.
Oh, it's okay. So the process we're going to discuss is something that it's not like sequential, right? We really want to do things simultaneously here for the best outcomes for our patients.
And CTAs in these patients are important to see if we have a causation for the hemorrhage, like if there's an aneurysm or anything like that. So again, repetitive. Early detection is key. So, nobody has X-ray vision. Nobody's going to look at a patient and be like, oh, that is a ischemic stroke or that is a hemorrhagic stroke. Imaging's key. And that determines which direction we're going to go, what therapies we're going to treat. So in order to do this, we have the recommendation states 25 minutes, but we really should marry what we do with the acute ischemic strokes, and it should be as quickly as possible to get those patients imaged, the first CT to see what's going on. That's probably the most important.
Ready?
And again, like I said, the CTA, again, to evaluate for causation for the hemorrhage.
Okay. Overall, the reversal treatment should be given within 60 minutes.
The golden hour.
Yep, the golden hour. The treatment, as we said earlier, is based upon the anticoagulation medication in use. Anticoagulation should take precedence prior to continuing the imaging, as we said before, like in the TNK type process, right? And should be done in conjunction with blood pressure management. The other thing in the guidelines they mentioned a little bit about was the platelets. So this is just kind of a little note on the side too. The recommendation for platelet reversal prior to surgery is reasonable to reduce the risk of potential post-op bleed, whereas it would be harmful if you're not going to surgery.
So it's not a catch-all.
Yeah.
So again, to drive it home, the golden hour, 60 minutes. The goal is to get your blood pressure parameters to where you want them and maintain them at that goal rate for the duration of the 48 hours of the acute phase of these patients. So lowering the blood pressure is noted to be of benefit, obviously, but as we've talked about in the guidelines, there's really no class 1 evidence to say this is the blood pressure to go to or this is the blood pressure to go to. So overall, they have suggested goals that are reasonable, and that's how they quoted into the guidelines. It's reasonable to get to a certain goal, as opposed to like just plummeting the pressures. Remember, that's no good. Keeping the pressures high is no good. So here it's a 2-stage process, and these are reasonable guidelines to follow. So if your blood pressure, your patient presents with a blood pressure between 150 and 220, it's reasonable to get that blood pressure goal into the 140s, okay? They give you an average of 130 to 150. Let's take the difference and shoot for the middle. 140 seems like a reasonable, attainable blood pressure goal. If the presentation of that particular patient is superiorly high in the 220s, again, we don't want to bottom them out either because that's bad. So it's reasonable to drop them by 60 millimeters of hemoglobin and hit in the 160s. And again, once we obtain that blood pressure goal, the overarching goal is to maintain it. We don't want fluctuating blood pressures up and down. That could be problematic for those particular patients and cause rehemorrhage, or actually more damage to that brain tissue, causing a deterioration in that particular patient.
Right?
Yep.
Okay. Why change? Okay. Why do we need to initiate ICH protocols? So as we've said, right, ICH is the most serious stroke, and we've had the least amount of success advancing management to improve these outcomes, right? It's 20% of our strokes. High blood pressure is so common with these ICH and strongly associated with poor outcomes. Ideal blood pressure is still unknown. results across randomized controlled trials and lack of evidence specifically in patients with large ICHs or those who receive neurosurgery further muddy the ideal blood pressure goals.
Right.
So, and in this picture here, you'll see it's the same patient at 3 hours with the ICH, and then at 6 hours, you see the hematoma expansion without control of their blood pressure.
And this is detrimental to the patient
Yes.
significantly, especially when they're under the care of a facility, right?
Mhm.
Okay, again, super repetitive, but implement code ICH is our ultimate goal for these patients. So we want to marry the acute ischemic stroke process into the hematoma arena. Okay, so we want to ensure the same urgency. We don't want to put once we get that diagnosis from the scan, we know that that's a hemorrhage. We want to continue on with care and as quickly as possible. We don't want to wait, pause, take a minute. We want to ensure that the ER staff is fully aware of the urgency to go forward with that anticoagulation reversals. We want to make sure that there's a pathway to ensure appropriate care for these patients and improve overall. We're looking to improve what? Disability at the end, because again, it's been proven that we cannot alter death or disability, the death component, but we can alter the disability piece with these patients. So emphasize the expeditious management of that patients for their anticoagulation reversal agents. It's very important to have protocols so we can automatically plug those in. Overall,
The takeaways.
takeaway. We highlighted a few things here and there's a bit of a repetitive nature to our talk, right? So we want to increase the recognition to optimize stroke care. We want to reduce hematoma expansion. We want to understand vascular pathologies when it comes to the ICH patients in regards to how we're going to treat them. We're going to have acute blood pressure management, again, key. ICH with anticoagulation medications can be causation for hematoma expansion. So we want to get medications on board and minimal invasive surgical approach has been proven and when to limit life-saving sustaining techniques. Please keep in mind that the new idea for when to implement the stop of all-out care on these patient population is 72 hours. So we really have to give this patient time to do better and respond to the therapies we're giving them. But please also keep in mind that palliative care and hospice consults are not life-sustaining. They are supportive for the families and very important to keep in mind as well. And then early assessment for discharge planning, because we want to ensure those patients are rapidly moved through the system when they're doing really well. Nobody wants to stay in the hospital. And rehabilitation services should be started quickly, but not until after the first 24 hours, because prior to that, ultra early care for rehab is proven to be problematic and detrimental to the patient population.
So, and I think really one of the keys as well here is the interdisciplinary approach, right? That we all work together, and that is key for the better outcomes for our patients.
And always doing research.
Yes.
Research.
So stay tuned because more to follow, as we like to say, in the ICH world.
Thank you all very much.
Right?
Thank you, guys. Any questions? Questions from the audience?
Huh?
No questions.
If you have any, let us raise your hand and we'll get a mic
No
to you.
questions for people.
I'll ask a question. I hate to let a good talk go to waste. I'm back here. Thank you guys very much for that. That's awesome. There are a lot of key takeaways and there's redundancy always, I think, in these workflows, but you just cannot hammer it home enough. I did want to ask two questions. Here down in Baptist, are you guys using Indexinet?
We do have it available, but it's not auto use.
I'm just curious, only because, I can't get it on formulary at my hospital. It is very expensive. There's not quite the indications out there yet, 100% that I think everybody's feeling comfortable, but didn't know if you guys were considering, if you're using it, to do any kind of comparison study or control study of, your maybe retrospective, PCC patients versus your Indexinet patients.
If I'm still on.
Yeah.
With the research piece, that could be really good, but we'll throw it to Diane because, she's our girl.
Yeah, I like that idea only because I think that there's not a lot out there yet that shows us what we should, to guide us in what we should be doing.
So they actually just completed like their nationwide look at
Mhm.
this, but the results haven't been published.
Haven't been
And I
published
think
yet,
that's
yeah.
the key piece that's missing in more widespread adoption. They're actually here, so you can stop by the table and talk to them. They're very interested in collaborating with future research, but until the data is actually out, it's really hard to move the mark.
Yeah, no, we've had a really difficult time getting that in, and I've presented in front of PMT committee like 3 times and they keep telling me no. So they're like, you're very persistent.
I will say the cost isn't actually prohibitive anymore because they'll have you store it and you only are charged if you use it. Otherwise, they keep it up to date for you.
Yeah.
And I think we have a overinflated idea of what the costs are. When you look at a slide like hematoma expansion,
Yes.
the cost seems pretty low if you're looking at the first versus the second patient, if it's going to prevent that expansion.
Absolutely. If you're avoiding
it's super
surgery
effective.
and all of the interventions afterwards, the
Yeah.
cost is not prohibitive. Totally agree.
But there's a little fear for thrombotic events with it too. And so that data that has been released is a little concerning.
Yeah, that is exactly what they bring up. And I think that is important for probably anybody in the audience that doesn't know is it's the thrombotic complications. Post-Indexinet is where the concern comes in, is that you kind of swing in the opposite direction. But hopefully the new research that's being published is going to give us a little bit more detail behind it. The other thing I wanted to ask is this group or anybody in this group moving towards that minimally invasive surgery? And maybe that's a question. I don't know if Dr. Savageau is still in the room or.
I think he stepped out.
But I know that's been something we've been discussing with our neurosurgery team. And there's this, we're on the fence. Do we really need to go to minimally invasive surgery? Is there enough evidence to support moving all of these patients into a surgical space with 30 cc's of blood in the head?
I mean, the data for that is excellent, actually, and that's why we have a 2A recommendation for it. It hasn't spread in the Southeast, but if you work in the Northeast, it's becoming standard of care. So if you have intracranial hemorrhage and you're going to have this surgery done and you're going to have slightly better outcomes than we have down in the South. So I hope it's coming.
Yeah. Okay. Thank you guys very much. That was great.
Really good questions.
Awesome. Thank you, guys.
Yes.
Anything else? I think we have another minute or two if you guys have other questions. No? Okay. So I'm going to introduce our next speaker in just a second, but before I do that, I have more announcements because I forgot to make some earlier. We will hand out evaluation forms for nursing in the audience. We will hand those out right before we go to lunch. You can leave those on the table or you can turn them back into us at the end of the day. However you want to get them to us is fine, but we do need those evaluation forms. Also, make sure to get your vendor card and visit our vendors and our sponsors and our exhibitors that are in the exhibitor hall. There's also some out here in the hallway. But at the end of every day, we do kind of a little giveaway with a nice little basket full of all kinds of wonderful things. So you might want to stick around to participate in that because you got to be here to win it. But you'll want to stay for that. But also you got to get your cards stamped because we only take the cards that are filled with that have a stamp from each of the vendors. So those are my announcements. And next I'm going to introduce Denise Walker. She's the nurse manager for our Weaver 5 IMC and PCU unit in the Neuro Tower and the Weaver Tower at Baptist. And we're really excited to have her present this morning on her work with the IMC. Welcome, Denise.
Hi, guys. So we're taking a little operational take instead of the clinical piece too much here, because if we can't operationally get our patients to where they need to go to get the care, no matter what great program we have, it's all for naught. So we'll start out by the objectives today. I want to talk to you about the conceptualization and the etiology of an IMC. We want to discuss the patient criteria and our preparation for developing an IMC with our nursing staff. We'll discuss a lot about the barriers, as they always are, and solutions, and then also preliminary outcomes and proof that this concept of an IMC can be pretty fruitful. Let's see. Great. A little background for those of you that don't know or aren't from Baptist Health. I have to do a plug. I've been working there for 28 years. We're the largest health system and most recommended in Northeast Florida. We're community-based, which is a key piece. We're not for profit. Where we work now, where I work downtown, we are a tertiary center. And we have almost 500 beds. We probably could use 500 more, but that's the whole piece of being proficient operationally. Okay, so the idea for a IMC, where did it come from? Well, our neuroscience program was just booming. We have patients that were going everywhere throughout the system and even our downtown campus. We had 2 beautiful neuroscience PCUs. We have Weaver 9. And they're a neurosurgical PCU. We have Weaver 8, which is a neuro PCU. Medical, go Weaver 8. Of course, we have our great Weaver 10 ICU, but the patients weren't getting there because we were backlogged and our program was growing. So our population was increasing. Everybody's moving from up north to come to us. And unfortunately, we have low literacy and socioeconomic disadvantage. So that also expanded our population. So Weaver 5 in the Weaver Tower, it was an empty unit. It was built as an ICU. It was intermittently used when we were renovating, like the medical ICU. Those folks would go there and then those units would get renovated. Mother baby went there when they were getting renovated. But in fiscal year 2021, we realized it was going to come available. What should we do with this unit? No brainer. Our neuroscience population was going everywhere. And of course, outcomes weren't as good because, as we know, with advancement in medical care, that we need neurospecific or specialty-specific nurses to get the most outcomes. We were really falling out on our stroke quality measures, so that team was having a heart attack. So also, how do we decompress the ICU? It was a log jam. We were having ED holds, we were having PACU holds, and we were boarding PACUs. So that's craziness too, and it costs a lot of money. And when the literature investigates ICU and ICU admits, we really recognize that of those patients that are admitted to the ICU just for monitoring, about 70 to 75% of those patients actually have a deterioration index of less than 10%. Do they really need to go to that ICU and clog up a bed for a true patient that needs that intensive care? And then also 20% of all ICUs, not just neuro, but all ICUs, they are deemed inappropriate according to the literature because of their low severity of index scores. So that artificial intelligence that grabs all that now is kind of making us a little bit honest. So why not use a portion of Weaver 5 for those lower level ICU patients? What a great novel idea. Brilliant. We are brilliant. Our team is brilliant. We're going to save the day. Well, unfortunately, it wasn't such a novel idea. Good idea, but not a novel idea. The concept of intermediate care units are in the literature well before the 2000s. There's different nomenclature. You'll have them as step downs. You can see them as step ups or intermediate care. There are studies out there, but just like with nursing, we really need to push the data and studies. Most of them are heterogeneous. They come from Europe, they're different patient populations. So it wasn't enough to really establish this as best practice. This is what we should do. But there's certainly, most of the studies were super positive with their outcomes. So it was definitely something that we should look at. So in the literature, when you read about these type of units, they're deemed flexible, the flexibility. As you adapt your staffing and your nursing ratios in the same bed according to acuity. So first you're at that intermediate level, and then when it's no need and we can go to PCU, we adjust the patient ratio from 1:3 to 1:4 and keep them in the same bed. I'm good now, thanks. And keep them in the same bed. There's actually a model about that too. And we're also efficient. So it decreases the PACU and ED holds, decompressing that. And then also these IMC units in the literature decrease length of stays, and it makes sense. So instead of going from the ED to the ICU, now we're transferring to PCU and then discharging. We can go right to that IMC and then discharge them from there in the same bed. And the big part is IMCs are very effective. There's excellent patient outcomes. There's increased patient satisfactions. Makes sense, right? Because they're not holding anymore. They're in a nice bed, the same bed until they get to go to rehab or until they get discharged. It allows appropriate use for the ICU resources. So instead of taking the time monitoring, these amazing nurses can actually do those intensive interventions that they need to do in the ICU with the other patients that they can focus on. The other thing too with this IMC concept, it's a great recruiting tool, because let's face it, all these new nurses want to go right to the ICU. And us old nurses know this is probably not the best. You get burnout, you're not going to be as good of a nurse as if you get that kind of core med-surg PCU training and experience. And so this way, that was a little carrot to hang onto them. Okay, I know you want to go to ICU, but we promise you'll be a better nurse. And look, these are lower level ICU patients. So it really worked out well, especially during the shortage. Okay, so we're going to do this. So the group, the intensivists, neurosurgeons, all getting together. We're going to do this type of unit because it makes sense. Literature supports it, but it makes sense. And we have to do something. We're so backlogged. So we had to get everybody on board with the same concept, the same flow, like herding cats, right? As we know, with docs and administration. We had many, many meetings. Our chief intensivist, Dr. Naval, was really the spearhead because he knew folks were going to him, let's just make another ICU. And he was like, we don't need another ICU. We just need to take care of ICU patients. These aren't ICU patients. They'll be great in the IMC. So we got administration support, you know, just as long as it didn't cost money, you know how that goes. Nursing support. At the time, our nurse exec, Cece Brooks, was on board. She wanted to call it neuro step down. The docs wanted to call it IMC. I didn't care. I called it whatever, wherever, whoever wanted it, just as long as we get to do it. The MDs still, neurosurgeons still, and we know how they can be a little bit tight on that. But we still went forward. So we defined our patient population. So we have, what about the thrombolytics that have a negative MRI? There's institutions that don't even go to the ICU or an IMC. They go to PCU even. So we can certainly do those. What about those with the thrombolytics that have a low NIH? They probably didn't even have a stroke. Why not bring them to the IMC to monitor instead of taking up an ICU bed? Transsphenoidal tumor resections, small bleeds, lumbar drains, all these are easy. We could probably even manage them at PCU, but it would be a good start for these patients. So, and then we looked at our nursing and how we're going to develop our nursing. Even though IMCs required less nursing in numbers, the literature supports that these nurses still have to be trained as much as the ICU nurses. Okay, so we know administration's not going to go for that. So let's think about it. There's no sense training on EVDs if we're not going to get EVDs yet. If we're not, there's no sense training on vents if we're not going to get vented patients yet. So let's really focus on the patient population that we identified. So we got lectures together. The docs were great and they came and chatted with us. We did resource books that were really clean and simple. Okay, you're getting a thrombectomy. These are your monitoring. This is what you should look for. TNK. This is the danger zone of when there's a hemorrhagic transformation. So we were pretty set. Again, the doc's a little tight because they really wanted ICU oversight. That made them sleep at night, that they had those ICU physicians and APPs overwatch their patients. They didn't have to worry about it, even though they really didn't do any interventions with it, but it made them feel better. They're still a little nervous too with Weaver 5, because when we opened in fiscal year 21, we actually had no Baptist nurses but me. So we really kind of from the ground up recruiting, and we all know it was a nursing shortage. So from the ground up, we had to train, but they were good nurses and we can do this. We really wanted to do this. So slowly but surely we moved forward and we were going to establish this. Even though their grip was there, little by little, we were getting a patient here and there. And then that happened. We all know, have PTSD from that. I'm really 39. That's what it did to me. We were 5, then turned into COVID. So we went from being sharp and neuro nurses to now trying to figure out respiratory and how to manage this awful disease. Not only that, we even had to double up. So talk about a nightmare. I can't even believe I was worried about the patients, worried about the team. So the IMC was far from all of our minds at that point. So fast forward a couple of years, as we know, quote unquote, timing is everything. We're in 2023. Thank you, Jesus, COVID is gone. However, the gridlock is even worse for our neuro patients in Baptist downtown. Is it time now? Our Weaver 5 nurses were growing, we were getting stronger, we were getting all our own team and established. We were having really great patient outcomes just from our PCU. So should we regroup and look at our IMC initiative again? So at that point, the docs were a little bit more open to talking about it because administration, Baptist Lyerly, they were going to get an APP. We needed another one for stroke because our stroke program, once again, now 10 years, is growing as well as our other neuroscience areas. So maybe we can split that APP that will cover some of the IMC and then cover the stroke and go to the code strokes and all that. Okay, that sounds like a good plan. There's more literature that was being published to support these type of units. So we're thinking, okay, fiscal year 2024, let's do it. We can do it. Why not convert 12 beds to an IMC status? 1-to-3 ratio. All the players are really getting on board this time, including the docs. We're so excited. Okay, so we revamped everything and we wanted things to be more robust. So we have, as you can see, many more patients. Tier 1s would be automatic. Tier 2s would have to have discussion and approval, but we can take those as well. Now this, and Dr. Naval's not here, but I think it's version 325. So that's how much we were going back and forth with the docs to try to agree upon this. And then nursing and nursing training. We have a lot of newer nurses that did not get the training from the beginning. It was almost 3 years. So we have an amazing nurse educator, neuroscience educator, Tiffany Green, that got this robust program for us. First, we had pre-work. She made us do everything from soup to nuts. It was long and it was hard, but we did it on Cornerstone. And then the great thing, she had this intensive, so we had lectures from Dr. Nima, Dr. Day, she did some lectures, but the key thing is we had sims. It was great, hands-on sims. And so we got to play with the lumbar drains, the pupillometers, we had scenarios when a hemorrhagic conversion would happen. So we were really pumped up. And I'm proud to say 100% of the RNs went through all this. So we were ready. And so here we go. On your mark, October 1st, we're going to do it. Get set. So we had one final meeting just to dot our I's and cross our T's that this is going to work. And it was like the 3rd week of September. So we're all set. And then finance. So, oh my goodness. So those folks that we know and love, but thank God they're running the system and not me, because we would be out of business if I was running it. But they, because of the sequela from COVID at that point, even though we got reimbursement from the government, we really took a huge hit. So they made the difficult decision just to pull the plug on all new programs in 23. Didn't matter. It wasn't just our IMC. It was all new programs so that we can get our footing better. Even though I wish I had an opportunity to tell them how much money they would save by us doing this, but I didn't. And so there we are. But let me tell you what, there's not much that makes those physicians quiet without a word. We were all deflated. We didn't know. There was silence on that call. It was a shock, number one. It came out of nowhere. And it was just like, it's been almost 3 years. How can this happen again? And then at this point, it's like, what am I going to tell my team? Are they ever going to trust me again? Because I kept on saying, it's coming, we can do it, we can do it. And I'm thinking, we just can't keep up. Give up, excuse me. We just can't do it. It's the right thing for our patients. And it's also the right thing for our health system. We have got to think out of the box. Those poor patients and the gridlocks that we have and the monies that we're wasting because of it. It's the best thing to do. So we decided to persevere. We had a relatively new director at the time, Corinne. And I'm not sure if you were just concerned of a mass exodus, because I will tell you in all transparency, I was working on my resume after that meeting. And the team as well. So we put our heads together. How can we do maybe a pilot? Okay, we don't have the FTE to do the 1 to 3, but how can we make it as a pilot to really show some good solid data to finance so that maybe in fiscal year 25, we can open with the 12 beds. And so we were going back and forth and we thought, how many beds could we do? Our A&Ms are up, thankfully. During COVID, they were never up. So they had full patient load plus their responsibilities. But is it okay to ask them maybe to take that 1 or 2 patients when we do have those 3 to 6 IMCs? Is that fair to do to them? So I had a meeting and I didn't even get it out of my mouth when all 4 of them said yes, because they believed in it. They wanted to do it. Even though they would have to take those 2 extra patients, they did not even hesitate. Right, Shawana? Yeah. So everybody agreed, we're going to do this. Once again, adjust and overcome. So October 1st, it's a pilot, but then I got a plug here, Corinne. She got cold feet and said, no, we can't do it. I don't think we're trained. We're not doing it. And I was like, oh, yes, we are, because I'm done. So it's a whiplash back and forth, but yay, we did do it. October 1st, we opened. The admissions were pretty scrutinized by our intensivist, the neurosurgeon, and myself, because we wanted it to be pure. We wanted to be successful. We were real good stewards about it. We downgraded to PCU as soon as the patients didn't need that close monitoring. And we really had great results to the point where other surgeons wanted their patients at the IMC, and it makes sense. Who wouldn't want 1 to 3, right? So, and here's just a stratosphere of the different diagnoses. As you can see, we're kind of across the board. From shunt revisions, cranies, TNKs, close watches. We even had a respiratory IMC patient at one point. So here's the data. Now, of course, I would love more numbers, as would we all. But right now, we are up to, as of February, 57 patient days. It's not a lot, but at least we have something tangible that we can show finance. It's a total of 27 individualized patients. Of that, only 2 we had to transfer to the ICU. And that was a very controlled transfer, because I'll tell you, the ICU is so supportive of us, between the docs, APPs, even the A&Ms would run down and we say, we're calling a friend, phoning a friend, help us with this. Super supportive, super patient, because we were pretty diligent because we want this to work. And they're like, no, it's okay. You're all right. You're all right. So here's the key, and this is the big key for admin. estimated charge avoidance, and it's pretty conservative. It's about $2,000 a day from ICU to IMC. So if you think about that, just the 57 days we had, it's over $100,000 worth of savings. And that's just a sprinkle here and there of the IMC patients. We had just one IMC patient a day, we can save over $700,000 in charges. So it's really a no-brainer to me. Could save the money, it's patient satisfaction, outcomes are supported by the literature, and our experience are really good. And if you think about this, it doesn't even include the cost savings of the holds in the ED, the decreased length of stay, and the boarding and PACU. So it's really something we have got to try to persevere and push through. We have to optimize our practice and our flow so that we have such a great program, but our patients aren't getting them because they're being stuck. So it seems like it's a win-win everywhere. Of course, there's always issues and opportunities, PDSA, right? Adjust and grow, adjust and grow. One is IMC label and Epic. I see some Epic people there. Of course, you know, their job is to try to put those barriers, but we have to overcome that. And so I think they're working on it. Communication with the hospitalists, they were a little nervous. Neuro is difficult, right? Let's face it. Neuro in general, the nurses are usually high functioning, high performers because neuro is difficult. So with hospitalists, some of them that don't really like neuro were a little bit taken back. They didn't know how to care for them as well as they felt like they should. So we were looking into having neuro hospitalists. So neuro-specific hospitalists cover our neuroscience units, which makes sense. That will be more proficient as well. I'd also like to loosen up their criteria a little bit, tier 1, tier 2. We know we can take care of all of them. And then we need to send IMC patients to the IMC. Old habits die hard. Those docs are so used to having the patients go to ICU, even when, again, TNK, MRR negative, but yet you're still sending them to the ICU because ICU has beds. Just because they have beds doesn't mean you shouldn't send them to IMC. They have the beds, but yet still you can have their resources focus on those truly sick patients instead of being diluted with patients that really shouldn't even be in the ICU. And then we also know nursing, we have got to do more studies and more research so that we can establish as best practice and good care. Okay, so what is it all about is our patients. Have to tell this story. So it's a 28-year-old man, Anthony. He ended up with super refractory status epilepticus, say that 10 times fast. And he was in the ICU for many weeks, and they pulled out all the stops to try to help this guy. Even did shock therapy, right, to try to get these seizures to stop. Well, all this medical support was exhausted, did not need ICU support anymore. So came down to the IMC, still real nursing heavy, had to really assess, had to make sure levels were correct and high enough, had to make sure if he did have breakthrough, we were on it to stop it right away. And so we had him for about a week in IMC status, maybe a little bit longer, but we were good stewards and the data we collected was appropriate. To the point to where having that 1-to-3 ratio, all of a sudden he actually talked, came out of nowhere. Dr. Chimasani almost fell out off his chair when I texted him saying, "You're not going to believe this, Anthony's talking." So then he ended up getting decannulated. He was talking. Not only he was talking, he was telling us what to do. He was telling me he's running the unit and I should get rid of her, but I should give her a raise. It was really great. And it ended up, instead of a long-term care, which is what we were looking for, we were able to transfer him to an STR near his family in Miami. And so that's a good thing, right? Was it from the care of the ICU? I'm sure. But was it really that close care that watched him to really so he can take that turn and recover? So the journey continues. Will it ever end? I doubt it, especially with our docs and trying to overcome. But should it ever end, there's always better ways of doing things, right? We can never, it's never autopilot. We can never sit on our laurels. The way healthcare is going, we always have to look how to optimize and to provide the best way we can, the most efficient way we can. And so I just want to say many thanks because it takes a village, that is for sure. First, my partner in crime, Dr. Naval. Him and I probably have stock in antihypertensives with all the meetings we had to go to and try to overcome the barriers that kept on being put forward. Tiffany Green, our amazing educator who still continues to support us and make us amazing neuronurses. The intensivists, Shah, Chimasani, and Maradia, and the APPs for being so kind and patient with us. Of course, we got to do the neurosurgeons and interventionalists, Hannel, Savageau, and Dr. Nima. Slowly but surely, their grip is releasing. And Corinne, even though she got cold feet, thank you for trusting. Thank you for trusting us so that we can move forward. And then most importantly, this amazing team. They are pliable. They adjust, they're passionate, and they provide amazing care to our patients. I love our patients, but they love one another, and I love them. So thank you, guys. Questions?
Thanks, Denise. That was great. Guys, do we have any questions from the audience?
Hi, thank you. That was a great presentation.
Thank you.
My question is, with these patients, do the nurses go on road trips with them? Like if they're going to CAT scan, like an ICU nurse would?
It depends on what's going on.
Okay.
But yes.
And then do they draw the labs?
Mhm.
Okay. And then are all the patients on continuous monitoring still?
Mhm.
Okay,
Mhm.
thank you.
Yeah.
Okay, she's coming.
You won't need a mic.
For the online audience.
No, that's true. I know you don't need a microphone. I was gonna ask, when you were deciding on your criteria for the different levels, so let's say on the tier 2, you said those were up for discussion. So your patient comes in through the ED and you go, okay, they might be appropriate for this, but we're not sure. How does that discussion get started? Who's involved in that and how quickly does that get decided?
So we're working on that with our PCLC, which patient control logistics centers, where they place the beds and the patients. And so it's difficult, number one, because we don't have that label. So that makes it difficult in the scheme of things. Right now, the docs will be, if it's in the ED, the intensivist will look and say, it's an IMC patient. I'll look, making sure it's nursing appropriate. And then they will say, okay, IMC. And what happens is they'll put PCU, because right now we don't have that IMC built, and then with a note. So sometimes that gets missed. And so that is an opportunity. But right now we're still kind of working those things out. But our bed placement nurses are really being proactive, and they have identified several, and then we'll just go through the process. Whatever intensivist is on call, and or myself or neurosurgeon, and we'll identify it. Hopefully, when we do have that 12-bed unit and we have that APP covering, it'll be more of efficient and smooth and automatic. Anybody else?
Anything else?
All right. Thank
No?
you, guys.
Okay, awesome. Thank you, Denise. Okay, well, I'm going to introduce our next speaker. She comes to us from Chicago. She's at Advocate Aurora Health, Advocate Aurora Atrium. All three, all the A's. Very large health system. A dear friend and colleague of mine, Kiffin and I met many moons ago at a meeting, and have been good friends ever since. But she's going to present to us this morning on developing a dual APP and stroke coordinator stroke clinic for our patients. So this is kind of focusing a little bit more on the ambulatory side. So we're trying to hit the whole spectrum of care here today. So welcome, Kiffin, and thanks for coming. We're glad to have you again.
Awesome. Okay, you guys can hear me. I can hear myself. This is great. Thank you, Wendy. And I just want to say thank you to the organizing committee for having me back. I always love to come to warm Jacksonville because it's very cold and maybe snowing in Chicago. You never really know what's happening there. I'm super excited to talk today. I kind of feel like we talk a lot about the hyperacute phases of stroke and neuro, and it's kind of the sexy, fun, exciting side, but we do sometimes just forget about that transitional care. Denise's talk is awesome, and thinking about how do we offload some of these patients for throughput and getting more patients in that need that hyperacute and acute care where we can put them in our beds. So all of these discussions and thoughts are really critical to us. And I just have to really make a quick comment. These chairs are hilarious. So like I keep thinking, am I supposed to sit in this chair? Like, hi guys, is somebody like, are we gonna have a little conversation, like a debate about things? I just love the chair. I might sit down. I don't know. Anyways, it kind of throws me off up here. Okay, so this is my talk. These are our objectives. I really am gonna just focus on transitional care. And actually, I have talked before down here on development of a multidisciplinary clinic. I confess I was a little confused on my talk. So you're going to hear about our multidisciplinary comprehensive stroke clinic that we've developed and sort of where we were at and where we're at current state, and then development of an APP, an APN-led clinic. I don't have any professional financial disclosures. I have many, but I won't go there. So what do we know? The average stroke survivor requires 35 to 59 hours per week in informal caregiving in the first 12 months following stroke. So caregiver strain is real. It's not really well understood, and it's not really that well researched, but it is a huge impact on our families and our caregivers once our patients leave our hospitals. There's large gaps in care and understanding caregivers during these critical transitions. So what are the unmet needs? What are the adverse events that are occurring at home that are leading to these high readmission and rehospitalization rates? Utilization of a transitional coach, such as an APN or a nurse, maybe a therapist, maybe a social worker, is associated with lower rates of hospital readmissions through the first 90 days. Increased adherence to follow-up stroke clinics is really critical. Timely follow-up with phone calls does help with that, but really presenting in our clinics is what we need. We need patients to come back to us. Patients do often consult with their general practitioners in the first year. I'm very sorry if there's general practitioners in the room. I'm not targeting this comment at you. This is a general statement, but in general, GPs don't follow recommended stroke guidelines. And that's just kind of a common theme that we see. I'm lucky enough to see patients both in the acute phase. Oh, thank you for that. I don't know how that happened, but I can see it better because my eyes are kind of crazy. Okay. The guidelines are not really followed by the GP group. And I think this is really important to us, is maybe that's part of our education, is how do we better get those new guidelines out to our partners in the internal medicine space. So when we think about transitioning our patients hyperacute to home, we really need to rethink and redesign what our care pathway looks like. And we know if we do this, we can actually really have very good success. We can keeping up with the advances. It's been difficult in transitional care because it's really not well defined. What does transitional care mean? It really starts at the moment that the patient gets admitted, but we oftentimes don't think about it till like day of discharge or day they're leaving to go to rehab. So really not well developed. So what are we missing? So understanding of rehab readiness, and we need to be nimble in the environment. We're pretty rigid, right? We say, oh, we have a bed, don't have a bed, they can move, they can't move. Oh, your Medicare payments are up, you got to go. Can't give you anything more, and good luck. Do you have help at home? So again, that caregiver strain, we see it all the time. Increased compliance and efficiency for collecting and reporting data. oh my gosh, doesn't exist. We have 1,000,001 tools when we're in the space of in our ICUs or in a stroke unit. But as we transition out to rehab, as we transition patients to home, it becomes very difficult to collect that data and to store it somewhere and to extract it and abstract it into a meaningful report for us to evaluate. Secondary prevention and stroke rehab is really, really critical. So what are the problems we're going to aim to fix? Compliance has to be key, right? We know our patients are really not compliant as they leave our hospitals. And oftentimes that has to do with education because they don't understand. They don't get the importance of the compliance, whether it's medication related, whether it's why they need to follow up in a visit, whatever that might be. Availability. That availability could be many things. Might be availability of a ride, might be availability of money to get drugs that they need, could be a ride to rehab, could be availability of physicians or APPs in clinic spaces in access to care. And then we want to fix readmissions, right? We want to keep our patients out of our hospitals from being readmitted. So this compliance, education, availability piece is really important. So we lack consistency and poor follow-up post-stroke admission. Patients, one of the big reasons is patients aren't being discharged with appointments. That's really critical. I mean, we tell a patient and a family member who comes in completely overwhelmed, oh, we're going to discharge you home. But by the way, we need you to schedule these 5 follow-up appointments and you can call the clinic. Oh, but that's the wrong clinic number. And you don't know why you're seeing this patient because it's just some general person's name that you saw once in the hospital. I mean, we have to help our patients leave the hospitals with appointments scheduled for them with a clear understanding of why it's important they attend each of them. Multiple provider appointments, difficult access, and there's a lot of confusion. As I said, they just don't know why they're going. I've had so many patients see me in my clinics and they'll say, do I need to go to that appointment really? Because I'll see, you know, hey, you have this appointment and this appointment. It was all recommended for follow-up. And they're like, yeah, but do I really need to go? Well, yeah, you really do. Yeah, this is why you need to go and see that cardiologist for your new onset atrial fibrillation or, you know, your PFO or whatever the heck it is. Then there's a lack of education and understanding of importance of the follow-up. So secondary prevention is poorly understood. In the acute setting, they just have too much coming at them. They're like clueless, right? They're like, oh my gosh, I have a stroke. I can't move the right side of my body. I can't talk. I can't eat. Can I go back to work? How's my family going to pay their bill? I mean, you know, when you start to think about, can you control your diabetes and get your A1C less than 10? They're like, what? You know, so we start to talk about secondary stroke risk prevention in the acute setting. It's like in one ear, out the other. So this has to be a space in post-acute care and transitional care. We're really hammering away at them. Long wait times to be seen in stroke neurology clinics, terrible access, almost everywhere, right? Almost everywhere in the country, we have terrible access. So up to 8 to 12 weeks. By the time they're waiting for these appointments, people are like, I'm better, I don't need it. I'm just gonna cancel my appointment. So they get lost to follow up. And then what happens? Well, then they're readmitted, right? The other problem is that we see a lot of, at least in my experience when I am in my own hospital system, and I didn't really say that, but I do come from a large healthcare system. And, you know, we're 25 hospitals big in the Midwest and about 67 when we include our Southeast partners. But we see a lot of one and dones. You know, you see them in the neurology clinic. They're like, oh, you're good to go. Don't need to follow up anymore. That is so not true. These patients need support through that first year of post-stroke. So what did we do? Well, there was a lot. And as Denise kind of pointed out, whenever you are going through a transition of trying to redesign how you're going to care for patients, it really needs to always start with a review of your current state and looking at your options. Like, what do you have going on right now? Who are your physicians? Who are your APPs? What are your support teams? Do you have clinics in place right now? So we did have physician stroke clinics. We had just neurology clinics that they called stroke clinics. And we wanted to start to think about, can we put in multidisciplinary comprehensive stroke clinics. So not just a stroke clinic where they come and see a vascular neurologist, but multidisciplinary, where we bring our team to the patient, not make our patient go to multiple team appointments. So that was a big look for us. Then we started to say, well, can we put APNs in charge of their own clinics? We know we do it all the time, but we didn't really have any designated APP stroke-led clinics. So we started to think about how might we operationalize that. We consulted the literature. So of course, any time we want to transition to something, we do have to consider, what does the literature tell us? There's not a lot when you start to look at transitional care and post-acute setting, long-term care management of these patients. So the BAMI group out of Austria published in 2021 a systematic review that did look at kind of included about 77 studies that had a mix of like functional outcomes, chronic disease state management, caregiver strain, and then looked at different outcome measures. The problem with those systematic reviews, they were in different settings, different resources, and then had different primary and secondary endpoints, in which case it makes it very difficult. We don't really have any, we don't have really any large RCTs that help us to have a control group to really look at, do the measures that we implement in the transitional care actually impact our patients? And what are the outcomes we're aiming for? Do we want to really focus on caregiver strain? Do we want to just look at readmissions? Do we want to focus on secondary risk prevention? But we don't really have any big RCTs that looked at that. I mean, Compass trial did look at that a bit, comparing 20 hospitals versus 20 hospitals, looked at a control group of usual care versus the intervention group, which included a telephone call 2 weeks post hospital discharge and then up to 90 days. But even in that trial, they only showed about, I think it was 39% of patients that actually returned into their visit. They got 58% of those patients in the intervention group that they were able to secure a phone call, but really only about 40% actually came back to that clinic for that visit to receive the intervention piece, which included like quality of life scale and screening and reviewing of their risk factors. But that's just it. That study is a little bit smaller, but it does tell us we've got work to do. There was good impact, but not significant. But we've got to look at the literature. And again, to Denise's point, we as nurses, as APPs, we have to be a part of the research process, coming up with ideas and how we participate in research. And we start to think about, how do we want to look at these groups and design some studies to look at functional outcomes, caregiver strain? Nobody better to evaluate that than us. So we need to be a part of that. Literature is really scarce. So we identified areas of need. This became really important when we started to look at geographic location. So I'm from the Chicago area. I don't live downtown, but I live in the city. And I often say like comprehensive stroke centers are like Dunkin' Donuts around me. There's like one on every 2 miles. There's a lot of us. I know that differs a little bit in this region, but that became very important to us as we look to say, where do we want to put our clinics? Where are we going to have the biggest impact, the biggest bang for our buck? We have to look at, where do other centers have their clinics at? Are there gaps? Are there areas where we have no clinics? Where do we see a lot of chronic disease states? So we went and did some data diving, looking at the different communities of people. Where did we have high levels of uncontrolled hypertension, diabetes, obesity? What was the socioeconomic kind of zip codes that we wanted to look at? And then where was that access to care really lacking? And where did we see stroke burden and disease state? So some of that data you can pull, out of your different communities. And that was really important for us as we looked at how we wanted to fix this and where we wanted to space our clinics out. We did also looked at our barriers, and that becomes people. Do we have people in place that we can just slide into a clinic, or are we looking at new FTEs? That's a whole different talk, pulling some FTEs out of the air and workforce planning and budgeting for it. And then we looked at space. Space is also something you always need to consider. You're trying to build out a clinic. We had to engage with hospital leaders, operations, and stroke program leaders. Really critical. That is like first step. Who are your stakeholders? Who do you need to get on board? You will never, ever, ever push a project like this through without buy-in, a lot of buy-in over and over and over and over again. Collaborated on goals of the clinic. What did we want? What were going to be our measures of success, our clinic design, and how were we going to operationalize it? So some of our initial considerations, as I said, geography was big. Where do we need the follow-up? We're a big hub and spoke model. So as I said, we're a 25 hospital system in Illinois. We have 2 comprehensives with a 3rd one coming up, and we have 2 in Wisconsin. So we're a big hub spoke model. So what we find is that we transfer patients into our comprehensives, but when we go to try and send them back out to their primary stroke center areas and communities or their acute stroke ready, they don't have the resources out there to see neurologists back in these clinics. So we didn't have a place to send these patients back. So we were finding that the patients weren't following up. They weren't getting anything else, and they were representing back out to their primary stroke ready or acute stroke readies or their GPs with secondary events. So we really had to consider that. Where were our communities of need? As I said, lack of stroke neurologists to see the patient, wait times up to 6 months. We had to consider that. Like, do our neurologists have the bandwidth to do this? The short answer early on became no, they don't. They don't have the bandwidth to do this. So what are we gonna do about that? Again, getting them to the table and having some really good conversations. Limited ambulatory space for growth. Oh my goodness. So you have to say, do we have a space that we can actually put these patients in a clinic setting? Where is that? Is it on campus, off campus? If we don't have a clinic space, can we use a hospital-based clinic, which looks a little bit different? The billing becomes different. So there's a lot of difference in charging. And then who owns and manages the clinic? Who's going to be that practice manager and engaging with them very early on? Then talking about that FTE budgeting, does volume justify this new hire? So we wanted to then start with, before we got our key stakeholders at the table, we wanted to establish the goals of our clinic. We wanted to decrease secondary risks. We wanted to have increased follow-up compliance. We knew that. We wanted to see them in our clinics within a couple of weeks, and we wanted that compliance with them. We wanted a multidisciplinary team approach as much as we could. It's really critical. I work in neurosurgery and the neuroendovascular space. That's where I've been for, over 20 years. But I will say that I recognize when I see a patient, I'm looking at them through a different lens for sure than my PM&R partners and my neurology partners and others. So that's really important that I make sure they're at the table and we're all talking on goals of care. We wanted to improve access to get our patients in sooner and more easily. We wanted to reduce readmissions. And then we wanted to have some coordinated diagnostics and follow-up. It really stinks when we bring a patient in and I order, a CTA of the head and neck, and 2 weeks later, the neurologist orders an MRA of the head. And it's like, why couldn't we coordinate that? Or somebody orders a carotid ultrasound when I'm already getting a CTA of the neck, in 2 days. So these are the things that we wanted to better coordinate in our clinics. So we created the roadmap. We identified our key stakeholders and affirmed buy-in with our executive leadership teams. We defined our clinic space, our clinic logistics. We did some scoping of marketing. How did we want to grow? And then we decided, how do we want to monitor and evaluate our growth plan? So whether that's financials, volumes, measures of success, we put all that together and we came up with a roadmap and design. We did define what our comprehensive stroke clinic meant to us. And again, that meant multidisciplinary. So we do bring in neurosurgery, neuroendovascular, stroke neurologist, a physiatrist from PM&R, and then we bring in a stroke nurse. And we also have somebody called our PCL, our patient care liaison, I'll talk about in a second. That is everybody our patients and families will see at our visits. Our multidisciplinary comprehensive stroke visits are about 2.5 hours long. So they see everybody for a very robust visit. And then they leave with a coordinated diagnostic plan and follow-up. So we're not making them come in for 4 different visits. They are educated by our stroke nurse at the end of the visit, who hands them their AVS and says, here's all your orders. Here's when we're going to see you again. We've already scheduled your appointments. These are the referrals. We've scheduled your appointment with those referrals. So we really wanted it to be comprehensive. We reviewed volumes and financials. I'll talk about key stakeholders. We came up with criteria for the clinic visit. What type of patient do we want to see? Very critical. Otherwise, you're going to have everything under the sun and moon in your clinic. And you're like, why is this patient here? This patient is not appropriate. These are 2.5-hour long visits. A lot of scheduling goes into it. Space allocation. Looking at your EMR and clinic templates is something important. Billing, marketing, and evaluation and growth, as I said. So by volumes and financials, so is there a volume need? You have to ask this question if the answer is yes. We knew that we had, as I said, our hub and spoke model. We knew we had lots of patients that were not being seen as they transitioned out. Costs involved were very minimal. And what's minimal? Well, we were taking our stroke nurse out of potentially other clinic space. We were using an MA, we're using our PSRs. A positive return? Yeah, definitely. We had multiple providers visiting at earlier time points and committed visits with each of these providers through an entire first year. That did not exist. That was not billing opportunity that ever was had previously in this clinic space. So these were all positive returns for us. And then we had a lot of downstream revenue, which is a lot harder to capture. But when you start to think about our referrals to cardiology, hematology, all of our diagnostics, there's a lot of downstream revenue that comes into play. So our key stakeholders, I'm not really going to go into this because I want to get to some of the other information here. Just know there's a lot. Everything from informatics to our clinic unit managers to our rehab teams and our acute rehab space, stroke program leaders, our service line and medical group leaders, and we included pop health. We have our pop health nurses that do make some of these calls. We wanted them to know we are seeing these patients in our clinic. Who are our high acuity nurses? So we started to work with them. And one of the ways that we work with them is in our multidisciplinary rounds, which we have every Monday, Wednesday, Friday in our comprehensive stroke centers. So this was our clinic design. We went through many iterations of what it should look like through brainstorming, feedback, design of the clinic. We determined the type of patient that we wanted to see, what is going to be the provider availability, who, how many days, times available. We discussed and decided on outcome measures. So what's our current state? Do we have benchmarks for them? Is our EMR capable of extracting the data? Do we have a space to document it or not? Are we manually taking this out? What's the design of workflow? The discharge from the comprehensive stroke center into the clinic. So we needed a pathway to identify the patients and then to schedule them. So patient criteria for clinic appointment. So we see ischemics, intracranial, subarachs, TIAs, hospital follow-up patients. So these are like all the patients we can see. Who did we exclude? We excluded new patient consults. One, because we didn't have the room. We knew we were going to get a lot of that, and we wanted to prioritize our patients who were in the hospital. We wanted to start there. We also excluded patients that were post procedure, and mostly what that means is our ruptured subarachs that had either a clip or an aneurysm coiling. They first followed up in the neurosurgery clinic, and then that pathway started. Then they got back right into our comprehensive stroke clinic. The only kind of exception to that rule is our carotid stents that were symptomatic. All of those came into our comprehensive stroke clinic. We see them at 2 weeks discharge, 30 days, 90 days, 6 months, and then 12 months. And if they're good to go, we discharge them at that point from our clinic back out to their internal medicine docs or their GPs. One of the things that I wanted to stress here is who do the patients see? So as I said, when the patients come into this clinic appointment, they're seeing all these people, but one of the required elements is they must have to see at least 2 of the providers within this space. So we don't want them to come into this clinic if they only have to see me in neurosurgery. Then they should come see me in my clinic, and we don't want to take up space here. Our clinic became really busy really fast. So we had to kind of start to pick and choose, but we felt as though as a multidisciplinary stroke clinic, we really wanted it to be multidisciplinary. If you had to just see the neurologist or you just had physiatry therapy needs, we wanted to hook you up into rehab or get you out to that stroke neurology clinic. So you had to see at least 2 of the 3. So how are the patients identified? Well, as I said, we have multidisciplinary rounds every Monday, Wednesday, Friday. So these are providers, our stroke coordinators, our case managers, our PCL, who's our patient care liaison. Love her. I submitted a grant for 2 years for her. Basically got a $50,000 grant that said, hey, I want to try this person called the patient care liaison. All she does is follow our stroke patients, makes them happy, tells all of us clinicians what we're not doing well. She has a terrible job, because she has to, we all think we're doing a great job. And she's like, yeah, your patient family's not so happy today. And I'm like, really? Like, I just spent 30 minutes with them. What did I not say that's right? You know, so I often would tell providers when they'd say, hey, Doreen was in here telling me this. And I'm like, don't shoot the messenger. Her job is to tell us what we can do better. And her job is to make sure patients and families are happy and they're getting transitioned and back into our clinics. She's awesome. It turned into a full-time position after 2 years of grant funding. Highly recommend it. I have the JD if anybody wants it and you want to submit for your own grant. We couldn't live without her now. Our acute rehab unit, we go out to them because we want to identify, hey, do you guys have patients there that we missed in the hospital setting that is now appropriate for comprehensive? Our PCL provides flyers and information to all of our families. And then our PCL and our clinic scheduler meet and come together and say, this patient, this patient, this patient, this patient is all on our list. And they schedule and they put them on the CSC clinic schedule before that patient gets discharged. So every patient family knows when their appointment is, when they're leaving. So this is just a little bit, I'm going to skip over this, our PCL and clinic navigators. As I said, could not work without her anymore. She's truly instrumental to our team. I can't tell you how many letters have been written about Doreen and how wonderful she is in making sure that they're cared for in the transitional space. I think we're going to see more, whether you call them a PCL, you call them a clinical navigator, whatever the role. She's a speech therapist by background. And she's wonderful. But I think, you know, you could have a social worker, you could have a physical therapist, you could have a nurse. Really, many people could live in this role, but I think it's really critical. And some of the studies that were reviewed by Bamey and the group actually found that these transitional care navigators were really instrumental in making a big difference in how we move patients back out to home. So clinic space is like gold. What department's going to host? I don't know. It's like clinic space is like pillows, you know, if you can find one, like, don't let it go, you know, just keep your pillow, keep your clinic space. I don't know. Maybe that's not the case anymore. When I was critical care nurse, it was always pillows. We could never find them anywhere. So who pays for staff and lights and supplies? Who's responsible to schedule? All of this has to be worked out if you're going to launch a clinic like this. They seem like mundane, like, yeah, of course, this is the obvious. It's not the obvious. And trust me when I say you got to get to the nitty-gritty detail of all of these components when you're going to build this out. EMR and billing considerations. Okay, all I'm going to say about this is, who knew that closing an encounter and signing a note could be so difficult? Well, we learned the hard way. Really difficult when you're in a multidisciplinary clinic. You have, what does that mean? It means we have one encounter built, and you have multiple providers that are writing notes within that one encounter. So everybody's billing their own time, which is great, but one of the providers needs to be dedicated to sign the note and close it. Otherwise, all the billing charges don't go through. So just a nuance to Epic, to the electronic medical record, to understanding there are some nuances when you build out non-traditional clinics, and understanding how you need to make sure your billing charges are captured, re-educating your providers a bit on what they need to know to make sure their time is recognized and their bills are being put through. And then making sure that that you're on track with provider level of service, the appropriateness of that visit. Marketing, not going to say much about this. We market the heck out of this as much as we can. But as I said, we've been really full with our hospital discharge patients. We're just starting to expand in thinking about new consults. So the multidisciplinary evaluation and growth, when we talked about how do we want to evaluate, and we wanted to look at measures of success of the metrics. So we wanted to look at compliance. What is our volume of no-shows? That became really important to us. As I said, we discharge all of our patients with an appointment. So we wanted to see, why are you not coming if we're giving you the appointment? What are the barriers that you're having to that? We're looking at our readmissions of these patients, and specifically what we were really trying to capture initially, and to this day we're trying to capture, is who's getting readmitted if you see us. If you don't see us, we're trying to compare that. If you don't come see us in comprehensive stroke, are you more likely to be readmitted versus those that do see us in our clinic? So we really want to have, it's a little bit of a control group. We don't have any data on it yet, but we are collecting it. Modified Rankins at 90 days, patient satisfaction, which is a very indirect measure. As you know, it's like, you know, pulling from the sky, trying to figure out, are they satisfied with us, or is it just the food, or was it the noise, or the, you know, the parking garage ramp or something? You know, there's all sorts of comments when you start to look at patient satisfaction. It's really hard to tweak out what they liked or didn't like, and if they're really satisfied with your care. And then we had this phased launch approach. So first, phase one was really this half day, hospital follow-up. Let's do a half day. Let's see how full we get. How are we going to structure, redesign, reevaluate, get some of our numbers? Then we went into this phase two. So we checked that box. Now we're into phase two, full day, hospital follow-up only. And we are now finally at a full day, and we are full. And you're going to see our numbers really jumped when we went to a full day. Then we're looking at phase three, which will be a full day plus a second day is able, and we're going to add in our new consults. So we're just starting to think about bringing in these new consults, expanding our marketing piece. Like, how are we going to do that a little bit better? Who will those patients be? Will we put them in a separate clinic or add them into our hospital follow-up days? So all these questions kind of come into play as we start to think about launching into phase three. So as we look at our stroke clinic, this multidisciplinary stroke clinic out of our comprehensive center, you can see here in 2021, we actually launched this at the end of, well, it actually did launch at the end of 2020, or I'm sorry, in the end of 2019 and 2020, which of course we were in the middle of COVID. Who doesn't want to launch a new idea in clinic in the middle of COVID? As Denise said, it really just creates a whole lot of fun conflicts in life. So we kind of took those numbers out. They were really skewed because sometimes you're going, sometimes you weren't. We were on remote and then we weren't. It was just a very difficult time and really not suggestive of, it was real life, very real for all of us, but wasn't real life when we really want to compare data. So we've taken it out. 2021, you can see our numbers, total patients, and then it's like a total provider visit, keeping in mind that each of our patients is seeing multiple providers. So you can see in 2023, and my clock is blocking this, but I can't see the numbers, but I think we're up to like 650 total patients and over 1,400 encounters with our providers. So we have had this massive jump in 2023 after we've launched into a full day clinic. So I'm super proud of that, which means we are seeing we're not only seeing our initial hospital follow-ups, but that means our patients are being compliant and staying with us in that 90-day, that 6-month, and that 12-month follow-up period. They are coming back to us. They like what we're doing, and we are able to still be helping these patients and their families in this space. When we look at our modified Rankin, we've actually done a great job. In 2022, we were still at about a 45% in this. And when we look at 2023, we're right around that same area. So we're, helping our patients to having some meaningful recovery. Now, this isn't all comers just because couldn't capture some of the data. Again, when we start to look in the transitional space, some of this modified Rankin just gets a little bit lost, and you have some outliers. But overall, we are really doing a great job kind of shifting these bars in the right direction, and that we can see our modified Rankin is moving in the direction we want at 90 days. Our measure of success, looking at our 90-day outcome, is trending correctly. Now, I will say, I thought I was giving a 60-minute talk, and it turned into I learned last minute, a 30-minute talk. So I took out some slides. So I will just tell you, I didn't put in here our readmission rates and our compliance rate. We have had about a less than like 6% readmission rate. So we are right where we want to be. It's actually quite low compared to national benchmarks. And when you look at traditional follow-up care, less than 6% of any patient that sees us in our stroke clinic is being readmitted after they see us. So I'm feeling pretty good about that overall. We have some really sick, complex patients, and we feel as though we've captured that pretty well. our compliance rate is at 94%. We have a huge compliance rate of our patients, and that is really only in our hospital follow-up. We're not looking at all the others. We're only looking at that initial discharge to follow-up visit. We have a huge, huge compliance rate. Super proud of that. Again, that goes back to the credit of our PCL and our clinic schedulers to make sure these patients are getting identified and they are getting into our clinics. If they see that they cancel, they need to be rescheduled, they're like on it. They're like, oh no, we're calling them. You're coming back. We're getting you. You're allowed to cancel and reschedule. We're still going to count you because we know things come up, but that compliance rate is huge. So super proud of that. All right, so that's our multidisciplinary stroke clinic. I have just a couple minutes left, and I'm just going to spend it talking about what the talk actually said I was talking about, and that's our APN stroke clinic. But I just want to say that the rationale, really how we went about this, the multidisciplinary stroke clinic like laid the foundation for this for me. So as an APN, I always want to listen to other advanced practice nurses, to physician's assistants to understand how do we help everybody to work to top a license? What's going to make you happy in your job role? And how can I help you with that? So rationale, why do we want this? Well, there was no stroke clinic established in this community where one of my APNs was working. No stroke clinic, like not even a neurology stroke clinic in this like far, like southwest suburb of Chicago. She works at a busy primary stroke center, so over 250 primary coded strokes being discharged from her hospital with nowhere to go, no neurologist willing to open access to their clinic. They did have general neurology that was seeing patients out there. They didn't want to see stroke patients. They didn't want to expand their clinics, so we had very poor access, no budget for additional FTE. And I had an APN stroke coordinator that was like, you know, I'm half-time as a stroke coordinator. I really love to see patients. I want to see patients. And I was like, let's make it happen. How can we help you to see patients? What are we going to do? Let's build you a stroke clinic. Let's find a partner, a collaborating physician. Let's make it happen. So we had this huge gap. So our solution was an APN-driven stroke clinic. We're going to put it in a 6-month pilot. So pilot launch, how do we get ready? Well, we modeled this after our multidisciplinary clinic, but we scaled it down, some nuances. So we had to really consider hospital-based clinic versus ambulatory. So who's doing our calls, who's going to be our medical assistant, triage, billing considerations, all those things. And then moving an APP from a hospital-based stroke coordinator to a medical group APN with a split FTE. Well, that's like jumping through 5,000 hoops, but we got it done. I'm really glad that I could pull her over into our medical group because she gets more benefits. She gets a little bit more support. But right now she's working as a 0.1 FTE medical group APN in my stroke clinic. And she's a 0.9 stroke coordinator over in the hospital. We had an SBAR that communicated out to hospital leaders. We designed our clinic, half-day weekly clinic, 60-minute templates, ischemic stroke patients discharged to home health, acute inpatient rehab, no subarachs, some intracranial hemorrhages, follow up at 2 weeks, 90 days, 6 months, 12 months. We created a service to order in Epic, which meant she saw all these patients in the hospital as well as the hospitalist team. We educated them, created a service to order in Epic that says service to APN stroke clinic. And you could put her name in, and those patients went to a queue that then her scheduler in the hospital-based clinic could see it and schedule those clinic patients for her. She doesn't have a PCL down by her, so we had to find a mechanism to capture these patients. We had weekly clinical meetings that we established with her collaborating physician, who is remote as our medical director, but she has regular meetings where she has case discussions. She reviews her cases and imaging weekly, and a referral pathway back to vascular neurology clinic was established for really complex patients where she could say, hey, this patient needs some more care. I'm going to get them back to the vascular neurology over at our comprehensive stroke clinic. So the APN clinic launched December of 2023, volume of 55 patients so far, readmissions 0 of our patients seen since December. No show rate, a little bit higher than we want, 29%, but we're going to get there. Again, she doesn't have a PCL. Billing level, so we went from 0 billing. So what's our return? Our return is this right now. So we went from 0 to, you know, I don't know what that number is yet because they haven't given me financials. But when you go from nothing to something, well, we've got a return. That's all I know is I'm in the green and I'm positive, and that's all I need to tell administrators. Other considerations, downstream revenue, specialty referrals. We 51 specialty referrals. Hard to really document or to put financials around that. But what does that mean? You know, when we refer out to cardiologists, hematologists, ENT, therapy groups, that's big. And 18 recaptured a neurology clinic at CSE. So I'm just going to say this. What is another kind of barrier sometimes? And again, to our neurology folks in the room, we're not trying to take your business. This is a collaborative effort where we are actually going to give you more business back. We really are. These are patients that were not seen. You were never seeing them. They were never going to come to see you, but now they are. They're going to come and see our neurologists in their clinic. So we have to collaborate because now we identify these patients who are never going to be in our clinic space for any assistance, and now they're coming back to us. Diagnostic downstream revenue, and then these patients are returning to her. So these are some of the barriers, and I swear I'm done in 30 seconds. Coordination and availability of provider time. We settled on a half day. It was a slow expansion to full days. We wanted to include our physical therapy teams in the front end. We thought it was a great idea, and I still think it's a great idea, but very difficult because they need referrals in kind of that space can be very difficult. Transportation difficulties for transferred patients. So when you have a hub and spoke model and you're trying to bring them all the way into your multidisciplinary clinics like this, we found that to be a big issue. So we still kind of work through that. Our PCL helps. Insurance and out of network patients can be difficult, but we're committed to seeing all of them at least once in follow-up for free. We do not want to take care of them in our hospitals and not be able to see them in follow-up and help them out. And then AVS issues. So Epic is, again, a whole nother talk. Opportunities are here, expansion of clinic, cardiology partnership. Our cardiologists are coming into our clinics starting next month. So we're super excited about that, is that we're going to have another provider where we will have, our patients will have access to our cardiology partners, tracking data, social work, and then development of an ambulatory navigator in Epic for a discrete field so we can build this out and actually capture transitional care data. So that is it. I thank you guys very much, and I'm sorry that I've gone over.
Awesome. Thank you, Kiffin. Topic near and dear to my heart. So any questions from the audience? Going once, going twice. Okay. Well, good news. It's break time. So there are snacks in the vendor room. So make sure you guys take your cards, talk to the vendors. I think we're done. Is it 15 minutes? We have 15 minutes. So or 30. It's 30. Sorry. 30 minutes, you guys. 30 minutes. We'll see you back in here at 10:30.
I was wondering, baby, will I make you my baby? We don't care, baby. We make us so crazy. You ask me, I'm ready. If you ask me, I'm ready. I'm ready. I'm ready. I'm ready. I'm ready. Already know I'm going to dinner that you left your body in the way I do. Because you told me with the confidential, but do you let anyone inside your mental? But you ain't told them the things that we've been through. I know you're not flashing your moves like you've been through. The fact that I actually started to trust you, then you broke my heart. Someone bring me to you. Be my notebook, I sharpen my pencil, I write you a letter. Show you something when you stood out forever. Even if it's tragic, go ahead, sign your name on the package. I sincere. Pick it up on me. Reason I hope you believe in that another guy. Can I move forward and have your relationship? I get in on it the same if it ain't you. To fall in love with 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 you. Never thought before that I brought you. Look back at the vacation I brought you on. And even magic, it's not in my bracket. You settle for less, but I'm not me. I put you on. Doesn't look good on you. Way too appealing. And go through experiences that he's given. Stay on this side, looking with fire. The bottles are roses like up to the ceiling. Without you, I know that I'm healing. But that doesn't change that the way I've been feeling. I don't know, judgment, I look like there's nothing to me. I'm sure I'm what you've been feeling. Better than that, it's like a joke. It's been no, I if we spoke. Can't help but think that my life would be better if we never met, but it's not how it goes. And in the words you speak when the west wind whispers, I can hear your voice ring clear in the evergreens. I'm all you thought I'd be, am I what you pictured? Did you understand it here in your wildest dreams? Oh, 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 oh. You never let me. You just left too soon. I'll save you a seat next to me. Always at the table. Hope you're proud of what you see. Watching with the angels. You're written in my soul. It's your blood that I bleed. Wherever you are, wherever I'll be, I'll save you a seat. Hear you in the rain that falls, or I still get shivers. Running like a family car down a perfect day. Did you find mom up there? Tell me, are you with her? I wonder if the ones who go miss the ones who stay. Oh, oh, oh. Just left too soon. I'll save you a seat next to me. Always at the table. Hope you're proud of what you see. Watching with the angels. You're written in my soul. It's your blood that I bleed. Wherever you are, wherever I'll be, I'll save you a seat. Keep your breath and change. Try to love, but it's not the same. You go, couldn't stay. So I'll save you a seat next to me. You're always at the table. Hope you're proud of what you see. Watching with the angel. Call me pretty little thing. And why not time alone? Why not be my routing? So you can look at us all day long. Ain't a sexy little thing. Snap it to bring it on. Oh, you wish you ever need routing. When it's popping out your phone. Run it down to the wall. Baby, you play too much. I'm just super shot. Looking super hot. I'm a fucking animal. I'm a fucking cynical. Go to just not be my dime. It's just too much with fun. Say, can you get that phone? You told me I'm wrong. She be I'm be money when I told you baby, must stop time I see you, I just wanna grab you. And I let you touch it, and you can't let it know. So let you take care of it all. Every hour, the hour, is the way to go. Pretty little thing. Why not to turn on? Why not to be my diva? She's so simple, but that is all they are. Me sexy day. Snap a picture, bring it on. Girl, I wish I wasn't leaving. She's popping on my phone. Oh, I love you down to the bone. Baby, you know I'm on my bullshit. I let you cry. Brody, don't in your room. That shit breaks my perfect time. You only tease me, so you don't need to sound. And then on hydroplane, baby girl, you the pilot. And I'm the slide, somebody. Someone slide. You never tell me baby, let's take one dinner, yeah, you have that in a simple like me. Yeah, it's my day. My sister on still asleep. I got shining through the in between. I got settled his leather seats. It'll take. Girl, I wanna take it all. You know I got to be a leader. So I can look at it all day long. Sexy things. Snap bring it on. Girl, I wish I was a leader. Popping on my phone. down to the floor. You But I never felt the separation for pain, drive me insane. That trust is on your ways, baby, you're shame, should be in the pain. I fantasize every time that you speak, coming alive when you're touching on me. Wish you could stay when you're right here and leave. Sometimes I just want to slow down time while you're looking in my eyes. How you hear me slow down? Ain't that a feeling I'm strong? You got everything in mind. I'm so fucking lucky that you're mine. You're mine. And I know that I say it all the time. Didn't know what jealous was, now I'm the jealous type. Didn't know the grass was greener on the other side. Ever since you're mine, I fantasize every time that you speak. Coming alive when you're touching on me. Wish you could stay with me right here and leave. Sometimes I just wanna slow down time while you're looking in my eyes. How you get me so down? Ain't that a feeling I know? You got everything and more. I'm so fucking lucky that you're mine. One teardrop from my eye. Say before the middle of the night, when things are going right, and you would all remember my story. I see you. It's only starting now, and you're just finding out. Happiness and life. We made this sacrifice. We do this stuff with a kind. This must be not be fine. Hours in you. and you take them. Even I'm shit, I see it. And now
All right, everybody. Welcome back. Sam, all the way from Mexico. I'm at double A. Everybody register. We have a great local. I met Sam at the AA meeting a couple of years ago. So he's going to talk to us today about right hemisphere. Excited to have Sam back, and I'm going to.
Okay. What? Yep, I got all the stuff. I think. Hi, I'm a nurse educator at University of Hospital. Now, I'm glad to be here. It's really, really nice and be around a bunch of neuro nerds. And I am a big fan of the AANN, you know, the conferences, presenting, getting together like this and sharing all the stuff. I always learn something from my esteemed co-presenters. What I'm going to talk about today is right hemisphere damage. I have a very, very strong passion for language and communication in the brain. I'm finishing my PhD in linguistics right now. And my master's degree is in linguistics. But I also love the brain. So I'm kind of a linguist disguised as a nurse. But let's see if I can figure this out. This is what I do. I don't have any relevant relationships, any commercial interests. Sometimes I wish I did, maybe. So what we're going to talk about is we're going to talk about the vessels that are most commonly involved in right hemisphere damage. We're going to talk about the domains, general domains of function. There's only so much we can talk about in 30 minutes. And then we'll kind of talk about monitoring and assessment. Can't stress enough, it was great hearing Kiffin's talk about a multidisciplinary clinic. It's really, really important for nurses to develop skills in monitoring and assessing these unusual things. And right hemisphere damage, how many people have noticed that right hemisphere damage patients, they're different, right? It's not like a frontal head injury. There's something wrong and you can't quite put your finger on it and they seem like they're okay. They statistically get discharged earlier than other patients because it's like, no, I think he's good. Yeah, it's good. So we'll talk about it. Quick review, all the things that we know there on the left, the typical deficits we see with a stroke, particularly left-sided. The majority of the population for the purposes of today's discussion are most people. 90% of some right-handed people have language centers over here. So the tricky part that we're going to talk about is what's the other communication functions of the brain besides language? So these things that I've highlighted here as far as the right hemisphere, communication disorders that are related to perception and cognition, not so much expressive or receptive aphasia, and all the things that go with difficulties with perception, right? All of the things that go, and with movement and memory problems, and we'll do a little quick review of the vessels involved. Some stats as far as, we know that there's these general left brain, right brain things. And then there's forget about the pop psychology thing of like, are you left brained or right brained? It's not, we're talking about actual neuroanatomy today. So quick 30 seconds to refresh your memory, all the different places that things can go wrong as far as vasculature goes and vision. Obviously if we have a problem at one there, you're going to have total blindness. It's when we start talking about getting back into that posterior region, 6 and 7, when we have quadritanopia and hemanopia, right? And if the blood supply is cut off there, the blood supply is cut off to other perceptual things as well. What are the challenges to safety? We have, if you're familiar with the term lateral pulsion, there's an effort to try to standardize that terminology. Lateral pulsion is pusher syndrome, if anybody's heard that term. People push towards the affected side. We have cognitive communication, pragmatic. When I say pragmatics, that's the most abstract part of the study of language is pragmatics. Things like maybe people with right hemisphere damage don't understand when I go like this. What does that mean? Says a lot, yeah, right? But if somebody's like, what's wrong with their shoulders? If you don't perceive gestural things. Neglect, which egocentric and allocentric. One is the neglect of the entire visual field. That's egocentric. Allocentric is when you're actually looking at an object and you can't see the left side of it, right? The difference there. Agnosia, I'll give you some examples. Impaired midline is a huge thing, right? I was kind of appreciating impaired midline sitting over there because my attention was focused on the stage, but I'm like this. So I felt a little bit like, I was like, oh, this must be what neglect is like, right? Because I'm sitting over there and having to turn all the way this way to have Kiffin in my midline, right? But when we talk about subjective midline, we talk about, our midline right now, as I face you, my midline should be here. But if my midline's over here, you know, and more challenging on top of that is the fact that I don't know that there's something wrong with that. So you asked me, are you having any visual thing? No, everything looks good to me, you know. So all this stuff goes together, and all these things are related to safety in this weird floral Venn diagram that I have here. And the lack of insight, right? I think we're all aware once you only need to take care of a right hemisphere damaged patient once to understand lack of insight. This is an example of something that's a very short clip to give you the lead up to this. He's been trying for 15 minutes to describe what this thing is that she's showing him. I don't have clearance to use some more current videos, so I apologize for the quality of this video.
Let me give you a hint.
Okay.
I'm going to give you a choice and you tell me what this is.
Okay, I can tell you then.
Okay. Is this a clock, a lock, or a telephone?
A lock,
Is it a lock?
a clock, a lock, or a telephone? Okay, let's rule out a telephone. What, a clock or a lock? Gotta be a lock. Must be a lock then.
Are you sure?
No, I'm not, but I don't recognize it as a telephone.
Mm-hmm. Do you recognize it as a lock?
No, honestly, I don't. But it's just, it really looks very indescript to me.
Uh-huh.
Watch his hands.
But your hands know what they want to do.
I know, and they want to do something.
That's right.
So I can see them.
Uh-huh.
Yeah, I can just picture them, and I know that I have. It's like I'm undoing a combination lock.
Good.
Huh.
Okay, good. We had to work on that one, didn't we?
No shit.
That's okay.
Right? So that gives you a sense of how complicated recognizing objects is, right? His hands are, he's just like, I'm doing a combination lock, right? This next one, you know, how would you describe that other than confused? But one of my pet peeves is using the word confused, because what do you mean confused? Disoriented to time? Unable to recognize objects? Or is he really confused? You know, what's another word that somebody would use? Anybody? Yeah, something. This is sort of classic object agnosia. Is this my real time on here? Or is it? Okay. I'm going to skip over this next one because it goes, I'll just show you the beginning of it. And I want you to think about patient at the bedside.
In this short film, we look at the perceptual problem of agnosia.
Plus, I love the Scottish accent.
Agnosia is the loss of ability to recognize objects, people, sounds, shapes, or smells, even though the specific sense is normal and there is no memory loss. Here we see there are many objects around the sink. Greg has to be able to recognize each one and how it is used. For a person with agnosia, this task can be very difficult. Notice how Greg not only looks at the toothpaste, he also feels the tube in his hand.
So I'll stop there. Try not to be distracted by this photo. If you imagine Greg's view of the sink, it might look something like this, right? And you start looking at it, you're like, no, I know what that is. It's a teddy bear. Is that it? Is that earrings? You know. So thinking about what clutter, the effect of the clutter, just having stuff in front of you, and this guy basically has to go through and put, you know, he's only got the use of his right arm. He has to put toothpaste on the sink and then wipe it up with the toothbrush and then use it. But he has to pick up the comb. And he has to like look at the toothpaste, and he has to look. So thinking about the clutter in the area, these little things that just go right past you, right? Or if somebody didn't pass on and report, I remember as a new nurse, somebody didn't pass on that there was actually, they said, it's the right-sided stroke. But that was all I got. And had been a nurse like a year, and I didn't know, he's not really eating. Well, the tray was on the left side, right? They don't even perceive of the tray. And in this case, I don't know, can anybody name anything in this photo? Anything kind of look familiar though? You look at it, you're like, is that a teddy? I don't know. Yeah, it does look like, it looks like the way that people display jewelry at a pop-up at a store, you know, at the whatever, you know, at a outdoor market or something. Right? How about this? Part of it kind of looked like the inside of an ambulance for a minute for me. Right? It starts to be, this is like cool things that I like that AI can do. Because I wonder, what does it look like to have agnosia, right? You know, because they look fine and they may not know that they can't recognize things. And you ask them and they verbally tell you, nope, I'm good to go. Everything's fine. In this case, we have lots of different kinds of agnosia, right? That tends to be what we think of with right hemisphere damage. We tend to think of, you know, inability to name objects, like this dude with the combination lock, right? Instead of phone, instead of clock, instead of, you know, that video actually goes on for like 20 minutes until he's finally like, and he figures it out, right? How many people have had the experience of a patient freaking out on their own heretic limb when it comes into view? You want to set them up nicely and you put their limb on their chest and then they look down and they freak out because they want to know who's in bed with them, right? It's like, no, that's your hand. No, it isn't. Yeah, it is. So it seems like confusion, but it's not confusion. It's an inability to recognize stuff, which could be confusing, but it's not the same thing as a frontal head injury where somebody's combative and delirious and hallucinating and inappropriate. There might be some impulsivity there, but this is our whole list. In the interest of time, I'm gonna keep moving. So quick 5-minute vasculature review. If we're gonna think about regions, okay? I love this stuff. Any of you are educators, I strongly recommend the University of British Columbia open source anatomy videos and images and scans. This is a rough estimate of vessels where, as if we're comparing MCA, ACA, and PCA, hemispheric strokes, right, versus greater than one territory, brainstem, lacunar. Look at how much. Now, I don't know why Excel is Excel, whatever. I typed it, it's actually 51%, but it keeps coming up 53, whatever. But at least gives you a broad thumbnail sketch, right? In this particular research article, the disparity of deficits and predictor, this is a better predictor of outcomes than location, right? But that's not actually true, because if your tools are not assessing correctly, like the NIH stroke scale does not, you know, the NIH stroke scale is biased, first of all, towards what? What is it biased? Anterior circulation, absolutely. And with that, and it's also biased towards left anterior circulation. And that's just a historical nature of a scale being developed at the same time that we're developing TPA, right? So it's kind of natural. That's what the tool was used for, but it's not an appropriate tool, right? What are we talking about here? We're talking about, oh, it's not rotating. Oh, there it is. What's this? It's the PCA. Okay. What happens when we have problems with PCA territory? Homogeneous hemianopia, some memory deficits. If you think about where it perfuses, part of the temporal lobe, but also occipital, there's, depending on where that occlusion is, you're going to have a mixture of these things. You might have, if it's towards that central area and it's affecting the thalamus, you're going to have all these things listed here. You know, postural tremors, my ability to carry a tray of coffee here, holding myself in space might lead to, right? Might lead to tremors. These optic radiations, oh, that's not going to work. That's all right. That's fine. The cool rotations is also from UBC. Honestly, it's great. If you're going to be precepting, if you're going to talk to somebody, there's a lot of great images, 3-dimensional images from University of British Columbia. They are open source because now everybody's cracking down on where did you source your images from, right? And also just finding good material to teach with, whether you're precepting or you're teaching in a classroom setting like I do. What do we got here? ACA. Just looking at this, thinking about all that frontal stuff that goes with that, as well as the space between. And when you think about the motor strip, what is this supplied with the motor strip? What's in that area? Foot and leg, lower extremity. No facial droop, no aphasia, no upper extremity weakness, right? Saw a great presentation by Dai Olson. He did a thing called Unusual Strokes and Unusual Folks, and he used all cartoon characters. So he'd give you the H and P, and you'd get, You know, this is a 25-year-old female who lives with 9 other men. She denies use of birth control. She, you know, fell into a state of minimal consciousness after eating an apple laced with street drugs. And then you realize, Snow White, you know, Popeye had verbal apraxia. It was great. Well, the example that we had for ACA was Rafiki. He's got some lower extremity weakness, and he's also got that frontal stuff because it's like flight of ideas. He's a little bit manic. He's a little bit, you know, inappropriate, hitting people on the head. So he's got that frontal presentation with lower extremity weakness. I don't know if he's incontinent. We'll just let that be. It's a cartoon. We'll keep it wholesome. But no aphasia, no, you know, so again, you think about what's in between here, what's in between these hemispheres. Rafiki's, I permanently think of him when I think of ACA strokes. Very small percentage of strokes. Of course, what do we have? The MCA, that's our bread and butter, right? That's the most common as far as cardiogenic, and I'll spare you the Jeopardy theme. So the obvious things of, you know, the FAST exam before we added B to it. And of course, statistically, left hemisphere, left MCAs are a little bit more common just because of that architecture. If the heart throws a clot, cardiogenic embolic strokes are going to go and land. It's bound to land up in the MCA statistically if the heart throws a clot upstairs, right? So these videos didn't work, but an example of aprosodia. This is just something I'm going to put out there because I love talking about language and communication. Is our speech therapist here that's presenting later this afternoon? Because I'm going to find you and I'm going to talk to you, whether you like it or not. So what's the difference when you say you asked Sam to talk, right? Versus you asked Sam to talk versus you asked Sam to talk? All of those things are different, right? That's an example. Prosody is the pragmatic element of conveying information, right? It's not the literal meaning. All these literal words are the same. But if you tell a metaphorical joke or something, sarcasm, how are you doing today? Oh, great. That might not be picked up on by somebody with right hemisphere damage. Now, a little bit nicer to know, you know, my boss likes us to just teach need to know, but I got to sprinkle a little nice to know in there because it might help the need to know stick, right? But, you know, when you're teaching a long class, you got to sprinkle some other fun stuff in there, right? In this case, this is from 2021, I believe. They found that people with right hemisphere damage don't know that they don't know information, so they don't ask questions. They don't ask questions for clarification. What does that mean for patient teaching? What does that mean for, you know, Kiffin's clinic when you're talking to a patient with right hemisphere damage and they're like, do you understand? Yeah. And you don't use teach back. You're in a hurry. So you don't like, tell me what you understand from that. You know, you're in a hurry. I get it. We don't always get to use teach back, and just in informal conversation with patients, right? This is something that's kind of interesting. This really deeply impacts how a patient responds to plan of care, understanding instructions, understanding what the medication is for, why it's important to take your, you know, whatever medication, your blood pressure medication, your statin, whatever you get discharged with, right? So overall, the thing is right hemisphere damage patients lack insight, and they can't trust their perceptions, and you can't either. I've got a midline that's over here, right? It's not until PT or OT assesses a patient, because a lot of times the United Stroke Scale will, you know, nurses will score, and it's not because the nurse isn't doing it right. The nurses will score for inattention, or they will not score for inattention. They don't notice it, right? They don't pick up on it. It's not until PT or OT gets in there. It's the same thing with a lot of cognitive stuff that speech picks up on that you may not pick up on right away, because of course, a lot of our patients, especially if they're in, we used to have a multi-bed ward. We had a 6-bed ward. If you ask any patient in that room back in 2007, are you ready to go home? Do you think you feel, oh yeah, yep, right? Because there's a guy with a closed head injury in bed 1. There's an incontinent person over here, you know, somebody else that's screaming and disoriented. They're like, I feel great. I'm, you know, and you don't necessarily pick up on their cognitive deficits. That impaired midline is super, I call that the angle of dangle, where they might come in, you know, you set them up in bed and they're like, oh, thank you. And they're very nice. And then you leave the room And then they're like this, and they're like, I don't know why that nurse keeps putting me at that weird angle, right? So their legs are dangling off the bed, and they're like, this makes way more sense. That's so weird. I don't know why does she keep putting me? This is way better, right? Lateral repulsion. If you see it when they're supine, it's going to be even worse when they're upright, because the perception being upright, your perception of location and space, it's not all just about the cerebellum, right? All of this stuff has to play together. Right hemisphere, like I said, right hemisphere patients get discharged sooner because they seem better a lot of times. And if they don't get the thorough assessment by rehab, they may get discharged sooner because they seem more functional. And you ask them, are you ready to go? Yeah, sure. We already talked about them not answering questions. Challenges with neglect, being able to, if the patient's capable of attending to both sides simultaneously, then you can start measuring neglect. Right. And a lot of times you got to have them close their eyes, right? That's the main thing. That's like nursing school 101, neuronursing 101, having them close their eyes, because we all cheat, right? If you're starting to feel a little weak on one side, even with a MCA, left MCA, start like, oh, I'm gonna hold that arm up a little bit better. So sometimes neglect and visual impairment can get mixed. I know I'm blazing through a lot of information. I'm watching my countdown, and the bomb's going to go off when it gets to 0. You can't necessarily, if they don't have sensation on both sides to some degree, you can't be sure that it's neglect. If they can't feel, it doesn't mean that it's neglect, right? If they can feel, but they can't put it together, right? When you assess your patient, which side am I touching you on? And they're like, right, left, right, right. What else do I want to say about this? So this is for the language section, right? This is for spontaneous speech, but we as nurses like to, rig things to work in other ways. Like, what else can I determine from asking you certain questions? Having you look at a picture. If you don't mention the kids, the cookie jar, the ladder, that might be giving you an indication that something's going on. If they start talking about other things, like the ATF coming up in the yard, then you got other things going on, right? They don't mention, or they do mention, that the little girl's about to take a bong rip, and the other kid is just suspended in midair, right? So from a rehab plan of care perspective, we have, see, the bomb went off. This is something that you might want to take a picture of. I'm guilty of taking pictures of. I'm happy to send my slides out. The main thing is this lack of insight. Patients will fool you. They seem totally fine. They talk to you totally fine. They don't talk to you like a frontal head injury, right? When you're talking about moving their food to where they can pay attention to it, addressing them from the right side, but also trying to get them to go towards midline, getting them to move their midline, right? Another factor in that, which I don't have time to go into, there are prism glasses that if the midline is subjective, they put prism glasses on that start to move the midline, and you'll see that patients will start to, after the glasses come off, they'll have residual effects of being able to point to their midline and accurately move between their midline and actual midline, like between their chest. But I'm happy to send these slides out. I know that was a quick blast. The main thing to remember is that to really effectively take care of a right hemisphere damaged patient, you really need that input from speech, PT, and OT, right? Because they're the ones that are able to catch these deficits that might get missed by the NIH stroke scale, right? It's a great tool for what it is, but it's not the perfect tool all the time, right? There's any tools, whether it's tools used by speech, PT, OT, nursing, whoever, they're designed for something. And when we start using them outside the scope of the tool, that's where it's no longer useful. So the NIH stroke scale is not the best way to catch this phenomenon. Does that make sense? What else do I want to say was about here? I guess that's it as far as I don't want to go too much further over. This is my contact information. I also have a ton of references that I encourage you to look at if you're the kind of nerd like I am that likes to actually read current research and be like, what does speech have to say about this? Right? Because the communication elements that you don't realize there's so much more than the words that I'm saying, right? You all, I'm assuming, can tell when I'm being sarcastic. but a patient may not be able to. Or when we tell jokes, like, hey, non-literal communication. There's so much more to communication beyond that. And that we tend to see that, we think about it with our TDI patients, but not so much with right hemisphere damage patients. Any questions? I know that was a quick 30 minutes of talking. Have you all had experience taking care of right hemisphere patients and you're kind of like, I don't know, there's something kind of off. I will tell you the opener I forgot to start with. The whole reason why I got interested in this is I took care of a patient who unfortunately was quite intoxicated on 5 different things. And he put a gun, he was left-handed. He put a gun to the back of his head. He decided to kill himself by putting a gun to the back of his head like this. And once he came out of that, he survived that. He kind of lost a lot of this, completely left side hemiparetic. Nobody wanted to get him up. And I got him to the bathroom. I put him on the toilet and I was precepting. So instead of a good example, right? Put him on the toilet. I was like, let's see if we need to change his seizure. And he hit the ground, right? Fortunately, he fell towards the side where he had a skull, not where he had the mesh, right? So he did survive. But then I was like, dude, I thought we were cool. What's up? Like you said you wanted to use the restroom. You said you felt steady on your feet. But again, I was a relatively new nurse and I didn't understand that this guy had no idea, even though it took 4 people to get him out of bed. He had no idea, like, yeah, no, I feel good. Yeah, I can walk to the restroom, right? That's that tricky part. And that's where they fall through the cracks. And that's why they're hard to take care of. And then especially in the follow-up, once they get discharged, because they're stable enough, because they're A&O times 4-ish, kind of, sort of technically, depending on how, they can answer the questions that make them A&O times 4, but it doesn't really, they don't, we're not asking for insight. Are you aware of how much help you're going to need? Are you aware of how much it's going to take for you to manage? Do you understand you can't drive, right? Another treatment that they use in addition to the prism glasses in order to get that midline is VR is really good for that. So driving simulators where they'll drive and there's like stop signs on the left side, or other objects on the left side that they have to learn to navigate, which is better to have them do that, in a VR setting than actually get behind the wheel of a car, because nobody's paying attention and nobody took the keys away. Questions about that? Is that helpful to kind of redirect your mind towards thinking about how we take care of these patients and how important it is, the multidisciplinary aspect of PT, OT, and speech, being able to weigh in on how, it takes a village with all of our stroke patients, but particularly right hemisphere, a very particular flavor. Okay. Questions? Thank you.
Thanks, Sam. Great talk. All right. So now I have the honor of introducing Diane McLaughlin, who is a nurse practitioner here at Baptist Health. She's going to talk to us today. She's very involved with Neurocritical Care Society and a lot of other organizations, but she's going to talk to us today about neuroprognostication. This is a really fascinating topic. So I know we're getting close to lunchtime, guys, but hang in there because this is a good one. You don't fall asleep at the wheel on this one.
Because of the lack of questions?
Yeah.
No? Thank you. So I'm just going to keep pressing buttons here until something comes up, which if anybody works with me is pretty much how I operate at night too. So neuroprognostication is kind of a hot topic right now. And that's in any of the critical care societies. And it's because everything that we knew 20 or 30 years ago is different. And I think it's particularly important to talk about in this setting with this group, because I don't know if you saw the ratings that came out about trust. Who always ranks at the top of that? Nurses, you want to know where physicians rank? It's like 20% lower. And also, how much time do you think providers spend at the bedside compared to nursing? So every time there's an eye roll, every time there's somebody saying, oh, this patient's never going to do well, the families listen to that more than us coming in and saying, no, that they might be okay. They might have a decent outcome. So it's super important that you guys buy into this. because you're really the person that they're going to look to and listen to. I mean, I'm just going to keep talking. So one of the other things that I found really interesting when I started looking into this was there's not a lot of data points about how who you are might affect your opinions. And so people that are early in their career are actually more pessimistic. And I thought it would be the opposite. I thought when you're brand new into nursing, you're a brand new physician, that you'll think everyone's going to do well. It's the complete opposite. It's the newest people that think everyone's going to die. And as somebody that's been a nurse forever, I was totally that person. I will also say nurses are more pessimistic than physicians. People that work in the ICU are more pessimistic because you don't see people along a continuum. You only see them when they're critically ill. And I'm sad to say, looking around this room, that women, we are not very optimistic. And we might tell you we're optimistic and then turn around and say, oh, he's never going to leave her, or whatever it might be. And so we have to keep that in mind when we're talking to families. Because whatever you think has a tendency, I mean, this was good. We can do this again too. It should be under Baptist. So whatever where you lean, you can put that onto the patient and the family when it's not appropriate. So you have to be very careful with your words. Who's familiar with the term heuristics? Everybody. Where's our linguist? You're familiar with that, right? Okay. So mental shortcuts, right? So these are mental shortcuts that we take. So let's say that you're working 3 days in a row. The first day, your patient's tachycardic. And so you give them a little dose of pain medication and then they're fine. So the next day you come in, patient's tachycardic. What are you going to do? You're going to give pain medicine again, right? So you've taken a shortcut where you've taken out all of that other thinking that occurs because you think that that's going to be the same outcome every single time. And so when you do this, when you're assessing patients and trying to guess what the future holds for them, it starts to become a self-fulfilling prophecy, which is a huge issue in brain injured patients, especially if you look at the progression over the last 20 years. So even in my career, the way that we take care of stroke patients has drastically changed. These used to be the easiest patients in the whole world to take care of because we didn't have TPA. I know I don't look as old as that, so just bear with me. But literally you admitted them and you turned them every 2 hours. That was all you did. There was nothing else to offer. You might do a decompression if it was really, really bad and they were really, really young. That's about it. Literally you turn these patients. It was super easy. And then TPA came out and then TNK, and more recently in 2015, thrombectomy, and that became widespread. Now everything that we thought we knew about how stroke patients are going to do is completely different. And that's even changed over the last 2 years as all of these anterior large core stroke studies have come out, that any type of prognostic score that we had, you can throw aside because they're all looking at old data and old interventions. So there's nothing out there to predict how these patients are going to do. So literally this whole talk is centered around looking in a crystal ball and guessing at how patients are going to do. And so with ischemic stroke, a lot of these patients do much better than you would anticipate. Are we still working on this or did we just give up? All right. I mean, I told you I'll talk for 30 minutes. So none of those prognostic scores work anymore because everything has changed. And that's absolutely the first question every family member asks. So you have a patient that comes up, they've just received TNK, they've just had thrombectomy, they're still barely moving one side of the body. And you come in and you ask how they're doing, and the very first thing they say is, well, are they going to be able to walk my daughter down the aisle in 3 months? You don't know the answer to that. See, now you can see all my cool AI generated images. All right, we're going to be a little bit far in this. All right. I mean, I'm going to skip some of this because coma is what everybody's going to look like in a little bit here. All right. So we talked a little bit about what heurism is and what that technique is, which is these mental shortcuts that we take. And so if you've taken care of these patients as long as I have, then at the beginning, how they do is completely different than how we take care of them now. So if I still use those mental shortcuts and said everybody that comes in with a left MCA stroke is going to look like this, I would be completely wrong. And you'll see they've actually studied this, and people much smarter than me are way more wrong than me, just putting that out there. And so Neurocritical Care Society over the last 2 years has released a whole series of prognostication guidelines. And you'll see none of it's really that great quality of evidence, because the truth is we don't know the answer to this. And I alluded to this self-fulfilling prophecy. And this is what we're all guilty of. And it's because of heurism, which is that we say somebody that comes in with a large ICH, they're not going to do really well. Well, they're not going to do really well. And so then what do? We start backing off care. We start to give the eye roll to the family. We start to say these patients never do well. And next thing you know, they're withdrawing life support. And then guess what happens? They don't do well, right? It seems really obvious, but we continue to move this forward. And that's the number one reason that stroke patients don't do well is withdrawal of life support. And so that comes back to us. All of these guidelines pretty much say to wait at least 72 hours. And I know in the ICH talk this morning that was alluded to. That's like bare minimum though. If you were to extrapolate some of the data that's come out of the TBI studies, and if you think about TBI, most of these are ICHs. Of course, risk factors hugely different, so you can't really just generalize it. But a lot of these patients that come in as a GCS of 3, a year later are walkie-talkie. So you don't really know how these patients are going to do, and there's not a lot of good studies longitudinally to say that. So don't take mental shortcuts and then give it some time. Confounders, if your patient, now I say the brain is a barometer of critical illness. And what that means is anytime there's any other insult, then the first thing that happens, all of a sudden your patient's confused, crawling out of bed. You have somebody that had a previous stroke that has recrudescence and they have those same stroke symptoms again. It's not actually reflective necessarily of a new neuropathology, but it just that something else is going on. So if you start to remove those other factors, you're going to see that the exam is going to improve. And with these, how can you actually make a determination of how these patients are going to do? But it's not really possible to remove every single confounder, is it? And so that's why we have ancillary testing. We should not rely on ancillary testing though. And so all of these guidelines that we put out over the last 2 years, you'll see that they're all worded in a way that makes every recommendation kind of lukewarm, which then you wonder, is it really valuable as a resource? But it is, because we used to put a lot of emphasis on these other studies. EEG, I mean, even if it's flat, that doesn't necessarily mean anything because you might get something back. MRI, as long as there's some gray-white differentiation, these patients can improve. So unless there's something profound on there, it's not necessarily going to sway your care one way or another. Now, if you start to get all of these bits and pieces and put it together, I tell families that as we're getting this, it's like painting a picture. Or did you guys ever have where you used water as and there was like a blank coloring page, and as you move the water up and down and brushed it on, the picture came into view? That's kind of what we're doing. But even like that, it's not a great picture at the end of that, right? It's like this impressionistic watercolor. That's really the best that we have. When you're talking about the brain, there's still a ton of stuff that we don't know. So we have this kind of soft view as to what the future might look like. So we don't speak in absolutes. So 1 out of 4 people in their lifetime is going to have a stroke. So look around right now. That's kind of scary, right? And I'm going to start pointing at people and tell you who I think it's going to be. And so the background I'm not going to go into. We know strokes suck. They have terrible things that happen to them, a lot of disability. Now this has changed a little bit as we've had endovascular therapy advances, but we don't really know how these patients are going to do. The scale that you've heard everybody talk about, I think just about every speaker has mentioned modified Rankin. How many people are intimately familiar with this scale? I see all of our quality and all of our stroke coordinators raising their hand, and then like not very many people from the nursing side. So kind of the quick way of thinking about it is most studies say that 0 to 2 is a positive outcome, 3 to 5 is a poor outcome, and 6, it really depends on how you're looking at it, because I think a lot of people would rather be a 6 than a 5, but that's your preference. And so the issue I have with this is 3 is actually not terrible. And so we're seeing some studies kind of shifting to including 3 as maybe an okay outcome, because when they've looked at quality of life scores, they actually found as long as you have some ability to ambulate and move around, that you're pretty happy with your quality of life, not any different than a 2. So I would say to be a little cautious as we're interpreting some of these studies that say that a modified Rankin of 3 is a poor outcome. And the reason this is important is all of these trials with endovascular therapy look at modified Rankin and functional outcomes. And so if you can shift somebody from a 4 to a 3, that's actually super important and associated with improved quality of life scores. So how do the people that are smarter than me, how did they do with guessing how patients were going to do? So our neurointerventionalists, not ours specifically, I'm sure they would guess 100% right at how patients were going to do. They looked at what the outcomes were going to be of patients that they took for a thrombectomy. And remember, a neurointerventionalist might be a neurosurgeon, it might be a fellowship-trained neurologist, it might be a radiologist. So it's still a spectrum of people. And they were asked to evaluate pre-thrombectomy, how many of these patients would have a good outcome, which was the modified Rankin of 0 to 2. So they got this right less than half the time. Well, that's terrifying, right? Because they're making a decision whether to take these patients or not. And if they're only getting it right, not even half the time, then were we taking enough patients? Were there patients that might have had an improved outcome had we intervened? I guarantee that there are still hospitals in this country and absolutely in other countries that don't take patients that would benefit. I will say we're very lucky to work someplace that's an aggressive center. And the reason for that is all of these new trials that I've alluded to. So most of these are out. The last trial is ironically the last to come out. So that one's not out yet. But these are looking at patients that already have an established stroke. And they're showing that even with a large core, that you still improve functional outcome if you take these patients for thrombectomy. And so that's why you've seen our patient selection has really widened over the last 2 years. And most of these patients will at least go for a look to see if you can improve. And sometimes it's shifting that modified Rankin, like I said, from a 4 to a 3. But in terms of quality of life, that's a huge difference. These are all of the worthless existing models of prognostication that mean nothing because they all happen before we changed who we take for thrombectomy, which is why you never see us use any of these types of scores. And I didn't even know half these scores existed when I put this together. So what about hemorrhage? We talked a little bit about hemorrhage earlier. And you see, one of the requirements in our documentation is that we have to put in an ICH score. So ICH score is essentially looking at how big is the hematoma, where is it located, what's their GCS, and then is there intraventricular component as well. And so what's happened is the higher the score, the higher the predicted mortality. But this has also become a self-fulfilling prophecy. And so now we have people that say, okay, well, if their ICH score is this high, we're not going to do anything. And then what happens to these patients? They don't do well. And so again, everything is starting to shift that we're not using such simplistic ways to predict and help patients that might actually have a benefit. So what do the guidelines say? So we talked a little bit about it. All the guidelines say, wait before you tell these patients that they're going to die. Now, the Neurocritical Care Societies, they're reasonable folks. If a patient comes in brain dead, we're not asking you to wait 72 hours to say that. But everybody else, you should wait. And so really, the most important factor is time. And you'll probably hear as we're talking to families
and they say immediately when these patients come out of the OR, how are they going to do? I don't know. I don't know how they're going to do. So we need to get more data points over the next couple of days, and we need to give them time. Patients will show you how they're going to do. Like most of the time, they're going to have one big change for the better or for the worse. And if they're riding somewhere, that's okay. And the biggest problem is there's not a good space for these. It sounds like maybe IMC might be an okay place for these. Only if they have insurance. I see the financials now. But there's not a good arena to allow these patients that are somewhere in the middle that still require a high level of care to give them appropriate time, because you have administrators saying, oh, length of stay, length of stay. And so this is going to be a new arena in critical care, in the critical care continuum over the next 10 years. Already national conversations occurring. Where do we put these patients to allow them time to recover? All right, so what we say matters. I know this is shocking, right? And more than what providers say, nursing at the bedside makes a huge difference. We know that the minute we walk outside of the room, they're going to turn to you and say, wait, so does that mean you think they'll be home on Tuesday? And a lot of times you guys come to us and we're shocked at the lack of understanding when we just spent 30 minutes talking to them. And you guys get the like real scoop as to what's going on. So there are a lot of communication techniques, and you probably already know the difference in somebody that talks to families a lot and people that don't. One is to talk early. So when they want you in the room immediately to ask how they're going to do, go. Doesn't mean that you're going to have an answer, but being honest about the fact that there's no answer means a lot. The other thing is when I go in the room, one of the first things I do is I try to get at the same level as the family. These are very comfortable chairs. You should definitely. And it's so that you're not just looking down at them. And especially if you have a trainee with you, I tell you, if you bring two people and you stand right over somebody, it's a lot more intimidating, and they're probably not going to ask you a lot of questions about what's going on. And it also seems like more of a patriarchal approach, right? Like, see, look, Wendy's taking pictures now, so I'm going to show you the alternative, which is that. So I know that your family member just came out of the OR. It's a lot more intimidating, right? Than if we were to sit down. And the next thing that I like to do is I like to ask your understanding. Wendy, family member just came out of the OR. Can you tell me what you know about this?
I don't know. It was a rush.
It was a rush.
Called me and said they were taking the surgery. I don't really know what happened.
It was a rush and you don't really know what happened. That sounds scary. And so you reiterate what their understanding is, because sometimes they'll be like, no, I know what happened, even though they literally just said that they had no idea what happened. And so that extra second to actually repeat back, you'll get more clarity. And then, so if the nurse is there and she's like, oh, God, Diane again. Then the family's going to pick up those cues, right? And they're going to be like, oh, this lady thinks everybody's going to do fine with time, which I will tell you, I totally was that nurse. I was rolling my eyes in the corner 20 years ago, but the more information you have and the more that you can see these patients over the timeline, over the continuum, the less that you think like that. Have you ever met the provider that talks the entire time and the family keeps trying to ask questions and they never get a word in? Do we have any talkers on our team? There we go. And so it's really important to let them talk, because one of the other things when you're thinking about prognostication is the discussion as to what's important. So I always say that if I can't put my own socks on, that I don't think I'd want to keep doing this. That's probably an exaggeration. But for some people, it is simple things. Like imagine if your family member is an opera singer and they're unable to talk or sing, even though those are separate areas, but still, that might be something really important. Or if it was a professional athlete, whoever is in the hospital bed, and now they're not going to be able to walk or talk. These are things that you want to establish early, because there are certain certainties based upon the vascular region. So if you're looking at the MRI and a complete section is taken out, you might be able to predict with a little bit more accuracy that this person is always going to be weaker on that in that right arm. They're always going to have some trouble with communication. Where if it's patchy, you might not be able to say that with absolute certainty. Say the best case scenario and the worst case scenario. So best case scenario, they might get some of this function back. It's hard to say how much because that whole territory is not taken out. So it all depends on which sections of the motor strip are affected. But worst case scenario, they might not be able to move that arm, which is problematic for that patient potentially. So you want to give them the full spectrum, the best and the worst case scenarios so that they can make an informed decision. And then recognize that this is probably the worst day of whoever you're talking to's life. And you don't want to just paint one picture. You want to show them one, we don't know. We don't know what the 100%. How many people in this room have seen somebody that you thought was going to die and they actually did very well and you were shocked? Put your hands way up because I want everybody to look around. Okay, so we're not that great at guessing, are we? Right? How many people have seen somebody that you thought was going to do great and they just never turned around? Yeah. So the truth is, this is not scientific yet. And so we have to go into it acknowledging the spectrum of what patients can look like and the uncertainty that exists and support what's important for the patient, the family, and then create a new space for these patients to be given the time to see what they're going to do. And the most important, to assess your right hemisphere, to see if you have any questions for me. They're still damaged. All right.
Really great talk, Diane. Thank you so much. Any questions from the audience? No?
What can I introduce my friend here?
Please do. Yes, absolutely.
All right. I'm very excited to introduce Dr. Greg Wursowitz. So I've worked with him at Mayo Clinic for
2.9 years.
Approximately.
Yeah.
2.9 years. But it was exciting for me because I'd worked up in Cleveland, Ohio for a while, and this is probably true in Chicago as well. We have fully embraced PM&R, and I think a lot of people down here don't even know it exists. And this is something that we absolutely should have in all of our hospitals. I'm going to keep you gainfully employed.
There you go.
And I'm also going to give you. You want this one?
Yeah.
All right. And so he's going to tell you how many of you guys have heard of PM&R? So we can get a background.
Raise your hands high. I brought coffee beans to keep you awake. Because I'm going right before. Yeah. Oh, that was a hearing aid. Uh-oh.
All of a sudden now people are like,
There you go.
so he's going to talk to you about it and why it's so important.
All right, we're gonna fly through this. So if you have questions, just ask. My name's Greg Wursowitz. A couple things, see if my slides came. I'll keep pressing buttons, just like that. But I'm more OCD than Diane, so I would just keep going through. And mine says Baptist as well, final. And I know they loaded it because otherwise you're looking at me. But actually, I am a physical medicine rehab doc. I actually went to University of Florida for med school back when my hair was black. And they had no PM&R. So actually, what do? Well, I actually graduate med school, so I do have an MD or DO as you know as we go now. I did a year of internship in internal medicine, and it's a training program of 3 years. And what I look at is function. I think Dr. Malati talked very well about function. He talked about right brain injury. You know what I was taught? Left hemi. Left hemi secondary to the brain injury. And I'm sorry. Anybody still awake on them? I've never been told to talk louder. That's scary. All right. So we're going to go stroke rehab. Next slide. What do I hit? All right. No disclosures.
Thank you to Jamie Cox, my assistant. Always got to thank the person who does all the work. And Diane, I was going to ask you what all these mean, but I only have a half hour, so I got to get going. All right. 3, we always have to have LOs. I want to describe the benefits of early mobility. Why do we mobilize these people early? Why not let them be in bed and then send them to rehab? Review some of the role of PM&R in the acute hospital and identify post-acute care. I'm going to ask a question later on post-acute care. Just to give you an idea what I did. I grew up on the west side of Jacksonville. Any West Siders here? All right, there we go. Where'd you go to high school? No, so did I. But you went much later than me. So I'm a Forest grad, went to med school, got an MBA at USF after I'd been in practice for about 10 years, because what's it all about? The question I ask all my residents. Healthcare, what's it all about? The money, stupid. And I say that to them because we're here to take care of patients, but we have to understand we don't have unlimited resources. So if I can do things effectively, get better outcomes, and show the system how I'm saving money or making money, I'm going to get a lot more for my patients. I've been employed. I did private practice, community academics, university-based, University of Missouri, and almost 3 years at Mayo. So that means I either have had a lot of experience or I'm no good because I've had a lot of jobs. Probably the other. I've worked in IRFs, acute hospitals. I ran the medical post-acute or APAC, acute post-acute system at Missouri, where we put together an organized system because care doesn't stop at the hospital walls. How many people here work only in the hospital? The evil, no, I know. But what happens, how many knows what happens to their patient after they leave? Other than if they happen to wander back into the hospital. How many would want to know what happened? Yeah, it's rewarding to see those great cases come back. Differences, we talk about motor recovery. That's motor function. I can grade your motor strength, but I care about functional recovery. That's improvement of your performance. So one thing you got to have wherever you are, a culture of mobility. How many, I know it, Baptist, boy, when I was a whippersnapper on the west side, Baptist might have been one hospital. It's grown like crazy into a super system. So thank you, Baptist, because my folks that live here need it. But you got to have a culture of mobility. What is mobility? I don't care. Get them up, sit them at the edge of the bed, get them into a chair, get them standing, marching in place, walking. Why do I care? Because we know bed rest or not moving impacts almost every organ system physiologically, right? We know your breathing goes down, you get atelectasis, better chance of pneumonia, renal calculi. It's amazing. The simple things we do that make a difference in the patient's outcomes longitudinally. Because if I'm at bed rest, we've done studies where you take athletes, put them in bed for a week, and what do? They lose up to 15 to 20% of their strength just by being in bed. Now I give you hemiplegia and I make you weaker on your good side. It makes it a lot harder for that functional activity. Also, this is my favorite. I always tell people in bed, I say, the hardest thing you're going to have is not walking. It's going from sit to standing. Why? They lose their power muscles, right? So I try and gain a little credibility with the patients. Diane talked about it. I get to see a lot of patients in the ICU and I tell them, well, when you leave the ICU doctors won't follow you, but I will. And when you're ready to get out of the hospital, I'm going to play a big role on where you go and what you need. It may be nothing. We may send you home. It may be rehab, maybe some other level of care. Also, what is the biggest thing? People are scared to move people. Oh, they just got TPA. They just got TNK. They just got whatever you guys are given nowadays. Well, we've done some studies. These are a couple that were done at Mayo, but mobilizing patients treated with, this was TPA at the time, and with EVDs. Was there any problem or deficit or problem? No. They actually mobilized these patients within 24 hours of getting the TPA. The biggest issue they had was Someone had a little worsening of symptoms, but it was a blood pressure related, resolved. So I love getting them moving early. Can too much therapy hurt? Well, this is the Avert study. Some people may or not know, but in Europe, they did a big study where they actually showed they gave them a lot of therapy early and they didn't do as well. Well, what did they do? They over-therapized them early. When you talk about therapy, it's a medicine, right? Frequency, dosing, intensity. Does anybody give people and just say, go take Tylenol? We say take 1 or 2 at this point in time. Do we say just go get therapy? No, we should think about it. Dosing, frequency, intensity. So, and that's actually shown. This is the AHA guidelines. Early rehab for hospital patients with interprofessional team. I'm gonna argue. Earlier we heard multidisciplinary. We're interdisciplinary. I guarantee you are. We don't come in separately. We work as a team and communicate with each other. So this is ground into me from day one. Anybody still awake? All right, we're just making sure. I know lunch is here. Rehab needs to benefit and tolerance. So more is not always better. It's timing. When do we give more? When do we give less? Dr. Maladay, you'll love this. Formal assessment of ADLs, communication. What? We need speech. I definitely need speech. And functional mobility. We need PT, we need OT, we need speech, we need a team working together to help decide what they need, where they go. Functional assessment by a clinician with expertise in rehab. Oh, expertise in rehab. I'm sorry. High dose, very early mobilization is not recommended as much. It's kind of the Avert study. If I give you too much of anything, you can have a problem. I got to tell you, this morning I saw a patient, he's got an impella in. That means he can walk more because his heart's doing better. He had no problems at home, was walking to the mailbox. Now he's walking 10 miles and he keeps coming in. My knee hurts, my this hurts. I go, no, hey, dude, you went to 10 miles. Yeah. So I'm a rehab doc. Why would you use me? Well, and how do I look at patients? I look ischemic versus hemorrhagic. 2 different types of things. I'm going to see different things. Hemorrhagic, more episodes of seizures, more maybe a longer recovery pattern as it resorbs and the edema goes down. Location, right versus left. Well, I'm more thinking first, are they a hemi and then middle cerebral? Okay, so I know what goes along, not to the detail Dr. Malady talked about some of the communications. He's an expert on that, but I'll use his expertise. Time from onset. If you're a year out and have spasticity versus a day out and have spasticity, already I'm thinking of a whole different picture, right? Had a guy today and he saw bad spasticity year out, has a backlift and pump in, but he's got a fist like this. Do I turn up the pump or do I give him localized Botox for the hand? I'm going to go Botox because why turn up the pump? It's just little simple decisions like that. What's their support system? Medical, functional, social, financial, geographic choice. Okay, where do you live? What's the structure look like? What did you do before? Do you have anybody living with you? Boom, I'm already putting together. I tell people, you're here now. I'm going to put you out here. I'm thinking out here already. How do we get to that point? And each person is different. What's my current exam? What's their tone look like? Distribution of weakness, cognition. As you can see, I can go very fast because I've done this more than once in my life. And heaven forbid I ever talk about patient choice. Who cares what they want, right? I'm teasing, I hope you know. And your ischemic strokes, this is a little simple recovery pattern they teach you in med school. Twitchell and Brunstrom, it's recovery stroke patterns. This is for ischemic. Well, what happens initially? They go flaccid. Then you see increased reflex. Then you see some increased tone. You can see synergy patterns. Then weak volitional, and they follow this recovery pattern. So if I see someone with an ischemic stroke, and one day out, they already got weak volitional. Is that a positive prognostic or negative? All right, who said positive? Right, I won't throw it this time. My liability insurance doesn't cover that much. All right. So again, I'm just using things that I know and in the literature to try and figure out what's going on with them. simple things. Anybody use multi-POTUS boots or in bed or Z boots or Z? I like multi-POTUS, are a little firmer, but I'm not promoting anything. Why am I'm standing over here the whole time? So we want to look at positioning and things like that. Simple slide, things I look at, sensory loss gait. Diane, I need a 10-minute warning when I'm 10 minutes. Yeah, I got 20 left or 10? 20 left? I need to slow down then. All right. Okay. But what do I do? But how do we determine where people go? It's drilled in my mind: medical, functional, social, financial, geographic choice. I will tell a patient that exactly that's what I'm deciding in my recommendations. Medical determines, that kills you. You got to be somewhere that can handle whatever your medical needs are. We know we have LTACs now that do ICU care. We know we have IRFs with rehab docs and consultants. We have some SNFs that have a lot of care. Physician, medical, functional issue. What are they doing from a functional standpoint that the team evaluated them to do? What's their social? Where do they live? At Mayo, we see people from all over the place. And the decision has to be, are they going to go back for rehab where they live? Which family is a very important component of rehab. Or do we keep them here and send them to Baptist doesn't have, but one of the other rehab centers? Okay. Financially, anybody ever look at their financial? I have no problem asking them, boy, who's your payer source? What's the best payer for rehab? I love you. Medicare A and B. What's one of the hardest? Manage Medicare. And United. United has what? They often have Navi Health out of Tennessee that does their monitoring. I know all this stuff because I did some work at the AAMC with bundled payments, and actually Tom Scully started Navi, I think. One of those guys, but it used to be at CMS. Financial and choice. Patients have a choice. Now, I hate when they tell me, you got to give them choice. I do, but they need to have an informed choice. How do we inform their choice? I need to educate them. There are different levels of care. All right. So I look at that, match their needs, current and future functional. I'm trying to predict where they may get, right? Like Diane said, I hate her. That you're always wrong. Have I made wrong? Yes. It was once. Social support, what is it? It's different if they're the primary caretaker for their old decrepit husband, like my wife is, versus if they have a big family. Anybody remember Christopher Reeves? High spinal cord injury. Where did he go? Home. Why? He got more money than all of us, and he could hire the help to do it. That's not good or bad. It's just what the case is. We see someone who lives on second floor apartment, no elevator up, left hemi, hurting for resources, barely making it. That's a whole different picture that we got to think about. That's the fun part. I love this job. You know, how do we help people? There's a lot of practicality to it. Geographic, and we said choice. Anybody look at MedPAC? MEDPAC. It's an advisory group on payment issues to Congress. Comes out, it's free, medpac.org, med.pac.gov. And they put out reports and post-acute care. If you ever have an interest in this, and they'll go in and it's great on it. And they tell you what's the latest things going on, what's the latest legislation, what are recommendations. This was, they did a survey of case managers of how did they determine whether a person goes to SNF or IRF? Bed availability, beneficiary, level of determination, proximity, ownership. On the other side, you can see MA penetration. Anybody know what MA is? What drives you sleepless? It's not Medicare, but what? Medicare Advantage. All right, we'll give you that. I'm gonna get close there. Oh, nice grab. But so that's why I asked. Financial is a big determinant. If we ignore it, you can't ignore it. It is what it is. We go with it. So what is post-acute care? This is my last one to give out. Can anybody name, based on CMS, what are the 4 levels of care in post-acute care? Somebody said SNF. Not nursing home, SNF. LTAC is this number 2. What's short-term rehab? I hate that term. I didn't look who said it. Who said it? Inpatient rehab hospitals or IRFs. Got one more. Home health, that over here. Home health. So when we talk about, I'm big on words because we use it. And the reason I say short-term rehab, some skilled nursing facilities will say they're rehab centers. And they'll say they give short-term rehab, and they do, but that's not IRF level of care. So we, back in, when subacute rehab first came out, I was guilty. I hate that term. It's therapy in a skilled nursing facility. It is what it is. Doesn't mean it's not good. It's just what it is. All right. And so you can see those are the 4 when we say post-acute care. And if you do reading, and just so you get an idea, in post-acute, this is straight out of the MedPAC stuff. There's about 15,000 skilled nursing facilities, 1,100 IRFs. Just so you know, there's a lot more SNFs than IRFs. That's why in your area, you need to know. And more money spent on SNFs than IRF level of care. This is my post-acute 101 when I lecture to the residents and other departments. The blue is the amount of medical care at that facility. So LTAC, you get a lot of medical, a bit of rehab. IRF, you get, there's medical there, but a lot of rehab. The rehab's in the red. SNF is, you know, medical's there. You spend the green is recovery time. It's more for recovery and some therapy. And it gives you an idea of what's going on. This is not hard and fast, but it gives you a kind of an easy picture. Regulatory issues, LTAC used to have a hospital 25-day stay they need to have for Medicare reasons. IRF 60%, 3 hours. Has anybody heard 3-hour rule? I got to 3 hours. I can't do that. I say baloney. I said getting on off the toilet and working with that is part of it. Even speech of all things is part of it. I'm not going over there again. But no, so I tell people it's not walking for 3 hours. It's split up during the day, and we can do that. So most of your decisions are pretty easy. People are going to go sniffer, but there's a lot of Venn diagram overlap. And that gray zone is where hopefully I make my money. Because if I put them in the right spot, we're going to get the right outcome at the right cost, at the right use of resources. So it'll be there in probably a couple hours if I stroke out. No, I don't mean that. 10 minutes? Oh, I got 10. Oh, it's on there. Diane, I got to mention, I love that you said, I hate her. One thing I do, I always get eye level. I was taught that. And I always like to touch the patient. Sorry, I didn't mean to touch you, but now I just hurt someone. I just attacked someone. But there's a lot of softness in it. And that little bit of softness goes a long way. So I'm a believer. Here's something looking at outcomes in patients with strokes. They looked at beneficiaries, and at the IRF, they doubled the gains in self-care mobility. The readmit rate was much less than the SNF. They had a decreased mortality and minimized medical complications. Stroke-specific readmits, well, the readmit rate for stroke in this large population was 11%. Going to SNF, it was 15%. So anybody ever done bundled care? Anybody had bundled care? Yeah, you did a bundled care project for what population? Yeah, stroke, how'd you do? Yeah, stroke's a hard one because it's a lot of medical complexity you can't control and predict. I did a Model 3 post-acute in Missouri. We actually made money because you know what we did? We made sure people got follow-up after they left and that they didn't get readmitted to the hospital. Readmissions are called bundle busters. What do most people do for bundled care? Hips and knees. Hips and knees. Why? They're easy. They're predictable. I'm not going to cut on you unless I get you real healthy. And then I cut on you. You can go home. People used to go to rehab. That costs a lot of money, right? But you can't do that with stroke. But if we did it, we even showed with our Model 3, you can make money. Now, the patients went to rehab. It cost more initially, but longitudinally, it was a 90-day bundled. We recouped that by not readmitting. This is my preaching. I hate when people say, oh, we send them, it's a bundle. They all need to go home or to sniff. No, 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 no. All right. I digressed. So in considerations, people will say, is there a bias there? Because you're only taking good people that can participate in rehab to the earth, right? We're self-selecting patients. And Weinstein showed that even with all the risk management, all the risk modifiers, no, they did do better overall. All right, AHA, and everybody's familiar with all these guidelines. They said it is recommended stroke patients who are candidates for post-acute rehab, post-acute, 4 settings, IRF, SNF, LTAC, home health, organized, coordinated, interprofessional care, right? Stroke survivors who qualify for and have access to IRF care, and I do not work for, who's in town now? Brooks, Encompass, I'm leaving people, Reunion, St. Vincent's, Orange Park. I don't work for those guys. Have access to IRF care, receive treatment in a nerve in preference to a SNF. It's right there in black and white, AHA and stroke guidelines. So, but what do we always need to do? Follow what? Follow the money. So, because why doesn't everybody go to rehab? Well, it costs money. And if you look at this stroke, this was also from MedPAC. If you look at this, payment was about $24,000 in rehab for stroke care. Now that's just an average, but I like to think, I like money and I like thinking about it because that's what makes the world go. And if I can find ways, if I know that and I can find ways to help patients and manage this, you know, I can walk into the C-suite, right? Who runs the world? Well, women, all right. God, I knew. All right, you get one later, Diane. I'm not, this audience, I am not arguing. I agree. At home, I'm doing the same. But you're right. Other than women, it's the C-suite, right? Who lives on the front line? You guys do. So if I can talk in their language, I can make change. If I can't, what are they looking at? They're judged on what? Did we make money or not last quarter? Oh my God, they're like politicians. They're judged by quarterly or short-term, you know. Okay. I saw a yawn, so I got to get going. All right, but welcome to Florida. I did a talk. What happened? We had a CON for rehab. We know rehab can make money. What happened when they broke the CON, Certificate of Need for Rehab in Florida? Bam. They're popping up all over the place. Now we're old and decrepit in Florida, so we need it, me included. But you can see would that happen if it wasn't? The other thing is, the thing we're starting to struggle with is Medicare Advantage. Anybody struggle with Medicare Advantage? It's fine for like going to the gym in silver sneakers, but if I need rehab, can I automatically get in? No, if I have Medicare and Greg Warswich says you need rehab for these reasons, medical, functional, social, financial, I put these things in my note, you go straight to it, right? But with Medicare Advantage, you have to get prior authorization. And what happens with prior auth? They can deny it, right? And this was from AMPRA, the American Medical Rehab Providers Association did a survey of the 102 respondents of 475, so about a quarter of their people responded. And they said lower level of care was the primary reason for denial. Is it lower level of care because of medical? And you got to be careful because what do we write in the chart? Medically stable, right? Well, if I'm going to rehab, why do I need a physician to oversee me? I have blood pressure issues. I'm going to give you 3 hours of therapy. That's a physiologic stress on the system. They are not at a functional level. They need to have something monitored. You better make sure your docs know, hey, come on, if you put medically stable, they're okay. Boom. Oh, that can be handled at a skilled nursing. Oh, but they need 3 hours of therapy. Oh, they're at contact guard. We better make sure our therapists, I'm not going to look to change the system, but just documentation is critical. So we cannot be sloppy. We, the team, the interdisciplinary team, we need to educate, never do what's right, and it'll come back in the wash. Also, LOS, length of stay, anybody getting squeezed, they need to be out. My beds are, I need more beds, I need more beds, I need more beds. I do. All right. Well, this adds about 2.4 days onto their stay just waiting for auth. So I better start early. And who can help me start early and write the right things? No, a PM&R doc. PM&R doc. Who needs a PM&R doc? All right, no, in your system. And peer-to-peer, how many people have to do peer-to-peers? Ever had a patient need it? Who does it? Who does it? Usually the lowest person on the totem pole. Yeah, I mean, who is like, I don't know, they're okay medically. Yeah, you don't know. Yeah, no, I joke, but it happens even at other esteemed places. They're time limited. Get the number from the case manager. Review. I tell everybody: medical, functional, social, financial. Be ready with all that. Don't go in there off the seat of your pants. Know the facts, because he or she on the other line has looked at it and they've circled things that they're going to say, no, what about this? It's written. You got to do it. And ask for their name spelling and record. Has any place here record all of their peer-to-peers they do? Does anybody complain about doing peer-to-peers? Nobody? All right, I'm out of here. You don't need a PM&R doc. Yeah, this is my next goal. I want to collect all the peer-to-peers we do. Is it a certain insurance? Who did we talk to? Is it a certain physician? And what was the reason for the no? And if I know the reason and it keeps popping up, is it something I need to think about looking at? Oh, got 1 minute. So should we follow the money or the patient? I say follow the patient. This is one nice thing about bundled care, because you guys, the blue in the hospital, this is something we did with bundled payments. You don't know what happens to them after they leave. Why don't we start tracking and working together and collaborating with our post-acute partners? This is my thing. I'm meeting with them now and getting scorecards from them. Do I care? And when you go to them, do you care what their overall, who do you care about? Who do you care about that goes to the rehab center or the skilled? My patients. I don't really, nothing personal, but I don't want to waste my time on how other system patients did at their center. I just want to know about my patients. Because am I sending you the right patients, and can you handle the patients I'm sending you? I don't care what St. Vincent sends or Baptist sends. I hope they all do wonderful, and I hope they beat the mark. But what about my patients, individualized by the service lines I send them from? All right, I'm preaching again. Here we go. We're getting there. What about future with rehab? Well, it's all activity-based therapy. Once again, here's the hard part. We talked about NIH scale has some deficits. Modified Rankin scale has every scale we have. But what type of therapy are they getting? When do we give it? Do we give high dose early or later? Is it within the first 90 days? What's the dosing, frequency, and sensing? What's the session length? Anybody a runner? And do you train for stuff? And do you look at how your shoes are, how often you do, what's the pace, what's this and that? What do we do with therapy? PT 3 times a week for Valentry. No, we can't. We got to be much more specific and granulate down on what we do. It is a drug, and each therapist is a little different professional on what he or she delivers. All right. Impairments, things we looked at, their studies for looking at aphasias, very early rehab for speech. Do you dump a lot more therapy early? And do you get cognitive or communication differences, dysphagia? They've done neuromuscular sim to help with that. You can go on discriminative. I love the motor cost benefit for training. How much it costs for added increase. They showed increased gait speed, but not distance. So my wife can chase me faster, but not farther. So good. Did I go there again? All right. ABT devices, telerehab. Some of the telerehab they looked at is, just simple things, getting people moving, making sure they move. Because we do what? We give them a lot of therapy, they get gains, they go home, and what happens? How do we make sure they do better. All right, virtual reality, same thing, looking at motor, getting them going, robotics, gait speed, repetitive transnerves. One thing they've started doing at our place, when we started a clinic, looking at, people that are a year out who have thrombotic strokes, do vagal nerve stimulators. If we change catecholamine, and they have to do an extensive post-surgical OT, they have shown improvement in Fugl-Meyer scores. Everybody know their Fugl-Meyer scores? You don't? What, Diane, you said these people, no, I'm teasing. Yeah, it's one of these again. There's only 8 million scales, only 8 million scores, but it has shown some benefit in some people. And we had one lady came back and said, wow, I can write better. And she was so happy and hugging me. And I'm going, until you have the problem, you don't realize how good it is to get something back. And we minimize often just gait pattern being a little better. Other things, drugs, med, computer, all the, we talk about cellular therapy for knee joints. Now I'm sticking needles in my brain and giving you cells and all. There's people doing that and looking at it, but they're about 10,000 times smarter than me. And who knows what's going to happen. We're at time, and look at this. Let's see. Wrong button. Because things are always changing. So you got to pay attention, because if you miss the boat, sometimes there ain't no going back. So I want to thank you for your time. And Diane, thank you for letting me talk. It was a great thing. Thank you. Any questions other than how do you get a PM&R, doc? Questions, complaints? Those will come later. All right. Thank you.
Okay, guys, I think it's
Recording stops. Recording in progress.
Hello, welcome back to lunch. Before you try
So a subarachnoid bleed, hemorrhage is the bleed in the space between the thin layers of that protect the brain. It is a medical emergency. If we see this on a scan, we get report that someone has a suspected subarachnoid hemorrhage, they immediately get rushed to visit their friendly neurosurgeons. All of these things can cause increased in intracranial pressure. They can present in multiple different ways. Most of the time when you have someone that has a subarachnoid, it's usually caused by a ruptured aneurysm, or sometimes it can be caused by a trauma, which are my residents' favorite things to see. When someone falls and then you see like scattered subarachnoid, you're like, sweet, they get to go to trauma and not to neurosurgery. Makes our day great. So some of the anatomy and physiology behind subarachnoid hemorrhages, we're going to talk about the ventricles, a little bit about the spinal anatomy, and then about a true SAH and ICH. And I will use SAH and ICH almost interchangeably during this talk. Stop me if you have a question or if you need me to slow down. I do speak very fast, which is why many people don't believe that I'm actually from Arkansas. I don't know. Words just tend to fall off. So in the ventricular system, we have 4 interconnected cavities known as cerebral ventricles within the brain. Each ventricle is a region of the choroid plexus, which produces cerebral spinal fluid. So this ventricular system is a continuous system with a central canal that goes all the way to the spinal cord from the 4th ventricle and allows our beautiful CSF to flow. One of the things that we will talk about, or I talk to my residents and other APPs about, is when we are doing LPs, we always want to get a champagne tap, and why we want to get a champagne tap, and you know what it needs to look like. And for any of you who do not drink, I apologize because I have a lot of wine references. Again, it kind of goes with it. Remember blue cell tumor, it's okay. So your spinal anatomy, now this is going to be the biggest thing. Again, working for neurosurgery, I do spine and brain. Those are my 2 systems, the things that I care about the most. So if I have a medicine team that calls me and they're like, hey, we tried like 3 times to get an LP on this person and we couldn't do it. Do you think you can come and like check it out? And I was like, sure, who's the patient? Tell me about them. And like, they have a spine and a fever. And I was like, okay. So they're meningismic, their neck's like stiff, they got something else going on. No, we just, you know, we've done all the scans and all the labs, and it's going to be like 4 days before they come back. And so we just thought that we would do an LP2 to rule out everything. And you like walk in and it's somebody just like up walking around going, yep, I don't know. They won't let me go home. They keep saying that I got to wait to see you guys. And I'm like, what? I mean, people, again, context clues may be lost on some people. So when you're looking at the spinal anatomy, you're getting a history of your patient, and this is going to be something that nurses are going to know and allied health professionals are going to know more so than my sweet little baby residents, is if the patient's had surgery before, if they had some type of spine surgery, because you talk to the patient, you're interviewing the patient, you're having conversations with them. So a lot of times someone's going to tell you, oh yeah, this one time when I was 24, I did a high dive off the cliff of the Ozarks. Again, I'm from Arkansas, so I have lots of references to that. And then I like landed weird and they went in, but they just said that they didn't fuse anything, but they may have put something in like a space. I went home like the next day, but like, that's it. I haven't had any other surgeries beyond that. And you're like, what? And then of course you like get an x-ray and they have like, they're fused from like teeth in the pelvis or something insane like that. You're like, what? You just said you had one thing. But knowing the history of your patient, just like knowing that whether they have an aneurysmal or traumatic head bleed, you want to know if they've had any spine surgery, if they have had any deformity correction surgery, if they were an equestrian, if they were a gymnast, if they were a swimmer, if they were a high diver. Just finding out those basic things can kind of help you understand what's going on with those patients, especially before you accost them with a needle into their back. So on to the pathophys of subarachnoid hemorrhages and intracranial hemorrhages. So subarachnoid hemorrhages is why I got into neurosurgery. It's why I became a neuro nurse. I have always done this. I was a pharmacist for a little bit before this. I went to pharmacy school, and then one of my patients was like, you really like to talk. You should be a nurse. And I was like, sweet. Sounds good. Yeah, that was in 1999. So here we are. So subarachnoid hemorrhages, when you see them on a CT scan, when the patient comes in, you don't know what's happened to them. All they say is that they fell down or they had a headache, or they were in a car accident. Trauma scans are my favorite because they scan from head to toe. And then they usually say, we saw some bleed, a little bit of blood on blah, blah, blah. And it's like, that's a calcification or a cross section of a CT. It's, not necessarily something that you need me for, but sweet, I'll come down to the ED and sign my name on the piece of paper within 30 minutes so that I can continue to say I showed up. But some symptoms of a SAH include severe headaches, nausea, vomiting, neck pain, nuchal rigidity, and photophobia. The initial hemorrhage is fatal in about 20 to 30% of the patients. Many complications include rebleeding, hydrocephalus or hydrocephalus, depending on what part of the world you're from, delayed cerebral ischemia associated with vasospasm and potentially seizures. The likelihood of rebleeding is increased by the measures that we use to take care of the patient. So to rapidly lower their blood pressure or to rapidly lower their intracranial pressure, those measures tend to affect whether or not the patient is going to rebleed. Which the ladies this morning, the stroke coordinators, talked a little bit about that. When you talk about blood pressure and lowering it, that's again a whole nother discussion because I do something completely different. When I lower my patient's blood pressure, I don't always go less than 140. Shh, don't tell anyone. Intracranial hemorrhages, we see these a lot. I'm sure you do as well. I mean, stroke belt, we have patients all the time. The total eclipse happened on Monday for those who were able to see it. I live in a place that had totality for about 2.5 minutes. So it was really cool. Everybody walked outside. We looked up. We had on the approved glasses. All the lights came on, confused my sweet little mentor patients even more. What was going on? It's fine. It's okay. It's day, night, day, night, day. It's cool. That's how we roll. So a lot of patients that come in, they have some type of head bleed. Most of the time, I'm going to see them because it's related to blood pressure. So the reason I even brought up the fact about the eclipse, we were just like waiting for all these things to happen. State of emergency was initiated in my state. They had all these one way for me to get to the hospital. Remember, only level 1 trauma in my state. One way to get into the hospital, one way to get out. The population of my state like doubled to 6 million people. There was like all these people going to Pinnacle Mountain, which is like 37,000 foot elevation. Like 10,000 people were out there watching it. All these people got married in the dark and all this cool stuff. And I was like, yes, we're going to have so many wrecks, so many traumas. Like, we're all like juiced and excited. Again, I'm sarcastic. I'm so sorry. So we were just all excited about this. I went to work early, which I'm not a day shifter. I'm a night shifter by trade, but like went to work early, was there, ready to go. We got one trauma. And that person felt special because you would have been amazed at how 30 people ascended up on her. And it was a sweet little lady who thought she was having a stroke because no one had told her about the eclipse. So when it got dark and she went outside to look up, she was on her rollator. So when she looked up into the sky, she just went ahead and fell back and hit her head. Oh no, she's okay. Traumatic subarachnoid. So yes, for me. But anyway, intracranial hemorrhages. So patients with high blood pressure, traumas, weakened blood vessels, your diabetic patients, people who have strokes before, high cholesterol, people who are alcoholics and like to party just a tad, not me, cocaine, menopause, severe migraines, any and everything can all lead to you having an ICH. So now the reason we're all here. So indications for EVDs, ventriculostomies, external ventricular drains, all the different EVDs, all the words that ventrix. I was like, what was the first word I used to use it? So these are for hydrocephalus, for patients who have an elevated ICP that is refractory to medication, meaning pupils pupils blown. We've given them like salt bombs. Sorry if people don't like that word. We've given them salt bombs, mannitol. We've raised their head 30 degrees and straightened them, which I know I heard last night is something that may not be a thing to do. And we want to measure the pressure in their head. Or if you're any of the trauma surgeons at my hospital, they create a GCS of less than 8, and therefore they get a monitor. Notice I said create a GCS of less than 8. And so they want something to stick in their head, and they usually don't want to just a bolt. They're like, you may have to drain CSF. And I'm like, you know what, trauma surgeon, I may, but I really don't. So this is CTs of hydrocephalus, which are very common after subarachnoid hemorrhages. About 20% of patients who have aneurysmal subarachnoid hemorrhage end up having acute hydrocephalus and end up getting a shunt. 1/3 of these patients, one-third of that 20% don't even notice that they are hydrocephalic, or they may not be symptomatic from that. But half of those after admission develop symptoms of, I almost said hydrocephalus, Sorry. So lumbar drains, something that we do a lot as well. And you'll find out in a couple of slides why this is EVD and lumbar drains for subarachnoid hemorrhages. So we usually stay busy putting them in patients who have a CSF leak, whether it's from a trauma, whether it's from, I don't know, we did a far lateral approach, something, we resected a tumor, and now they're leaking out of their ear. We'll throw a lumbar drain in them. But we also are kept really busy by my cardiothoracic surgeons. I probably place more lumbar drains in a week for CT surgeons than I do for neurosurgery patients. Not necessarily a bad thing. It's just, you know, the reasons for that. And so those are some of the indications that we actually do place those CSF, those lumbar drains for patients. But wait, the reason everybody's here, and this is only funny to Diane because Diane sent me this. So just like going to a speakeasy, you have to be able to recognize things and understand and know the secret passwords of all the way to take care of patients with EVDs and how to place them and how to take care of them and manage them. Unfortunately, it is not always easy. As you can see, the title of this picture actually says Parks and Recreation. So one of my beautiful residents, 3 passes later, actually gets the EVD into the ventricular space. It's not as easy as they thought it was. Also, the reason that this is a picture is because we have a wall of shame. So whenever you have a hubris about you and you're like, I'm gonna get it, here I go, especially when they say that they're gonna be able to get one on the first shot, or they don't want me to do it, I'm like, go ahead, we'll see. And then I'll put your picture right up there and make you sign it. So for us, we always place them at the bedside. Occasionally they're placed in the OR. It depends on what is happening with the patient. If we have somebody that's a polytrauma, then those patients will be in the operating theater already, and so we'll go in. But most of the time, this is at the bedside, wherever the patient may be. So ED, PACU, hallway of the wherever. And then here's some more examples. The midbrain motor is hilarious. And also, I'm sorry for people who have never seen anything related to that movie. I'll explain it to you later. But it takes practice to be able to get it right, to get your techniques right. Also, now with the placement of lumbar drains, as you can see, that's my wall of shame. That's also up there. Lumbar drains, typically they're placed at the bedside by myself or my PGY1. Sometimes PGY2, depends on who's in trouble and on call with me that day. It's always by landmarks. If someone has had a previous surgery, that's the only time I would call fluoro. And usually I'm going to fluoro with them, interventional radiology, while they're having this done, and we're shooting it. Now here's the kicker. So for me, I put lumbar drains on a pump. The med pump that we use for medication. It's the off-label use I've been doing for over a decade. It allows my patients to get up and walk around. And yes, people thought I was crazy, but it's a MacGyver thing, literally, that me and at the time he was called a physician ascender, but another nurse came up with to try to figure out how not to overdrain people, how to offload some of the go in there and wait for the drops to like come down. How many was supposed to do? 10? Dang, I did 15. Okay, well, -5 the next hour. And then you go in the next hour and you forget that you're supposed to do the -5 and then it's whatever. So putting them on a lumbar pump. The patient is the piggyback. So we use Alaris med pumps at my facility. I take a 250cc bag of normal saline. I flush regular primary IV tubing. I tie it off. I drain out the bag because people like to help you. And I don't need anyone to touch my pumps and like try to bolus a lumbar drain. Because again, this is on a med pump. This pump is separate from everything else, but still you have those really helpful individuals who like to come and touch stuff like anesthesia. And you were like, did I tell you not to touch my pump? So I tie it off at the top, put back on my saline just to keep it covered and keep us all kosher. Hang it on a bag. Do a regular lumbar drain like I would normally do. Instead of connecting it directly to the Buritrol, I'm connecting it to the piggyback port off of my primary tubing. So the patient is my piggyback. So I'm setting my lumbar drain at 5, 10, 7, 12, 25, depends on the patient, what we set it on. And then I am draining. This is what we do for just about every aneurysmal subarachnoid hemorrhage. You get 4 lines, usually an ET tube, an ART line, a central line, EVD, and then if you're real special, you get a lumbar drain. We do dual exhaust on all of our people for over 10 years. I know, it's scary. And it's on a pump. I mean, we're just crazy with it. And the one thing I don't have is a picture of it on a patient because I didn't have a picture without a patient. I know, I suck. I'm sorry. I'll email it to you. So management of EVDs, we want to make sure that the CSF is draining, it's working properly. We have peaks and valleys and that it's clear. We use, again, a wine scale for my EVD drainage, somewhere from Merlot to a Chablis to a Rosé. I told y'all. And that's kind of like how we measure what's happening with the patient. It also helps the patient family be involved in it. Like, what color is it? Oh, it looks almost like a red wine. I said, then we need to keep going. We're not there yet. So some of the management of lumbar drains, like I said, I made it real easy by placing it on a pump. These patients, as it was discussed earlier about your step up or step down unit. So these patients are progressive. They go to my regular floor where these nurses are 1 to 3. So I can get them out of the ICU. If I can liberate them from their EVD, which most of the time I do get the EVD out before I get the lumbar drain out. It just depends on which one clears first. That's the whole math behind it. It's not like a magical thing. I don't always go, yeah, let's take out the lumbar drain first. But usually whichever one clears first, that's the one that comes out. And then the patient can go upstairs, have family visit, sit in a chair, be semi-normal, and still get TCDs and still be continuously monitored and all that stuff. It's just a way, again, to offload beds in the ICU to make the patient feel more normal, especially when you have those that come in with like lower grade aneurysmal ruptures, and they're able to do more stuff. So for advanced practice providers, for my facility, we are in charge of these. I'm the person that teaches all of my residents how to do this. I'm the person that educates all 200 and something odd critical care nurses from the ED, the PACU, the ICUs, and then my progressive unit on how to manage and take care of those. Twice a year, I do the education. I've had people FaceTime me like, hey, help me out, how to figure this out. Slowly, as I've been involved with teaching residents more so I have more baby graduates that are, kind of all across the country that always want to know, okay, I need to do this, help me walk me through this, or hey, come visit me today and let's figure out how to make this work. So quick overview. Let's see what we've learned. Yes, interaction. It's after lunch. I mean, I need people to wake up. Okay, 54-year-old female presents to the ED, sudden onset of headache, describes it as the worst headache of her life. Has a history of hypertension, but no recent trauma. Her GCS is a 13. She does have signs of meningeal irritation on exam with some neck stiffness and photophobia. Here's her pictures. The CT scan of her head reveals diffuse subarachnoid hemorrhage, predominantly involving the basal cisterns that are consistent with an aneurysmal rupture. And there's a little bit of hydrocephalus there. So which one will we do? EVD or lumbar drain? Just shout it out. Sorry. Remember, I'm the crazy person. Everybody gets all the things. You get all the lines. Most of the time, by the time my PGY1s hit like month 6, they've done so many of these. They've done at least 12 because we do both at the same time. So this patient, we threw in an EVD, pressures were good, put in a lumbar drain, set it at 5. Why? Because 5 sounds good. EVD's at 15. Why? 15 sounds good. We scan them every day because why wouldn't you? It's neurosurgery. We don't have a portable scanner. So at 4 o'clock every morning, it's just like a little processional down to the ED scanner, makes our respiratory therapists real happy too. So this patient, remember she was young, so her headache got better. We only kept her in the ICU for 10 days. Everything was clear. So again, for her, I pulled the EVD first and then pulled the lumbar drain second, but she was upstairs on our progressive unit with the lumbar drain. Worked with PT, OT, and I always get PM&R because I love my physical medicine rehab doctors. Hydrocephalus resolved, went home with no issues. Beautiful. Number 2. P.S. Everyone lives in all of my case studies. I feel like I have to say that. So 32-year-old male brought to the ER following an MVC. He was wearing a seatbelt, good for him, but unfortunately was involved in a high-speed collision. His GCS was 10 until the trauma people got a hold of him, and then it magically became 7. Pupils are echoreactive, but he was exhibiting some signs of increased intracranial pressure. Can anybody guess what that was? He was combative. And so they're like, he was combative. And so we knew his ICP was high just by like looking and waving a hand. We felt that he needed to be intubated and then put on propofol and Versed. It's fine. So he was bradycardic and hypertensive by the time we made it down there, GCS of 3. So here's his picture. I mean, that does kind of suck. So large ICH, right, involving the right frontal lobe with extension into the ventricles. So, you know, we know what he's going to get. He's got some midline shifts. So what do we think? I know. See, I know. You're what? Yes, you're welcome. But he was a trauma. And the only reason he needed an EVD, I won't say. But he would have got a bolt if they wouldn't have snowed him. But then they snowed him and I didn't have an exam, so then you get EVD. Okay. So remember I said everybody lives. So he worked with therapies. We do have a TBI rehab, which is where my PM&R folks are housed. So he went there, and actually this is a fun story because this happened to him as an M4, and I almost said a not so nice 4-letter word. I was walking down the hallway and I heard someone say, "Hey, Ebony," and I'm like, is it a family? Dang it. And I turn around and it's him. And I'm like, "Hey, what are you doing?" And he was like, "Oh, I matched with neurology." So he's like a whole resident. I wrote him this beautiful letter, me and the surgeon and all this stuff. And like, so he wouldn't get kicked out of med school. I know, he's like a PGY1. He's doing neurology, not neurosurgery. Whatever. Okay, number 3. So 60-year-old male, hypertensive, comes to the ER with fever, altermental status. He had an aneurysmal subarachnoid hemorrhage. We had an EVD in him. Of course, because if you draw CSF studies, it'll show that something's infected, so you just don't do it. Come on. Here's his scan. So SAH is still present. It's in his Sylvian fissures. some enlargement of his periventricular. So, and then there's like a little bit of hypodensity, which may not be clear on the scan. So, you know, we're like, crap, he had an EVD, now he has a fever. So what's going on with him? Yes, I heard it, sepsis. So we dropped in an EVD, treated him for ventriculitis, called our friends an ID, which we never like to call because then they always tell us like, is you have dirty hands, you have poo-poo hands, everybody needs to get colonized, blah, 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 blah. So we did IT antibiotics, vancomycin twice a day, 10 milligrams per mil for 2 weeks. And then we sent CSF like almost every day, I feel like, because ID has weird rules. So for him with his antibiotic therapy, the EVD, we made everyone wear sterile gloves, which normally we don't when they touch it. We're just like, no, just be clean. His head CT improved, he got better, ended up going to a skilled nursing facility for a little bit of rehab, but he got better. Remember, I told you everybody lives. Okay, I have one more. 45-year-old guy, left-sided weakness. GCS was a 10 when he came in. Here's his head CT. Bleh. Right basal ganglia extension into the ventricle, midline shift. So what is next? And I hate that it showed up like that. I'm going to do an EVD, lumbar drain, both, because you know that's my favorite answer. Take him to the OR. Or number 5, ask for a DD prize pack. So a DD prize pack is not necessarily Jesus, Holy Spirit, but it is whomever you pray to. And I always say that to people. I was like, it's whoever you think needs to come help us. Call them and tell them because we need them. So, you know, I say DD prize pack. We really didn't choose DD prize pack, but it was cool. So I put it in there. So here's his head CT. We did take him to the OR. I'm work at a site that was one of the sites for the Enrich trial. So we use the Myriad and suck out blood. That's what we do there. And then took him to the OR. We sucked it out. Of course, his ICPs were super high because he was on neurocritical care and not on SICU. And neurocritical care, we like Precedex, and SICU, you know, they're like all the things where people don't move. So salt bombs, had a sodium like up to 160, had him flat, strapped down to the bed with the sheet and all. And it's lots of things happen. We won't talk about it, but he lived. We sent CSF all the time. He went to a stroke rehab, therefore afterwards. I know. And I'm missing the last one, but that was my favorite one. We had somebody else that came back with meningitis and we just did a lumbar drain. But that's it. Me and my children. Any questions? Yes. Yeah. So it goes into the end of the primary IV tubing. So the end of the primary IV tubing goes to the barotrawl.
The original limitor.
Exactly. Yes. I know. And I'll send it to Diane. I mean, I have a picture. I'm really sorry.
Girl, I can't hook that up.
I know.
You'll have to FaceTime me.
I don't have a video. Why have I never thought about this in 10 years?
TikTok.
Ooh. I'll get my 10-year-old to help me. She can do it. I know.
Any more questions? All right.
What I'm curious to know, since it's an off-label use.
Yeah.
In regards to responsibility, legality, if something malfunctions with the pump, do you have a policy, a procedure written? I mean, like, as far as if you set it up, are you employed by the hospital? What, as far as the nurses, what would be their responsibility if it malfunctioned?
Great question.
So, yeah, so that's the way I'm thinking because of off-label.
So it's a part of the consent when you place a lumbar drain. We actually also have a letter from Alaris Pump. Those are the pumps that we use. That they are aware that we have been doing this since 2000 and whatever, using the pumps in this way. And then when we have to explain to the families, because we do, they're like, but why is it going into a pump and not into something else? It's a lot of patient education.
So does your consent include the Alaris pump?
It does.
Okay, great.
And it says
Okay.
off-label use, not to be used for medications.
Okay. Because that's what I figured as far as if something happened.
Yeah.
You know, how would that go down? Okay, thank you.
You're welcome.
We'll do one more question and then we got to keep going, guys. But you know, a bottle of wine and we'll get some answers later.
I may set up a lumbar drain. You never know.
I'm just wondering, with the use of the Alaris pump and the lumbar drain, are your infection rates higher?
No.
No.
Nope. Infections rate lower, but I think it's because nurse practitioners do it and not residents. Sorry, any physicians in the room, my bad. And then also I have empowered the nurses on my progressive unit that they are the champions of this. And so they like a freaking hawk, like the pump goes off, you have like 4 people. It's almost like a code stroke when people respond to this thing. So, I mean, and that's just the culture that I've created around it. And that's why I personally like put myself in front of them twice a year and talk to them about it and made myself available. Now I'm going to have to do a TikTok, apparently. I know. Thank you, guys.
Thank you, Ebony. All right, now we're going to bring up another Baptist favorite, Lena Osger. And so one of the things I know we get all the time in the middle of the night, and all of these are core stroke measures, when patients can take their aspirin, when they can take their nimodipine, and we fail just about everybody. And so we have our experts maybe help us pass some people.
So for those of you who don't know me, my name's Lena Osger. I've been a speech pathologist for 24 years. I've been at Baptist Medical Center for 14 of those last years. I am the clinical supervisor for speech pathology. It's funny that today I'm going to be talking about post-stroke dysphasia in the acute care setting. Starting from that first contact of the bedside swallow screen all the way through to instrumental swallow assessments. And it is interesting, speech pathologists in general get a little bothered because everyone thinks that we only do swallowing. So I'm doing my profession a dirty today, and I'm only talking about swallowing, so don't tell anyone. I just realized I don't have the clicker to move the slides. Does Ebony have that? Thank you. All right. So how common is dysphagia in the acute care setting? Well, in stroke, I mean. So it depends what study you're looking at, but 37 to 78% of acute strokes, stroke patients are going to have dysphagia. Those patients are shown to be at increased risk of aspiration, and that's associated with an increased rate of pneumonia, higher morbidity, and mortality. Pneumonia risk is greatest in stroke patients who actually aspirate. Patients can have dysphagia, not actually aspirate. There is a wide variety of issues you can have with swallowing. However, 50% of patients who have dysphagia will actually aspirate. 67% of those are going to silently aspirate. So that means 2/3 of them, which is really a huge number. What is silent aspiration? That means that when the food and liquid goes into their airway and heads to their lungs, they do not feel it. There really isn't an outward sign. There can be some subtle signs that people often miss. Very delayed throat clears, voice sounding a little bit wet, or maybe just a change in their vocal quality. With many patients, their dysphagia will resolve or significantly improve in a matter of days to weeks. But with 50% of stroke patients, they still have some degree of persisting dysphagia at 6 months. So it is a very common problem. So why do we need a nursing bedside swallow screen? Patient comes in with a stroke or suspected stroke. That first step to deal with a concern for swallowing is going to be that screen. And we need it because early identification of dysphagia is associated with lower rates of pneumonia. It decreases medical cost and reduces length of stay. Right now, hospital-acquired infections are a hot topic, and pneumonia is one of the biggest. So we want to prevent that. Speech language pathologists are not there 24/7. I have a staff of 10 people to cover 365 days a year. So it's really important that nursing is able to do this screen. And it's created to identify patients who are at risk for dysphagia and aspiration and identify those who need a full assessment by the SLP. And it can allow patients to get those vital medications that they need and start oral intake a little sooner without having to wait for the SLP to see them. So at Baptist, we use the Barnes-Jewish Hospital Stroke Dysphagia Screen. So I'm going to kind of focus on that one. There's lots of tools out there. Research tells us and Joint Commission tells us that we need to use a standardized and validated tool. And this one it's a great screening. The study was done on 225 acute stroke patients. The nurse performed it at the bedside, and then the SLP performed a modified barium swallow on those patients to see if that patient did in fact have dysphagia and aspiration. So this is a highly sensitive screen. Sensitivity and specificity of that screen to detect dysphagia was 94% and 66% respectively. And then sensitivity and specificity to detect aspiration was 95% and 50%. So what does that mean? Sensitivity of a test or a screen shows an individual with a disease as positive. So you want it to be highly sensitive so that you have few false negatives and you're missing fewer patients. The specificity is the ability to designate a person as not having that disease or being negative. So with the low specificity, yes, we will have patients who are going to fail that screen and delay resuming their oral intake when in fact they do have a normal swallow. But we want to make sure we're getting at the people who are having issues. So this is the actual screening tool itself. First thing you're going to look at, does the patient have a GCS less than 13? Why do we do that? Because with a lower level of alertness, impaired cognition, that starts increasing your risk of aspiration. The next one is, does the patient have facial asymmetry and weakness? So why does that matter? That musculature is important for containing food and liquid in the oral cavity, not losing control of it, and potentially losing it to the pharynx where that patient can aspirate. This is one that I see a lot of people end up wanting to pass that patient. I hear, well, it was a very mild droop, or the droop's improved. And so they end up passing the patient. But we really need to avoid that because even though there may only be a mild facial droop, you don't know what's going on in their pharynx and they may be silently aspirating. So you don't want to let that patient through. You want to wait for a speech language pathologist to actually see that patient. Next up is tongue weakness or asymmetry. The tongue is extremely important, not just for orally moving things back, but the tongue base is really critical to clearing out the pharynx so that nothing stays behind in the throat. If someone has lingual weakness, they absolutely have some degree of dysphagia. So we definitely don't want that patient to pass. Palatal asymmetry and weakness. So you're looking at the roof of the mouth, that velum. You want to see it elevate symmetrically. I can't stress how important this is for swallowing. The velum is really hardwired neurologically. It takes a lot to knock it out, but when it does, we see really significant effects with swallowing, and these patients typically are silent aspirators. So those questions, if there are any yes responses, that patient fails and they need to be kept NPO until speech can see them. If all the answers are no, then you're going to move on to the 3-ounce water test, which is that's based on the Yale Swallow protocol. That is another great tool, a screening tool. So the patient has to drink 3 ounces of water in consecutive swallows. They cannot stop. If they stop, then they fail the screen. So why do we do that to the patient? That is because finding the silent aspirator, research has shown it's volume dependent. So a patient can take small sips of liquid. They silently aspirate a little bit. They don't cough. There's no outward sign. You don't catch them. When you have them drink this much, the large volume, you will eventually get a cough. You'll get some response from them. Especially if you get enough in there and it gets in the lungs, that sensory system's going to take over and you're going to see that delayed coughing. And why do we use water? Water has nothing in it to cause infection. That pH level is neutral. We don't want to put food or juice in the patient's lungs. So water is the safe option. So you're going to assess for any signs of aspiration, so throat clearing, coughing, any voice change during that process, and then you need to observe them for at least 1 minute. And that is because you want to look for that delayed response, which is what commonly happens with a silent aspirator. So if the patient passes that screen, they can be put on a diet. If it's okay with the physician, they can have their medications. If the patient fails, then they're kept NPO until the speech pathologist comes to do a clinical bedside swallow eval. So what that entails, I'm not going to list everything because we're going to go into detail, but these are the components of what a speech language pathologist is going to be looking at the bedside with a patient. So the first area, doing a full chart review and past medical history. First thing we're looking at, number 1, is location and size of stroke. Large strokes start increasing a risk of dysphasia and aspiration. And then there's certain strokes that we know tend to be the ones that are prone to silent aspiration. So those are going to be your right CVAs, cerebellar strokes, basal ganglia. When you're getting down into the brainstem, especially a medullary stroke, these patients will have significant dysphagia, and they're probably going to be silent aspirators, so we're very cautious with these. We're also going to look at some other contributing diagnoses. Do they have baseline neurological issues? Do they have Parkinson's? Do they have dementia, myasthenia gravis? We're likely dealing with a patient that has a baseline dysphagia that they're probably unaware of, and now we've had a stroke on top of that. Another big one is head and neck cancer, a history of head and neck cancer. Those patients often have significant swallowing problems well after they've had their treatment. We're looking to see any surgeries the patient has had or baseline dysphagia. So any kind of cervical spine surgeries, esophageal surgeries, gastric bypass, gastric sleeve, those types of surgeries actually will cause problems higher up in the swallow physiology. It can start to affect the pharynx. It also increases their risk they might aspirate reflux. So then we're going to also want to know their baseline diet. Some patients are already modifying their diet at home. You ask them if they have trouble swallowing at baseline and they say no. And when we start talking to them, yes, they did have a baseline problem. Next up, do they have GERD and a history of esophageal dysphagia? That, as I said, is going to impact other phases of swallowing, but also they're at risk to aspirate their stomach contents. And you see that a lot, especially in the ICUs, which is important why we need to follow those head of bed restrictions. And then we're going to talk with the nurse, the doctor, see how that patient's been doing throughout the day. And then we also want to focus in on whether that patient was intubated, for how long and how long they've been extubated. I've looked through all the research. There are no magic numbers or times for when to screen or evaluate a patient after extubation, but you do need to be cautious. We need to avoid doing it 30 minutes after they're extubated, they haven't gotten their sensation back. So they're probably not going to feel something in their airway. They also probably still have some laryngeal edema as well. So next up, we're going to look at just kind of observe the patient and their vital signs. We want to know about their level of alertness. You know, are they drowsy, lethargic? Can they maintain that? Are they waxing and waning? Those sorts of things start increasing a risk of aspiration. Looking at whether they have generalized weakness, the severity of their unilateral weakness. Can they get up to the chair to eat? Are they eating in bed? Can they feed themselves, or are they going to be dependent for feeding? These sorts of things are really important. Cognitive impairment as well starts increasing risks of aspiration. We do look at their communication, whether that patient's aphasic. I do hear a lot, well, you can't assess their swallowing because they can't follow commands. They're globally aphasic. And for our assessments, we can. They don't have to follow our commands. And a lot of times globally aphasic patients can actually be on diets. We're going to look at their baseline vocal quality. We'll talk in a minute about that, but it's very important for swallowing. Those are the same muscles that you use to swallow that you use to make your voice. So if they've got dysphonia, so a voice problem, that starts increasing our risk of dysphagia and aspiration. We're going to look at their vital signs, heart rate, respiratory rate, their O2 saturation, and also what's their level of O2 need. Patients who are requiring a mask, whether that be a Veni mask, non-rebreather, they're not appropriate for swallowing. Even patients who don't have muscular weakness or a true dysphagia are at risk for aspiration when their respiratory status is compromised. High flow O2, we're seeing that a lot now in stroke patients since the COVID epidemic. Research tells us those patients, the high flow does negatively impact their swallow function because of the CPAP effect, and they are typically at a higher risk for silent aspiration. So we will see those patients sometimes depending on how they're doing, but we're going to want to do an instrumental swallowing assessment. And we're going to look at secretion management. If they can't manage their secretions, they're not ready for eating and drinking anything else. We do sometimes get requests to see patients who have nasal trumpets in, and that is a definite hard no. The nasal trumpet, they need it because they're not managing their secretions. The other issue is the nasal trumpet goes far down. It inhibits velopharyngeal closure, so that patient's going to have a lot of pharyngeal residues. It also inhibits epiglottic inversion. There's a good chance their airway is actually being held open. So when they swallow things, they're going to aspirate. So typically we wait for those patients not to need that any longer. And so next up, we're moving on to, we do a cranial nerve assessment. These are the cranial nerves that are important for swallowing: trigeminal, facial, glossopharyngeal, vagus, spinal accessory, and hypoglossal. Why are they important? Because they supply that innervation to sensory and motor function for muscles and areas critical for swallowing. We then do an oral mech examination where we're assessing speech and non-speech movements. We're looking at their dentition, their oral care. We look at diadochokinesis, which is looking at the rate, the regularity, and motor planning of repetitive movements of the oral articulators. So we have the patient actually repeat pa 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 ta 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 ka 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 ka. Then we make them put it together. Pataka, 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 pataka. It tells us a lot about how that system is functioning. So far we've done all these things to look at their swallowing, and we haven't even given them anything to eat yet. So why are all these things important? This is why it's important. This first study about this actually came out when I was in grad school, and it was a game changer and kind of mind-blowing in our field. So what we noticed was that there are patients who have aspiration events and they don't get pneumonia. So who is it? How can we predict what patient's going to end up with the aspiration pneumonia? And that's what this study looked at. And what it found was that dysphagia and aspiration was concluded to be an important risk for aspiration pneumonia, but generally it wasn't sufficient to cause pneumonia unless there were other risk factors present. And so if you look, you would think that dysphagia and aspiration would be high on the list. It's not. Aspiration's number 11, and we don't get to dysphagia until 12 when we're talking about a pharyngeal delay, excess residue. So what was the biggest predictor of getting aspiration pneumonia was dependence for feeding. And so how many of our stroke patients are dependent for that? Swallowing starts cognitively by you seeing the plate in front of you, taking that spoon, grabbing the cup, and bringing it to your mouth. That starts a whole process in your brain telling you, I'm about to swallow, I need to get ready. So with this, that's taken away. Somebody else is doing it for you. And then who's feeding you? Are they following strict safe swallow guidelines? You know, it's healthcare's super busy. People are in a hurry, and you start to feed that patient, and sometimes you start feeding too fast, or you give a big bite, you give big sips. And that's what's really going to end up causing that aspiration pneumonia. The next two, dependent for oral care and number of decayed teeth, I'll talk about together. That all comes down to oral care. Can't express how important that is. If there's bacteria in the mouth, they're going to aspirate it, and that's going to cause an aspiration pneumonia. We have patients who aren't even eating that end up with aspiration pneumonia. This is often the reason why. And dependence for oral care, they're not doing it themselves. Somebody else has to do it. And are we doing it frequently? Is it thorough enough? And then the other thing is after meals. Oral care is important right after to make sure there's nothing hiding, even way down here behind the teeth. You lay that patient down to take a nap and they can aspirate that. Presence of tube feeding. So whether that be an NG tube or a PEG tube, you can still aspirate. You can reflux that material up. So it's important, you know, that those patients not be laid flat in bed because they will aspirate their tube feed. Also, like at nighttime, they need to be sleeping elevated. Large bore NG tubes, especially in a patient with dysphagia, can lead to actually more aspiration. It allows more of those secretions to actually get into their airway. More than one medical diagnosis. So the sicker you are, more likely you are to get aspiration pneumonia. Number of medications prescribed. If you're a current smoker, another big one is reduced activity level. You know, our stroke patients are not getting up and walking around. The act of standing up and moving does help the lungs actually clear out any material you've aspirated. We have head and neck cancer patients who we know aspirate every meal and they never get pneumonia. It's because they're up, they're moving around, they have a strong cough reflex. So they don't actually develop that pneumonia. And then here we are again with GERD, reflux and esophageal dysmotility. That definitely, they can aspirate that material coming back up. And if you do have a patient that has these issues, when you're giving medications, you want to give some additional presentations after that maybe first bite of crushed meds and applesauce, because it needs to get not just through here, but down the esophagus into the stomach. All right. So next up, just another little study that found some important things. This is the study, the aspiration in patients with acute stroke, that found that high risk of silent aspiration, that 2/3 of them aspirate. It also found that there were 6 things that if a patient had, they were the best predictors for that patient to be a silent aspirator. And that was dysphonia, dysarthria, an abnormal gag reflex, an abnormal volitional cough, so just telling the patient to cough, and coughing after the swallow during assessment, and a voice change. The 2 best predictors were an abnormal volitional cough and then coughing with swallow on examination. So now the speech language pathologist is finally getting to the point of giving them something to eat and drink. So PO trials, we can give ice chips, thin liquids, thickened liquids, pudding, solid foods, semi-solids. And what we're going to give that patient depends on the patient, how they're doing. If they have a profound dysphagia, we're not going to go beyond ice chips. It all depends on how they're functioning. We're going to assess their oral, their pharyngeal, and their esophageal phase of swallow. Oral phase, are they able to contain the bolus? Are they losing control of it anteriorly? Is it falling into the lateral sulcus? Are there residues after they swallow? Do they know they're there, and are they clearing them? The pharyngeal phase, we're looking to see if that patient has a delayed pharyngeal swallow. For this, at bedside, we can't really know for sure until we look in there. So it's more whether we're suspecting that. The presence or the absence of hyolaryngeal elevation, that's extremely important for swallowing. When we swallow, our larynx moves up and forward. That helps seal off the airway so that nothing gets in it. It helps our epiglottis flip over, covering our airway, and it helps clear out the pharynx so that nothing stays behind. The swallow is very quick. It needs to be completed in 1 second. If it's taking longer than that, we know we have issues. Or if we're seeing multiple swallows as that patient's trying to clear things out, then we get concerned that they're going to have significant residues there that they can't get rid of. And of course, we're going to look for signs of aspiration. Is the patient coughing, clearing their throat? Are we hearing a wet voice? Are we hearing just a subtle change in their vocal quality? The esophageal phase, sometimes we'll see people having a lot of belching. They'll complain of food sticking in the chest. We'll look at basic compensatory strategies, small bites, sips, possibly placing the bolus on the strong side. We do not look at chin tucks or head turns at the bedside. That has been found, research has shown that while a chin tuck helps some people, it will cause others to aspirate. And I've seen that under fluoro. So don't ever tell your patient, everyone always wants to say, tuck your chin, tuck your chin. And I know everyone means well, but don't tell your patients that unless we've done a modified barium swallow and we've recommended it. So then we're going to come up with some impressions. Are we going to start them on a diet? Do they need to stay NPO? And do we need an alternative means of nutrition? And then we're going to decide whether that patient needs an instrumental evaluation. So anyone who is suspected of having had, if they have pharyngeal dysphagia, requires an instrumental assessment. We don't have X-ray vision. We are taking our best guess at the bedside. So the only way to rule out silent aspiration also is going to be with instrumental assessment. And the gold standard is going to be the modified barium swallow and the FEES, which is fiber optic endoscopic evaluation of swallowing. So the first one we're going to talk about is the modified barium swallow study. That's completed in radiology in conjunction with radiology staff. So either a radiologist, a PA, it may just be a tech providing us fluoro. We give different textures with barium sulfate. We do use Veribar, which that is the best, that's best practice to use. It is standardized, it's validated for MBS studies, and it's FDA approved. Barium is inert and it does not harm the pulmonary health if they do aspirate it. So we do this in a standardized chair up at 90 degrees, unless we're trying some different positioning techniques. And we can also do it standing, but of course our stroke patients usually can't do that. We are looking at the anatomy and physiology. We do focus in obviously on laryngeal penetration and aspiration. And this is where we're going to look at the effect of evidence-based frontline interventions like the chin tuck, the head turn maneuver, to see if it in fact helps that patient. We're going to come up, it's critical to figuring out the diet recommendations and also treatment planning, what treatment modalities to assist that patient in getting better, especially when they're going to rehab. So with the modified barium swallow, it is a short period of time. We're going to take that diagnostic information and combine it with our clinical eval, our patient history, and our clinician judgment to come up with a swallowing diagnosis for them. Research tells us we do have to use standardized, reliable, and valid protocols for acquiring and reviewing video fluoroscopic images. And we do have to consider risk for aspiration events. So if a patient can't manage their secretions, we're not going to bring them downstairs and put a bunch of barium in their lungs. We're not going to do that to them. The other thing is radiation exposure. Although this test is found to be, it's low exposure compared to other types of radiological testing. I'm going to talk a little bit about the modified barium swallow study impairment profile, or the MBS-IMP. It's what we use at Baptist. It was developed by Dr. Bonnie Martin Harris. She got a lot of the experts together and they figured out the best physiologic components of swallowing for us to look at from the literature. The components are grouped into functional domains or phases. So that's going to be your oral, pharyngeal, and esophageal phase. And there's 17 components that we have to look at. Swallowing is actually pretty complex, and they're distributed across those 3 domains. And this is a certification course that we have to renew every 5 years. So I won't go through all of these, but these are the oral and pharyngeal domains. These are all the different areas that we're looking at. And swallowing is not just about muscle strength. There are sensory components to it, and it's also about pressure. The bolus, anything that you're swallowing, we call a bolus, and there's positive pressure behind it being created by that musculature, and that moves it back, and the bolus is moving towards negative pressure in the esophagus. So all of those things are very, very important. When we put something in our mouth, our tongues, once we masticate it, we manipulate it into a bolus we can swallow. That tongue moves up, hits the roof of your mouth. It's almost a wave motion that moves back, sending that bolus down into the pharynx. We're looking at what level in the throat are you initiating your swallow and starting that hyolaryngeal excursion moving up. The velopharyngeal port, the soft palate's important because when we swallow, that moves up and back. It hits our pharyngeal wall to prevent anything from going into our nose. Our pharyngeal constrictors then squeeze together to move everything down. That upper esophageal sphincter, or what we call pharyngoesophageal segment, is always closed. It's got to relax and open to let everything go through. I'm going to bring out one of those components to talk to you because I know that's what everyone's interested in. And that's laryngeal vestibular closure. So this is where we're looking at laryngeal penetration and aspiration. So what is laryngeal penetration? We have what's called flash or transient, which means what you're swallowing starts to go into your airway, but as you complete your swallow, you squeeze that material out and nothing remains. That is actually a variant of normal, especially as we age. A patient can have shallow or deep penetration. So shallow goes in a little bit into the top of the laryngeal vestibule. Deep can actually go down all the way to the level of the vocal cords. What is aspiration? That means that the food or liquid's gone below the vocal cords. And so then we want to know, does the patient sense the aspiration? Are they coughing, or is it silent? Can they clear it? If they spontaneously clear it on their own with a cough or a secondary swallow, that can be normal in an aging population. It's not with a stroke patient who can't get it out. If it stays in there, that patient's going to eventually aspirate. Then we want to know, why did it happen? That's going to help with our treatment planning. There are lots of different reasons, whether it be a delayed swallow. Sometimes they aspirate after the swallow because they can't clear their throat and those residues fall in after the fact. And then we also look at, we use the penetration aspiration scale, which is a standardized tool. 0 means nothing got in the airway. All the way down to 8 means they silently aspirated and they couldn't clear it. The esophageal domain It's the only thing we look at is whether or not the esophagus cleared. It's more of a screening. We don't diagnose that area, but we do know that poor esophageal clearance affects the oral pharyngeal swallow. So it's important that we look at it. And if there are issues, we refer them to GI for further testing. And so based on what we see on a modified barium swallow, we're going to make the appropriate diet recommendations and treatment planning. So here is, hopefully this will work. This is not a full modified barium swallow, but it is just one swallow. That first one is normal. So you see nothing went in the airway, everything's cleared out. And if you watch the abnormal swallow, very delayed, it's all the way down in the throat, and now hardly anything's going into the esophagus, it's staying in the throat, and they grossly aspirated that. And if you'll notice, the patient's not coughing. The patient didn't feel any of that, and that was really bad aspiration. They don't usually all look like that. A lot of times it's a lot less going in there, but that one is significant. So that's the kind of patient that you see at the bedside, and it looks like they're swallowing just fine, when in fact, a lot of it's going in their airway. And then our next instrumental swallowing assessment is the fees. So this is where we use a flexible endoscope. It's passed through the nair. We go down into the pharynx, so we have a superior view. We're looking down, and we can view the pharynx and the larynx during the swallow. And this is completed with patient voicing, performing non-speech tasks, and we have the patient eat and drink different consistencies. We do put a dye on it, either blue, green, or white, so that we have better visualization. Indications for fees, why would we do this? If we want direct visualization of the tissues, if we're concerned that the patient has a dysphonia and we're concerned about a vocal cord being paralyzed, we can actually see vocal fold mobility. It's good with assessing velopharyngeal insufficiency. MBS might not be available. They're too busy. The equipment's not there, or a patient's unstable for transfer if they're on high flow. Patient may not be able to fit. We might not be able to see with fluoroscopy, depending on their body habitus. Sometimes the shoulders are too high and we can't see into the throat. And then if you can't have radiation. So if someone was pregnant, this would be a better option for them. Also concern for secretion management. When I mentioned with the MBS, we may not be able to give someone who's not managing secretions barium. We can actually dye their saliva. We can see their secretions actually going into the airway. So this is kind of a rundown of what we do. We go transnasally along the floor of the nasal passage. We're going to assess velopharyngeal efficiency as we're moving back. Then we go down. We're going to give them different PO trials and assess airway violation and response, and then formulating, again, diet, nutrition route, and a plan. The benefit for fees, it's portable. We don't need a physician or a PA or a tech. It's just the SLP doing it. There's no radiation exposure and no time limitations. There's also no issue with medication. Barium is considered a medication. And like if someone has a GI bleed, they can't have it. Limitations is we can't see the oral and the pharyngeal phase of swallow. And there's a whiteout during the swallow. When that patient swallows and the epiglottis covers the airway, we can't see anything. There are some possible complications, of course, discomfort, nose bleeding, vomiting, gagging, mucosal perforation, and laryngospasm. Some special considerations if someone's had a recent history of facial or nasal trauma. We don't want to scope them if they are on bleeding precautions. We're not going to do that. Severe movement disorder. They can't keep still to pass a scope. A severely agitated patient. We can't scope cardiac instability, or if they're prone to severe laryngospasm, that scope can actually trigger one. And then I don't have a video, I apologize, but this is an endoscopic view of the hypopharynx. You can see at the bottom of the screen that kind of curved lighter section, that's the top of the epiglottis. And the V-shaped area there, those are your two vocal cords. The two bumps towards the top next to the vocal cords are the arytenoid cartilages. And then that at the top of the screen is your pharyngeal wall. And there are a few pictures here. If you look at the one all the way to the left, that green stuff is actually what we've given them to eat and drink. And that patient they have laryngeal penetration. The green stuff is actually in the laryngeal vestibule, and you can see it's on the vocal cord. That next picture is just showing some inflammation. The third picture, that right vocal cord looks like it's probably paralyzed. It's not moving. And the last picture is just an NG tube actually going into the esophagus. And so that's all I've got. Any questions?
I have never been more grateful to have speech pathology.
Who's talking? There you are.
The voice of God.
Sorry, I know that was a lot of information, but we love our swallowing.
Any questions, guys? Okay, luckily this is a local expert, so we'll be able to ask questions in the future. So this is our last talk before break is going to be Shannon. So if anybody's planning on sneaking out at break, there are going to be evaluations in the back, and we're just asking if you could please fill them out. But we encourage you to stay. So this goes till 5:30, and then we have a reception after, which is going to be a lot of fun. But it's my pleasure to introduce Shannon Terrell, who was one of my first mentors and one of the smartest people that I know. She works with us in the neuro ICU at Baptist. She's very humbly shaking her head, but it's true. You'll find out in a minute. And she's going to go through some neuroimaging with us. Cannot.
Now you're going to.
Give it up. If I put my head down, but I don't want to do that because I might aspirate when I swallow. Okay, now where we go. Okay. And I might need some instructions on this, so. Okay. So what I want to tell Ebony, she probably has a very good idea to make a lot of money if she could patent a medical device. But now that you've told the whole room and you're about to put it out there on social media, you might need to hurry up. I think it's Innovations 2024. Very original. But I can go ahead and start telling you what I'm going to be talking about today, and that's going to be neuroimaging in acute stroke, but not necessarily just the acute ischemic stroke patient, but what are we looking at as patients come in? So we're going to go through a case, and we'll kind of talk about that patient and what happens with them throughout their course as they come into the hospital. So. Let's see if they found it yet. I'm not quite as good as Diane. I can't really just wing it. And since this is kind of about imaging and stuff, we'll need that. But I can go ahead and talk about my objectives. I'll go ahead and do that. So the objectives are going to be basically going through some imaging. But looking at the process of the code stroke and the decision-making as it's related to like neuroimaging, going from the notification from EMS forward. We're going to look at the different stroke syndromes and what we can rule out by imaging, looking at ischemic strokes, hemorrhagic strokes, subarachnoid hemorrhage, AVMs, looking at subdurals, epidurals, and how they relate, and cerebral venous sinus thrombosis, which is actually a form of stroke, discussing some of the imaging, including CTA, CTV, dual energy CT, MRI, the role that AI plays. I know this sounds like a lot.
I have an idea while we wait for this to work.
Okay.
Come join me in the chairs.
Oh, this almost scares me.
So Shannon, if I have a patient that presents acutely and we have no idea what's going on, what would be the appropriate test and why?
If you, yeah, I was going to say, if you have a patient, you don't know what's going on. Yes.
Yeah, let's just say they come, they're all droopy, they're not really talking.
They're all droopy and they're not talking.
Yeah, unlike us.
I was going to say, I think it really depends on the scenario of the situation that we're in. You know, are there drugs involved? Is this, you know, I need more story.
Would that change if what you would do if there were drugs involved?
If the setting that I'm in is the ER, I mean, if my exam necessitates getting a CAT scan, I'm going to get that. So that would be the first thing.
So why would you start with just a regular non-contrast CAT scan? Why would we start with that?
Because you're trying to rule out the major things such as bleeding, a stroke that you can see, any kind of tumors or anything that could be causing an altered level of consciousness.
And so let's say in our patient that the CAT scan is negative. Because I would say half of our CAT scans are negative, right?
Yeah. So again, these are all always nice to know a little bit more of the story. Like, did this patient just come from dialysis?
They can't talk. Somebody just found them. They're all droopy and not talking.
If they were found
at 2 a.m., it's Tuesday night. This is
I'd
how it is.
probably give the patient Narcan also before they got to CT.
I think you probably would.
Yes.
At 2 a.m., that sounds appropriate.
Yes.
So, but if they have that focal motor weakness that you could localize and CAT scan's negative, would you keep going? Would you code stroke this?
So if they have a focal motor weakness, then yes, I would certainly code stroke it.
What does that even mean? What is focal motor? Does everybody here know focal motor?
So basically, that's going to mean if you have something that is focal, that you can localize it to an area of the brain. So like if you're not moving your right arm and your right leg, then you can localize that to like the left MCA or possibly even brainstem.
This sounds terrible. All right. So what test would you get now? So you got the non-con. We're saying we're code stroking them. What does that even mean? Like what images are part of a code stroke process?
So we're going to talk about this if I talk about it now. So part of the imaging process would be getting a CT angio, and which is basically going to look at the arterial vasculature. And then we're going to do a perfusion study and look at whether there's any flow deficits. Did you find? Okay.
I'd really like to
Okay, got
see
it.
some pictures if you don't.
Okay.
Yeah. Okay.
I almost feel like Diane planned that. Nothing like putting you on the spot when you're already like kind of nervous, right? That's the icebreaker. Okay, so now I got to find my clicker where I put it. Okay, so my disclosures, I have none. I work at Baptist. That's my only disclosure. We already talked about my objectives. Okay, so this is our case. So I'm going to kind of go through it, and we will talk about it as we go. So we have this patient. They were called a code stroke by EMS. Usually, you know, they say, oh, we're 10 minutes out. They give you a notification. They said they're a lambda 5. What does that mean? So most of you are probably not pre-hospital people. You're in the hospital, you're not really familiar with that. So here we have our little nifty, app that you can put in all the information. So in this patient, they said they were last known well around 8 o'clock in the morning, and they are alert. They're nonverbal. They're not following commands. They have a right facial droop. The right side is paretic. They have decreased sensation on the right, a left gaze, neglecting the right side. So like Daniel was saying, what does localization mean? What does that mean as focal? So this patient has what we would consider our focal deficits. So, and here you have the LAMS, which basically comes out to they have a facial droop, they have an arm drift, and they have no grip strength. So that gives them the LAMS of 5. So the patient is examined by the ED physician and a code stroke is called. So the ER kind of screens these because sometimes EMS gets a little excited and will call things that aren't necessarily a stroke, but that's good because it's better to cast a wide net and then not. So there are some that will get missed because of that. Sorry, I will have to intermittently take sips of water. Okay, so this patient, a code stroke is called by the ED physician. They go straight to the CAT scan, and a few minutes later, because we're walking all the way over from Weaver Tower to the ED, and it's a long walk, and they beat us to CT. When we get there, the CT is already in progress. So the APP or the physician or both of us will meet there. After the CT is done, we're kind of reviewing it as it's scanning through, looking, for any obvious hemorrhage or anything. And then we will go in and examine the patient. So in this patient, we are going to give them an NIH of 23. And this is actually kind of a picture of what we would do on our phone that we can send out to the group. So when we have an NIH of 23, we're going to go ahead and send this out on our communication device, which we use Telemedic, so that we can notify the stroke team, give them a heads up, hey, there is a high NIH patient, and it is likely that they could be a candidate for a thrombectomy. So this patient, they're not able to provide any information. So we're going to have to contact the family to get information, such as what medications they're taking, which in this one I have here, they were taking aspirin, but no anticoagulation. And then I'm going to forward that information of the phone number on to the endovascular team while we are continuing. Okay, so going on, so we get their CT. And remember, as you're in CT, it's kind of hard to be able to evaluate as it's running really fast, but you can kind of see any major hemorrhages. So you'll go ahead and go in and look at the patient, and then we're going to go back and look at the study again. So in this patient, in this CAT scan, do you see anything on that looks concerning just on this one slide? What do you see? I heard somebody over here, but I can't. Yeah, there may be a little hyperdense there on the left. Anything else that you see? So that right there. So in the correct setting, it's not an always, but this is a hyperdense sign, and that can be seen in any major large vessel, not always seen. Sometimes you think you see it and it's not really there. You kind of look for the symmetry. Does the other side have it? And I know you can't necessarily maybe see might not be completely lined up. It has a sensitivity of like 30 to 67%. Whoops, I guess I should. 30 to 67%. But when you do have it, it's pretty specific. It's often seen in what's called a red clot or a clot that's considered to be cardioembolic. But a couple of pitfalls, it can be with elevated hemoglobin, you can see it, or if they've had a recent contrasted study and they have not cleared all that contrast out, you may see that and think that it's something it's not. Okay, so going on to talking about other hyperdense signs. So this is a basilar artery. So when you look at this, it's a little hard to see, but right there in the center, you see that it's kind of a bright white. And I know I'm not showing you all of the images. If you stick around for the next 2 days, I promise you're going to see a lot of imaging. And then on the next patient, it can be even harder to see sometimes when you get a lot of scatter, especially from in the cerebellum, your posterior circulation. So it's just important to look at that. So in your patient, because sometimes patients can have posterior circulation strokes and mimic. I recently had one that I really thought was a left MCA coming in, and it turned out it was a basilar thrombus. So it's important to take a look at both areas. Okay, so excuse me. All right, so back to our case, the CT head was completed. There was no hemorrhage. The hyperdense sign is seen on the CAT scan. The patient's going to be evaluated for T&K. We know the time of onset, it was less than an hour at this point, so we're good there. The medications, he was not on any anticoagulation according to the family, and he was only on aspirin. He's no bleeding issues, no recent surgeries. He doesn't have any history of cerebral amyloid or anything like that. So the family's called, they provide the information. We review the case with the neurologist, the pharmacist, and we're going to consider giving this patient T&K. So would you give this patient T&K? Is there anything that would maybe keep you from giving it? So I know I didn't show you the imaging in its entirety. If you obviously see that there is a large area of hypodensity that is concerning for an acute stroke, you may consider not giving TPA or T&K, because that means this is obviously a little more established. But it doesn't necessarily mean that they would be outside the realm of being able to have other intervention, endovascular intervention. So just keep that in mind. In our case, for right now, this patient has a hyperdense MCA, and they are a candidate for T&K, and there's no contraindications that I see. So we're going to give them T&K, and we're going to go ahead and continue on with our workup. Okay, so why did we do the CT? What's the reason that we're doing a CT? Yeah, ruling out blood. I mean, essentially, that is the only reason that you do the CAT scan. So first, before we talk more about stroke, we're going to talk about when would thrombolytics not be indicated, other than the things that we already talked about. What imaging findings are going to keep us from giving this patient T&K? So intracranial hemorrhage, that's the obvious contraindication to giving T&K. So all bleeds that are spontaneous, that are not traumatic, are really included under the stroke umbrella, okay? Some of them you don't think of as stroke, but everything that is listed here essentially is considered, and that includes also not listed here is a cerebral venous sinus thrombosis is actually considered to be a form of stroke. So you have multiple areas that can be involved: basal ganglia, thalamic, lobar hemorrhages, pontine hemorrhages, and other midbrain hemorrhages, cerebellar, epidural, which is not necessarily considered a stroke if there's underlying trauma. Then you have subdural, subarachnoid, intraventricular hemorrhages. All of these do fall under that stroke window. So we're going to go through and just kind of look at a couple of the different types of hemorrhages and what we will see with those. So basal ganglia hemorrhages are essentially the most common type of hemorrhage that we see. They are occurring spontaneously. There are about 65% of hemorrhages that are seen. They're usually non-surgical. They may extend into the ventricular system, but often these are smaller vessels, and they may stay contained right there. In patients that are very hypertensive, they do, of course, have the risk of expanding. So certainly important to address these patients if they're on anticoagulation or low platelets or anything that would precipitate further bleeding. All right, so then we have thalamic hemorrhages, okay, pretty much along the same lines, usually hypertensive, smaller vessels. Basically, they can have intraventricular hemorrhages also. And as you can see in here, do I have a pointer? Okay, yeah. So this right here is blood in the ventricular system. Not very much blood, but depending on how much blood you may have in the ventricles, they may require Ebony to come visit and place an EVD, okay? These patients will typically not have a lumbar drain. Why? Well, the risk if they have a lot of blood in the ventricles is they can obstruct the third ventricle and the fourth ventricle. And if that is obstructed and you put a lumbar drain in, it's still not going to go anywhere. So that's why they will require a EVD. Whoops. Okay, so cerebellar hemorrhage. So usually these patients present with pretty severe nausea, vomiting, dizziness, headaches, mostly the nausea and vomiting. That's what mostly bothers these patients the most. If they come in right after the bleed happens. So the biggest risk that we see with these patients is that they can develop hydrocephalus. Okay, again, these patients may need an EVD because of obstruction of the fourth ventricle, which you may see in this patient here. You don't see a fourth ventricle, which would be an area where CSF could flow through in this area, which would show up as being dark. So that is lacking. So this patient is a very high risk to develop obstructive hydrocephalus. So the other risk with these patients is that they can have herniation. It can be upward or it can be downward with tonsillar herniation. So, you know, if we put an EVD in this patient, but we don't actually take them to the operating room and do a posterior fossa decompression, they're at really an even higher risk potentially for upward herniation if we're not really careful about that drain. Because if you overdrain them, then it releases too much pressure and that can allow it to herniate upward with the path of least resistance, basically. So it's better to be proactive than reactive in these patients, and go ahead and have your neurosurgery colleagues evaluate them for decompression early on so that we don't have the complications that can be seen. Okay, so next, pontine hemorrhage. So the reason I specifically mentioned this is because it basically has the worst prognosis. It's about 6 to 10% of all intracranial hemorrhages actually originate in the brainstem, but most of those 60 to 80% of them are pontine hemorrhages. They're usually hypertensive related. They usually have a sudden onset with a rapid neurologic deterioration, progressing even to coma before they can even sometimes get to the hospital. And these, unfortunately, there's not a lot you can do for these patients, and they do have the worst morbidity and mortality is about 30 to 90%. It's very unfortunate, and hopefully at some point we will have something that we can offer these patients. And this is just basically kind of a picture to give you the idea of exactly where the pons is as part of the brainstem. All right, so lobar hemorrhages. So this kind of encompasses a lot. Basically, it is anything that is cortical in the brain. They can be hypertensive with severe hypertension or maybe with drug use. They could be because the patient has cerebral amyloid angiopathy, if they have any prior history of bleeding, if they are coagulopathic, or maybe they have low platelets from some other, for some other reason, liver disease. They may have an underlying tumor there with history of malignancy. So with these patients, we need to rule out any kind of vascular abnormality. Could be like cavernoma, an AVM, aneurysms, vasculitis, even cerebral venous sinus thrombosis can cause hemorrhages like this. They may or may not be a surgical candidate depending on their symptoms, because believe it or not, you can have a patient like this that has this bleed that looks like it's kind of awful, but their exam may be focal, but maybe not too bad. So in this patient specifically, they actually were found to have an AVM. All right, so moving on now to AVM, which we kind of just talked about. What is an AVM? So basically there is a tangle of blood vessels that connects arteries and veins in the brain. And this can be a high risk for an area to bleed, not necessarily with that's hypertension related. These hemorrhages are typically cortical, or like I said, on the kind of periphery of the brain. They're often seen in younger patients. They will always need to get CT angiography imaging with any suspicion of any lobar hemorrhages, like we previously said. These patients will also need to go on and with our neurosurgery colleagues and have a formal cerebral angiogram so that they can be evaluated for possible embolization of the vessels, or just to kind of determine where the vessels lead. And in the one picture there in the background, this is a formal cerebral angiography, and then you can see the area where there is what's called a nidus, which is essentially the area where all the vessels kind of conglomerate together. All right, so next we're going to have subarachnoid hemorrhage, everybody's favorite, right? So typically this is something that is associated with a thunderclap headache, but not always. Okay, some of these patients may have had kind of a bad headache, but you know, they took some Tylenol, they laid down, they felt a little bit better. It maybe lasted for hours to a day, and then they basically go about their business and they feel a little bit better. And then a few days later, suddenly they have the real hemorrhage that maybe looks like this, and they have an acute deterioration, or maybe it's just like suddenly a worsened headache. And that can be the sentinel event was the initial headache they had, and then they can rebleed. So just be aware that it's not always that typical thunderclap headache. So aneurysmal subarachnoid hemorrhages typically have this star pattern, which I'm sure you guys have seen many times working in a comprehensive stroke center, but that is the typical star sign that you will see. And they will also have blood in the sylvian fissures, which don't necessarily have the picture of that. But if we go on to the next one, this would be a perimesencephalic subarachnoid hemorrhage, okay? So they may still have blood there in the sellar cistern, but it's not going to be quite as bad as the aneurysm rupture. Typically, these patients, they don't have the same morbidity and mortality that you're going to see with the aneurysmal subarachnoid hemorrhages. They're still going to need to go on to get a cerebral angiogram, okay, because you need to still rule out. It could still be that there's an aneurysm and it just didn't bleed a lot, but they do need to have that ruled out. And then trauma. So trauma typically has a different pattern, okay? You're not necessarily going to see the blood in the cisterns like that, but you can. And if you do, this patient definitely needs to have imaging to rule out that they did not have an aneurysm rupture that caused whatever trauma they had. You know, if they were a car in a single car driving down the road and you have an aneurysm rupture, you probably will crash your car. So I have seen patients before that have had aneurysms rupture, had something like this happen, and it got missed because it was presumed to be traumatic. So, and unfortunately, some of those patients did not have good outcomes. So very important to, know that traumatic subarachnoid hemorrhages look differently, but always you're going to want to make sure that you evaluate them for that. But the picture that you see here is kind of a typical, this would be a patient who had traumatic subarachnoid hemorrhage. And whoops, sorry, how do I go back? Yeah, okay. So when you look here around the sulci, you see that there's blood there, but also something that kind of tells you it's trauma. You can see here on the side, they kind of have some swelling, some contusion there. You can see it on this side, little contusion here. They've got blood in the sulci around. And then they may, have other types of brain injury as well. There might be a subdural or a little epidural or some frontal contusions or something that's maybe not seen in this photo. Something important to remember in your subarachnoid hemorrhage patients is that they may actually have a negative CT. Okay, so you may not see anything, but they had that typical presentation of, well, a few days ago I had the worst headache. It's just kind of lingering. It's not gone away. You do a CAT scan and you see nothing. It looks pretty normal. If that patient has a story that seems like it could potentially be a subarachnoid hemorrhage, especially if they have any kind of focal deficits, any visual field deficits, any eye movement issues, then that patient needs to get a lumbar puncture to rule out an actual subarachnoid hemorrhage. Or the other option would be an MRI. And then this basically just talks about, and again, if you're here for the next couple of days, we're going to go over this a lot, but the different types of aneurysms that you're going to see, the fusiform here and the saccular, and of course, that's a normal blood vessel. All right, then subdural hematoma. So there's a lot of patients that seem to come in with these spontaneous subdurals, and I always think to myself, there's got to be something that's causing it, right? I mean, people are just walking around and they just spontaneously happen, but I guess they do. A lot of these patients may be on anticoagulation. They're often elderly. You don't often see young people come in with these. They may be on antiplatelets. Some of them are on antiplatelets and anticoagulation. They can be acute, they can be chronic. In this patient, I want you to pay kind of attention to, like, if you look at the midline here and see, you know, did they have any midline shift? This is not a very big subdural, but when we go to the next patient, it's a little bit bigger, but what we see here is kind of this mixed density. You've got this hypodense fluid there, and then a little bit brighter here, that's a little bit more hyperdense. So the hypodense is going to be, it's going to be older blood, okay? And then what's brighter here, and even this is like not that bright, so maybe it's subacute, but it's more acute than the dark areas. And if you look at this patient, like the midline shift, there's really not a lot of midline shift, and it looks like there's actually a pretty decent amount of blood there. Why do you think that why don't they have more of a midline shift? Yeah, exactly. So this is probably an older patient, like we commonly see these in. And so they can accommodate this. And that's why these patients come in with these huge subdurals that you're like, how is this person still walking and functioning? It is pretty surprising, but yes, their brains can definitely accommodate it. So, all right. So, and yeah, I asked that question already. So. All right, so this is an epidural hematoma. Now, typically epidural hematomas are not going to be considered stroke. It is very rare. You don't really see them happening outside of trauma. And if you look at this patient's CAT scan, you can see that they have some thickening there. So they have been hit in the head or something has happened over here. You can see outside of the skull, that area. So these are almost always traumatic. You really need to have a story, but you don't always, like Diane was asking, you found him down at the bus stop, okay? So those patients often are going to be traumatic. Maybe he got hit by the bus. But also want to look at epidurals and subdurals. A lot of people have trouble differentiating which one is which, okay? So the picture can actually tell us, oh, I said that in there, that what it is. So we're going to talk about lemons and bananas with subdurals and epidurals, okay? Does anyone have any idea what an epidural would have to do with a banana or a lemon? So this is a way to help you remember, okay? An epidural is a lemon, all right? When you look at the imaging, oh, it doesn't want to go back, okay. So basically it's more rounded, okay? So now we're going to go on and we're going to talk about subdurals and why they're bananas. It's more of a banana shape, okay? So if you have trouble differentiating those, think about it. And if you think about lemon pie, I would never remember this, okay? But lemon pie, the pie has the EPI in it, okay? And bananas, if you look at subdural B starts with banana. So if you can just remember that one, I would probably remember that one more easily. Okay, so venous sinus thrombosis. So this is, like I said, it's less common. You will see these patients still present with stroke-like symptoms, though. They may have headache, though. They may also present with seizures. They may have altered mental status. They may be dehydrated. They may be older. They may be younger. One of the most common groups of patients that may have this is postpartum or pregnant. So those patients are at a higher risk for it. So the imaging typically in this, it may show areas of ischemia or areas of hemorrhage, or it may show both, which may confuse your picture a little bit. But typically it doesn't follow any certain vascular distribution. So it may not look like it's an MCA or a PCA. It's going to be like maybe even scattered areas. So this patient will need to have a CT venogram or an MR venogram, and it will show an absence of contrast filling the affected sinus. So I don't have a picture of this. I'm not going to go through the video. That they can have a empty delta sign. Essentially, that would be in this area right here. And normally this area is going to be kind of bright because it's going to have blood there. And an empty delta sign would basically be where there's a black area within that. And that would be consistent with the patient having a thrombus there. All right, brain tumors. So who would have thought you'd talk about brain tumors and stroke, but how many patients do we have come in through the ED with stroke symptoms that it turns out that they actually have a brain tumor? There's quite a few. These patients also can have nausea, vomiting, weakness, other associated symptoms, but often, I mean, these didn't just grow overnight. So these patients, their brain has had time to accommodate this, and they're able to carry on and not have deficits, or they maybe had slight deficits that they just kind of shook off, or maybe they have seizures where they're having like a little bit of numbness in the contralateral side, or a little bit of tingling, or maybe they have a little weakness when they wake up and they think, oh, I just slept on my arm wrong, and they just kind of blow it off. But like I said, the insidious onset, there's subtle complaints, and then often they have an acute onset of something like a seizure, or like I woke up and my arm just will not work. Tumors are not as apparent on non-contrast studies. This study that you are about to see right here is a contrasted study. So also, when you look at where this tumor is, this could certainly compress the vasculature and cause the patient to have a stroke symptoms at least, okay? So would you want to give this patient T&K? How many of you would do that? Okay, nobody. That's probably a good idea. I'm glad to hear that. So this is a picture of a tumor that has vasogenic edema. The one on your right side or your left side is going to be a non-contrast study, and then there's a contrasted study. Again, this tumor may not be that big, but when you look at the area of swelling around it, that's a pretty significant area, and that's as that swelling increases, your patients are going to start becoming symptomatic. Okay, so looking at these pictures, the first image, who would give T&K for that patient? Okay, good. That obviously they have multiple strokes. They're very large strokes, and they are definitely outside of the T&K window, and they would be a very high risk for hemorrhage. How about the second patient? Look at the imaging closely. Is there anything you can see in there that would, just given the picture you have? So again, this patient, a little hyperdensity right there. Not a hemorrhage, but that is going to be a hyperdense vessel. Okay, how about the last one? Last one's a little bit more difficult. So you don't really see it very well. There's maybe some hypodensity here, but when you look at this, you also see that there's kind of loss of sulci. Little bit of edema going on there. So this patient, you know, already is having an established infarct. So probably wouldn't be giving this patient TNK. And their symptom and time of onset is probably going to go with that, but just keep that in mind. Sometimes it's subtle. You just don't see the sulci, but it's not, you can't actually see the hypodensity yet. All right, so back to talking about our case. The patient's gotten TNK. We're going to go ahead and resume imaging, and we're going to include the CTA and CTP, and we're going to communicate with our interventional team because we want them to be ready to go. Okay, so disclaimer on this. This is AI generated. This kidney, I was thinking about changing the picture, but then I thought it's a good conversation point. This is not a male kidney, okay? I think that's supposed to be an artery. Okay, so who gets a CTA and a CTP? All right, does everybody need one? Who thinks everybody needs one? Okay, we know that everybody doesn't need one, but who do we do one on? Everybody. I mean, that's the reality of it, okay? So typically, if you're an NIH of 6, then yes, you should. Or if you have something that is, you know, going to be disabling, or it points to somebody having a large vessel occlusion, or maybe even a thrombus. So what if the patient has an iodine allergy? What do we do? Yeah, just pre-treat them. If it's anaphylaxis, I mean, those are the hard ones, okay? You have to really judge. Like if I have the patient who's an NIH of 23 and they say, well, I have anaphylaxis with it, I mean, almost rather just intubate them. Or do we even need it? If they have signs localizing with a high NIH, can we just take them straight to angio? They can intubate them there and give them contrast there. I mean, these are things to think about, but yes, just pre-treat your patient. So renal issues, if they have CKD, if they have an AKI, again, brain is always going to kick butt of the kidney, all right? Neurons over nephrons every time. If there's a low LVO suspicion, less than NIH, you can consider not performing the imaging. Okay, so this is just looking at some CTAs. Does anybody see anything in these CTAs that you would be concerned with? I know it can be hard. I'm going to go to this side of the room first. So right here, you see that there's bright vessel and then there's not. And then you see over on the next one. So why do these vessels here look so much brighter than over here? Like here, you see kind of drops out there. And then over here, this looks so much better. It's like, why is that picture so much better? And you'll notice that when you look at imaging, sometimes it's so much better, right? So that is when they will do its process, the processing of the imaging, and those are the MIP images, excuse me. And then when you look at this over here, you see that also you can see, and this is the same patient, the vessel drops out over here. So just looking at the different views, the axial views and the coronal views. So, and MIP is basically a maximum intensity projection. And what that does is it basically takes the brightest area of vessel and then it applies it to all of the vessels. So it makes everything look much brighter so that we can see things better. Oh, yeah, I circled those. All right, so we're going to just move on to the CTA of the neck. All right, so this is a normal CTA that you're looking at of the neck. And basically, we are doing this to evaluate whether there is basically, you're looking mostly for an occlusion in the acute stroke patient in the common and internal carotid artery. So with this image, there is nothing wrong. But in this next one, what do you guys see? Anything there that you would be concerned about? And this is looking at the ICA. I know it's kind of a blown up view. Okay, so this right here is a thrombus. Well, I chose the stenosis first to circle. All right, this area is narrowed. All right, so this is basically a highly critical stenosis. And then if you look here, you've got a thrombus in the vessel. All right, so this patient may be just put on a heparin drip. Somebody may decide they want to take him for thrombectomy, depending on if they have other vascular abnormalities intracranially. They will probably be stented if that's the case. All right, so I was given the thing to like hurry up. So I'm gonna try to talk faster. So one of the things that I wanted to talk about that's important is looking at artificial intelligence and stroke care. The examples are Viz and Rapid. These are tools that we use every day. And it's like, how did we live without them before we had them several years ago? They use algorithms that analyze the data and kind of automate the process of looking at the CTs. They're available for not just CTs of the brain, but I think for vascular imaging, they're coming out with new products with for trauma patients, EKG, echo, all of these things. But it basically can help accelerate the diagnosis and treatment of these patients. And we can detect large vessel occlusions, intracranial hemorrhages, and aneurysms within minutes of the imaging being done before they're even available on a computer. So they all have smartphone apps. So you just pull up your smartphone app and you just wait, and they send out communication alerts for when there is an LVO or something to the team members. So, and it all happens within minutes. So it's a very nice tool to have. Potentially, you can have lower contrast levels as well. Now, the automation bias is a very important thing. Just because Viz says it doesn't mean it's real, okay? Or Rapid, either one. So it's important to still do your clinical assessment. You know, you have patients that go and get scans and they're moving during their scans, and then Viz reads that they have an intracranial hemorrhage and you're like, oh no. And it's like, okay, there is no hemorrhage. It was just movement. All right, so CT perfusion. I'll go through this really fast. Basically, it looks at your core infarct, all right? So you have an increased mean transit time in Tmax. You're gonna have significantly decreased blood flow, decreased cerebral blood volume, and in the penumbra, you're also gonna have an increased Tmax, but it's in MTT, but it's not gonna be quite as bad as the core infarct. You're going to have moderate reduction in cerebral blood flow, and you can have normal or even increased cerebral blood volume. This can be overestimated in the early time window, so it's important to note that, again, don't always listen to your tools. They may say, oh, yes, this core infarct is really large, but this happened 15 minutes ago. So chances are this patient could still be intervened upon. All right, so this real quick, I'll show you the, oops, that did not. Well, I was gonna, well, I guess it's not gonna work, but it does show you kind of that up closer, but it's not working. So if you can see that, there's a very small area of purple there on the very first image, and then there's a large area of green. Okay, so we'll just kind of look at that one. That's the easiest one for you guys to look at as you're looking at your patient that's coming up from the angio suite to know exactly how bad was it before they went in. So this large area of green, that's all the penumbra, okay? And then there's only a small area of red in there that you really can't even hardly see. So this patient had a very large penumbra, and hopefully they went for a thrombectomy. Okay, so in our patient, they basically, this is the Viz app, and they basically said LVO, so they let us know. Fortunately, we were there and already looking at it, and we saw it before Viz did. But this now is going to kind of alert the team. And ideally, they're ready for our patient, and we basically take them from CAT scan straight to the interventional suite. So when they're done, the patient's going to need a dual energy CT, okay? After the stroke, the patient can have breakdown of of blood. In this picture right here, this is a CAT scan. Like you can't tell whether is that blood, is that contrast? We don't really know. So we want to be able to identify whether it's blood or whether it's iodinated. I can't say that, sorry, right now, contrast. Okay, so this next slide basically shows you. So when you look at this patient right here, you see an area of extravasation, whether it's blood or contrast, you don't know. And when they basically put the filtering on it, you can see that it looks like it's still there. And when they complete the images here, you no longer see it on C. So basically, they're taking the iodine out and there's no blood there, okay? And then this is the same patient actually, and if you go down on the lower, on D, you see that there's a little bit of blood over, or a little bit of blood versus contrast here. They removed the iodine and it's still there, okay? So over here, you see what's either blood or contrast, they removed the iodine, and then post-processing, it's still there, so that is blood. All right, so the first one, that's contrast, and that one's blood. All right, MRI. So now our patient's going to go.
Coming in
Okay.
2025.
Okay.
I think this is going to be a good place to stop.
Yeah, our patient gets an MRI post-intervention. They already had some stroke, which we maybe saw on the initial, but here we are. And honestly, I think I was about done. So, Pearls, time is of the essence.
It is.
So,
all right.
there.
If you have questions, make sure to harass Shannon during our 5-minute break because you don't want to miss the fight of the century starting promptly at 3:15.
You can come visit me at the AANN table. I just threw that in there.
Can you make that louder?
Don't be banging on the table.
Everybody come in, you don't want to miss it. This is the showdown of the century. These are crosstown warriors. We have Jason Ferreira, pharmacist at University of Florida in Jacksonville, standing 8 feet tall, weighing in about 100 pounds. Here, Pro K-Centra, fighting from Baptist downtown and also from the opposite side of his bed. His wife and our esteemed pharmacist, Jessica McManus, who is pro Indexa. So everybody be ready to pick your sides and be here for the showdown of the century. Once you guys start, people are going to come streaming in, I'm pretty sure.
Am I on? Okay. All right. So full disclosure before I get started, I know the paper that you guys have said that I'm a neuro ICU pharmacist, but I'm in fact not. I've actually practiced in the medical ICU for the past 15 years. My colleague decided that he wasn't able to do this, so here I am. I decided the best thing to do was debate my wife in public. So that was my way of telling you guys I make poor life decisions. And ultimately, you can utilize that information on whether or not you trust anything I say from this point out. But what we'll be talking about today is indexing alpha and actually prothrombin complex concentrate, not necessarily the 4-factor version. Some objectives that we'll be discussing: exploring the pathological distinction between indexin alpha and 4-factor PCC or PCC, assessing indexin alpha or PCC's efficacy in direct anti-10A inhibitors, and then scrutinizing the limitations, addressing evidence gaps, and finally practice challenges. So what I'll be talking about personally is prothrombin complex concentrate. And again, a lot of this is focused on just hemostasis. That's one of my big expertise. One of my areas of interest is hemostasis, anticoagulation reversal, and that's kind of what I'll be touching on today. So really, in order to talk about this, we have to talk about the two agents that we'll be discussing. So the two players in the game, prothrombin complex concentrate, commonly referred to as PCC. Fortunate or unfortunate, many people really weren't familiar with these agents until K-Centra came to market in 2013. But really, these agents have been around since the 1970s as they were originally developed for the management and treatment of a lot of rare blood diseases, including hemophilia. And because of that, they really have a lot of variability between the different agents. So depending on what products you're talking about or what pathology you're talking about, you're going to see different varying compositions of these different products. But largely, they're just plasma-derived coagulation products. The way that I commonly explain them is they're just lipophilized or concentrated versions of FFP. So a lot of the things that you see inside of them are very similar to what you would see with FFP. The whole theory behind their utilization in anti-10A inhibition is really just replenishing factor 10 in hopes that you can circumvent that inhibition. But a lot of these products come with other things such as heparin, protein C, and protein S. Again, that'll become more relevant later on in this conversation. Now, the one thing that you have to keep in mind when you talk about PCC, particularly for this indication, is that you have to keep in mind that when we're administering it as PCC and or FFP, we're administering it in the inactive form. So when it's in this inactive form, you see this protein here, this gray protein. This is actually blocking the serine residue that factor utilizes in order to activate subsequent factors, in this situation, thrombin or factor 2. So in order to activate that, we have to cleave that protein, ultimately exposing that serine residue so that it can go about doing its job. But particularly when we're talking about 10A inhibitors, that site is where 10A inhibitors bind. So in contrast, andexanet alpha is actually that form. It's the active form of 10A. It's just been cleaved or modified in order to prevent it from doing its complete job. But with these modifications that happen to 10A, or these modifications that andexanet alpha utilized, it ended up in its significant shortening of the half-life of this factor inside of the human serum, ultimately resulting in a half-life of around 3 hours. But when we give andexanet alpha, we're assuming the same exact thing, a stoichiometric sequestration of these inhibitors. Essentially, just we're hoping to outcompete these 10A inhibitors or hopefully so that our activated factor 10 can continue now to do its job. But fortunate or unfortunate, 10 isn't the only thing that andexanet alpha binds to. In fact, it also binds to TFPI, which is our tissue factor pathway inhibitor. This is your endogenous brake that you typically use to stop coagulation. So when andexanet binds it, not only does it reverse the anticoagulation that you're hoping to reverse, but it actually pushes you into prothrombotic state because it takes away your only brake that you have. So as I just mentioned, this is an active form of 10. So you can see this highlighted portion is that active serine residue. In contrast, this is andexanet alpha, looking almost identical. You can see where your inhibitors will then bind to andexanet alpha. What it misses is this GLA component of factor 10. So this stops it from binding to the prothrombinase that usually is what it does in order to bind factor 2 and then subsequently activate factor 2. So because of this modification or this absence of this component of the lower molecule, it can no longer do its job. But before I really go any further, I really need to talk about some basic coagulation concepts because I promise you a lot of the things that you've been taught have been oversimplified. Because a lot of these contemporary models are really based off very simplistic, more laboratory things, and not so much really reflect what we really should know about coagulation. And this becomes important, particularly with this discussion. So we're all familiar with the intrinsic and extrinsic pathways, but really this is based off of laboratory parameters. In the early 2000s, this is the cellular-based model that was proposed, basically saying that there's a lot more things that go into coagulation. It's not only this intrinsic and extrinsic pathway, but there's actually a lot of interplay between the two. In addition to that, there's cellular components that play into activation of coagulation, and then there are a number of other factors that actually go into it. But if we really were to sit down and map out the coagulation cascade, it probably would look more so like this. There are a whole slew of things that we just are unfamiliar with or that we just don't know about at this point in time that influence coagulation, which becomes extremely important when we start talking about utilizing PCC for the reversal of 10A inhibitors. Because from this point on, the efficacy of PCC is solely dependent on the kinetics of activation of factor 10. And there are a lot of things that play into that, including platelets, endothelium, a number of other factors, factor 8, 7, tissue factor, factor 5, and factor 9. Luckily for us, particularly with what we're talking about today, when it comes to intracranial bleeds, the brain actually is laden with tissue factor. It has one of the highest concentrations of tissue factor of any other organ system in the human body. And in addition to that, it actually is very low concentrations of anticoagulants. So the brain itself would rather clot than bleed. TFPI and antithrombin 3, the body's endogenous anticoagulants, actually are almost completely absent in brain vasculature. Even TPA is expressed at very low concentrations. We think this is an evolutionary process given the closed vault. So in order to really talk about the literature when we start talking about PCC, we really need to take it in a couple different buckets. There's in vitro literature. This is really kind of what predominated after the release of these 10A inhibitors in the early 2000s, or sorry, 2011 and on. Some in vivo literature. This is both in healthy individuals and bleeding individuals, and then really the injury type that we're discussing. So the first study that I really wanted to touch on was done by Dr. Liu and colleagues, and this was a completely in vitro study. So this was plasma that was spiked with either rivaroxaban or apixaban, and then it was tried to reverse with Kcentra and andexanet alpha. And what they were looking at was just generally thrombin generation. You'll see these terms repeated. Terms repeated multiple times: thrombin generation, ETP, or endogenous thrombin potential. Basically, what this is saying is that if I'm capable of overcoming this 10 inhibition, I should be able to activate thrombin being factor 2. And if I can generate thrombin, it's telling me that I've bypassed that inhibition. So you can see this black inflection here. This black inflection is basically telling you that you're producing thrombin. So that big hump that you see there is actually plasma that was just activated. There's nothing in it, no rivaroxaban, no Kcentra. You can see quite a high inflection when it comes to thrombin. All these colored lines down here are after they added PCC. Ultimately, your left-hand side here is rivaroxaban, right-hand side is apixaban. You see really no difference whatsoever. So with the addition of PCC, even at increasing concentrations, no real difference in the production of thrombin, basically insinuating that PCC really isn't doing anything. Now, they did this across multiple different concentrations of rivaroxaban and apixaban once again. This yellow block here are actually the concentrations of these drugs that were seen in ANNEXA 4, the trial that got andexanet alpha approved. And what they looked at here is, and then this dotted line here is normal physiological concentrations. So again, they're looking at thrombin potential, so how much thrombin is actually being formed. And you can see even at these varying concentrations, 25 and 50 units per kilo, really PCC failed miserably to actually produce any thrombin, again, insinuating that there was no bypassing of that 10A inhibition. This is in contrast to andexanet alpha, which is on your right-hand side here. You can see that even at extremely high concentrations of both of these agents, it was capable of reversing and producing thrombin generation. Again, insinuating that that andexanet is doing a great job. PCC really can't do anything at all. But something about this really doesn't make sense. This paper was published in 2020, 2 years after andexanet alpha came out. Unfortunately, we've had almost a decade at that point in time of looking at this literature and trying to find a way to reverse these agents when patients were bleeding. There's a lot of inconsistencies when it came to that study and when that study was published in comparison to what had already been published. So these two trials here, this was one of the first ones that was published utilizing 10A inhibitors and PCC. And you can see that after spiking this plasma with rivaroxaban and then reversing it with Kcentra, within 15 minutes of adding Kcentra, you actually had complete reversal of that agent. The thrombin potential went right back up to normal. This bottom one here looked at different fibrin or different clotting factors or different forms of clotting factors, PCC, FEBA, and factor 7. And you can see here PCC is this red one. The orange one is normal serum, so nothing in that. And you can see that PCC, while it didn't bring it up to completely normal, it came pretty close. FEBA actually came the closest. It was a little bit delayed, but still came pretty close to normal. So what exactly happened here? Doesn't really make a whole lot of sense. Dr. Brinkman and colleagues thought the same exact thing, so they decided to repeat the same exact analysis as Dr. Liu and colleagues. So what they did is took the same thing, spiked the same plasma, and at this point in time, they remeasured the same exact laboratory parameters. So the one off to your far left, this is going to be andexanet alpha with the blue line. The green line is going to be your control. So you can see andexanet alpha once again return thrombin generation back to normal. The really peculiar thing that they found was these are two different forms of PCC. Variplex is how Kcentra is marketed across Cs. So you'll see that name kind of used a couple times in this talk. And then Cofact is just another form of a PCC. Again, it's only available overseas. It's not available here in the United States. But you can see these blue lines, they actually were able to reverse a lot of this anticoagulation. With apixaban, you didn't really see it as much as you did with rivaroxaban, but reversal of rivaroxaban was nearly complete with the addition of both of these PCC agents. So things started to get strange at that point in time. So once again, they did the same exact analysis. In this one, they used orange bars instead of yellow bars, but these are the concentrations of drug evaluated in ANNEXA 4. And triangles being your PCC agents, squares being ANNEXA. And again, you saw actually at some concentrations, PCC outcompeting ANNEXA, which was peculiar as well. So what exactly happened? Why did we see such divergent responses? Some of you may have already picked up on it from the previous slide, but really the big difference here, or what we think the big difference here, was actually the fact that Liu and colleagues used an apheresed or a non-cellular component plasma. So they use a platelet-poor plasma, and at this point in time, it really may have affected the activation of factor 10. And the capability or the inability to activate factor 10 may have actually prevented it from doing its job. The other thing, you really had to be a little bit more of a detective to find if you wanted to see what the big problem was with this study. I tried to zoom in on it. It was published by Portola Pharmaceuticals. It was actually done in their lab, which for those of you who may not have known, Portola Pharmaceuticals is actually who owned ANNEXA. So for some reason, they decided once again to not do the best in gaining trust of the medical community. So why can't in vitro cut it? Why are these just bad tests when it comes to theoretical reversal agents such as PCC? A lot of it has to do with the fact that we have to and rely on tissue and cells in order to activate factor 10. And at this point in time, we just have a very poor understanding for the kinetics of how 10 is actually activated. But what we do know is that there are a number of different things that weigh into it. I can back up. So factor 8, factor 9, tissue factor, and even the phospholipids and cellular membranes, all of these things weigh into activation of factor 10. Once I activate factor 10, it can then become combined into the prothrombinase, and this is usually where your 10A inhibitors will start to work. But there are a number of studies that show that these things are extremely important. So these top two ones here are just looking at cellular membranes, so both platelets as well as endothelium, and show that as we increase the concentrations of both of these cells, you see a significant increase in both velocity and number of 10A factors that are actually activated, changing it from the inactive to the active form. This bottom study here is looking at factor 8 and factor 9, again showing that increasing concentrations of both of these factors will dictate and determine how rapidly and how much 10 you're actually activating. These are things that unfortunately we're just not good at reproducing. So what in vivo studies do we have? The first one by Song and colleagues just took 15 patients and they started giving them apixaban for 3 days. What they did at that point in time is after that 3-day period, once the drug had hit steady state, they gave them PCC. In this study, they used 2 different forms, Beriplex, again, this is the agent that we commonly refer to as Kcentra in this country, and then Cofact is another agent. This first slide here is just zoomed in on the first couple hours, but you can see that essentially, as soon as they gave PCC, within 4 hours, they had almost complete reversal of thrombin generation. As we zoom out, you can see that this thrombin generation actually peaked around 24 hours to a super physiological concentration. They were able to make them prothrombotic at this point. In addition to this, it maintained for roughly 72 hours. So particularly when we're talking about the disease state we're talking about today, you're able to give a single dose and this thrombotic state or this hyperthrombosis can persist for up to 3 days, drastically different than the 2-hour period that we see with indexing alpha. So that's all fine and good, but those are healthy individuals. And again, as our list of things that we really don't know how people react with, we really don't know what the coagulation system does when a patient is actively bleeding. So these are patients who presented to the emergency department with 10A inhibitor-induced bleeding. They were administered 50 units per kilo of a PCC as well. Roughly 60% of these patients had intracranial hemorrhage. It's roughly 10 hours since their last dose, and these researchers, I commend them for this, they actually check drug levels as well. So these are the average drug levels that you saw in these populations. Now, what was interesting is they rechecked the same exact lab values that I've been referring to this entire time at time 0, so at that time of diagnosis, then at time 1 and time 2, which was 15 to 30 minutes, and 4 to 8 hours later. So you can see the thrombin generation or thrombin potential that I've been referring to this entire time. Prior to administering anything, it had already normalized. So again, there may be a potential that the human body is able or capable of overcoming this inhibition all by itself. But the reality is most of us will push ourselves to super physiological concentrations in the event of bleeding. So after administration of PCC within 15 minutes, again, it pushed itself to that high concentration. And then again, that maintained at 4 to 8 hours. Now, thrombin peak was really the part that was hindered the most, and this is pretty consistent with the literature. So the thrombin peak really didn't hit that super physiological concentration until that second time or that 4 to 8 hours out. Some of you may have noticed that green and red dots right here, and this is kind of a big point that I want to make. So the green and red dots are actually patients who had good and bad hemostasis. So patients who continue to bleed and patients who had their bleeding cease. And you can see that there is generally no correlation to these laboratory findings and the clinical process of this patient, which again, a lot of big pharma is going to tell you that these lab values are telling you exactly what you need to know, and this means that this drug works. But I'll argue that a lot of it has to do more so with the injury than really the reversal of the anticoagulation. So what do we do? Should we use PCC? Does it matter what drug we're using? Does it matter what dose we're using? Or does it matter what agent we're reversing? Again, these are all questions that remain to be answered. But here in the United States, that we have 3 general agents that are currently available to us. That's Kcentra, Profil 9, and FIBA. Alpha-9 is also another, Alpha-9 is another agent that is marketed by the same company as Profil-9. But Kcentra is commonly referred to as a 4-factor PCC. It includes heparin. It's marketed overseas under the brand name Bariplex. Profil-9 is commonly referred to as a 3-factor PCC. It's marketed for the treatment of hemophilia B. In addition to that, the reason why it's called a 3-factor PCC is because it really doesn't have any appreciable concentrations of factor 7. Unlike Kcentra, though, it has no heparin in it. And there are similar agents to this overseas marketed under different brand names, but they have 4 factors in them rather than 3 factors. And then finally, FIBA is commonly referred to as an activated PCC. Essentially, this is a 4-factor PCC, but what has happened in this agent is they've prematurely activated factor 7. It's commonly used for the treatment of hemophilia in patients with inhibitors. So really what I wanted to harp on here is the addition of heparin. So heparin was utilized or added to these agents when these agents were being used for hemophilia as a method of trying to circumvent the procoagulant state that occurs. But if you guys remember how or why heparin works, it works by inhibiting factor 10 and factor 2. So unfortunately, when we are wholly relying on the activation of factor 10, this may ultimately hinder the success that we're hoping to have. And this has been shown a number of times. I've actually showed it to you guys earlier in this study by Brinkman and colleagues. They used Bariplex and Kcentra, which is a heparin-containing agent, in comparison to Cofact, which is a non-heparin-containing agent. And you can see a drastic difference between the amount of thrombin that was able to be generated. Similarly, the study by Kong and colleagues. So again, this red line here is Cofact, which has no heparin in it. This blue line is Kcentra, which has heparin in it. So you saw a much higher peak with products that did not have heparin in it. And the last one I really wanted to show is Brinkman and colleagues, because I think this showed a really important thing, because if you look at the different or varying concentrations of drug, this is really where it becomes the most important. Because heparin-containing products seem to hit a plateau effect or a ceiling effect. And really that becomes the most important when drug concentrations get extremely high. So at that point in time, these heparin-containing agents really may fall short when we're trying to reverse very high concentrations. Keeping in mind that most therapeutic concentrations of these agents are usually less than 200 nanograms per ml. Again, these are studies that I showed you guys earlier. What about FIBA? So this comparison of different FIBA, you can see that PCC kind of fell short of what FIBA was capable of doing. What I didn't tell you at that point in time when I presented this slide was this study actually utilized Kcentra. So if I fast forward to this Brinkman and colleagues study, you can see that when I use a non-heparin containing agent, thrombin generation still hit 200, very similar to what FIBA was capable of doing. So when I take all of this evidence and I put it together, I can make at least somewhat of an argument for this agent. But what about dosing? Unfortunately, we really don't have any evidence for dosing. A lot of governing boards have recommended 50 units right off the bat, and we really don't have any evidence to support that. This is the largest study that was actually done, and what they did when they did a regression analysis is they found that receipt of high dose increased the likelihood of survival. But with a confidence interval of 2 to 52, I don't know how much I'm going to trust that evidence. Unfortunately, in addition to that, we also decided that it was necessary to do a meta-analysis of even worse literature. So if we had bad literature, we may as well put all that bad literature together and find nothing whatsoever. So this really tells us that we don't know anything about doses. But if we go back to the in vitro literature, we do see a dose-dependent response. So Brinkman and colleagues actually went from 25 units per kilo up to 80 units per kilo and found that there was a dose response when it came to this. But again, it was very dependent on the concentration of drug. So with apixaban, you may have to use very high doses in order to reverse very high concentrations of drug. When you start to get those lower or therapeutic doses of drug, you may be very comfortable with 50 units per kilo as an ability to reverse that agent. Now, rivaroxaban is a completely different beast. It appears to be much easier to reverse, much lower concentrations of drug. So again, in that therapeutic realm or that therapeutic range, 25 units per kilo may be sufficient. When you start to get into that area of the higher doses or higher concentrations, this may be where you opt for that 50 units per kilo. So if we just use kinetic modeling or the evidence that we have available with kinetic modeling, we can basically break this down based on their last dose. So if we look at apixaban dosing, we hit that 100 to 200 range in about 5 hours since their last dose. So you may be able to safely use 25 unit per kilo dose at that point in time. And then anything beyond that, or excuse me, earlier than that, you may have to opt for that higher dosing. And the same can be said with rivaroxaban, but because of the longer half-life, it's that 8-hour cutoff rather than that 5-hour cutoff. Unfortunately, if you're ever faced with a patient who had a massive overdose or an intentional overdose, these are patients where you may be opting for much higher doses of PCC. So with that, in conclusion, in vitro studies really have very limited purposes in 10A inhibitor reversal. Surrogate endpoints really need to be stopped when we start doing this, particularly from a pharmaceutical standpoint, because we know that it really doesn't extrapolate well to clinical outcomes. When we talk about theoretical concepts, though, with PCC, evidence really kind of supports non-heparin-containing agents, dosed based on the agent that you're trying to reverse, dosed based on the time from the last dose, and then adequate comparison really is required because the current evidence that we have right now, we just have not standardized that treatment arm or that control arm well enough. So with that, I will hand it over. Do you have your own? Yeah.
All right, so I should also add to my disclosures that the views are my own, and you'll see why. Was it this like green arrow?
Do it.
Green arrow?
Yeah, green arrow is good for it.
Cool. All right, so I don't know if Jason really like he didn't get too hard at me, so that's good. But he might have kind of alluded to that there's a lot of controversy when it comes to Indexa, and in my point or my perspective. In order to really appreciate the utility, you really have to recognize its flaws. So I'm going to be airing out all the dirty laundry when it comes to Indexa. So I can say bad things about myself, but you can't say bad things about me, right? All right, just as long as you recognize it. So when Indexa first came to the market, it really did not give a good first impression. Right off the bat, cost $50,000 for a dose. And that's with zero evidence saying that it's better than what we're currently doing for particular patients. And to put it into perspective, a drug that was also a reversal agent it's for a different drug, not this indication, but was literally released years prior, $3,500, so substantial difference. But the manufacturers, they recognize this and they have since reduced the price by 50%. Now, with any new release of a drug, the poor reps for this manufacturer, they had the hard task of selling this drug, expensive one with little evidence. And so they pushed hard. They were doing their job. And unfortunately, it just didn't really bode well with a lot of people. And honestly, I've heard actual, people talk about how they felt like they were scared to not use this drug because they were scared they're going to get sued for not using the FDA approved. And so when somebody uses scare tactics to sell their drug, I have a problem with that. I have to say I've never had any issues and everybody's been very nice, but I just want to put that out there that that was the issue when it first came out and people are just trying to do their job. So what I really want to focus on is the initial drug studies. Now, the first ones are not bad. Preclinical data, we need this to know that it's good to use in our patients that are critically ill. And so what they did was Indexa A and Indexa R. Those were studies done in healthy individuals to evaluate Indexina alpha's effect in terms of reversing drug in healthy patients compared to placebo. And 100%, it reduced anti-10A levels, and then it also reduced the drug concentration significantly. Now, this was a study in sick, bleeding patients on anti-10A inhibitors. It was prospective single arm that evaluated hemostasis at 12 hours. And when we look at our ICH patient population, one thing that you'll notice is that they're not overtly sick. They're not the sickest of the sick, right? But what they found is that hemostasis occurred 80% in the patients that did receive Indexinet, and that was defined essentially as 35%, less than 35% in terms of hematoma expansion. For thrombotic events, it was 10%, and then mortality 14%. And this was the first part of the study. They later on went and enrolled more, and the incidences were similar. All of this led to this FDA approval, adding it to our repertoire of FDA-approved replacement and reversal agents, and making Indexina alpha the only DOAC reversal agent out on the market. But there was still a lot of controversy. So there was this no comparator group. So again, we had no idea whether or not this was going to be even better than what we were already doing for these patients. They excluded the sick patients. So did they set themselves up to look good, or were they really having a good study design to evaluate whether or not this drug worked for these particular patients that were at risk for hematoma expansion? And we've already kind of alluded to surrogate marker. Should we be looking at hematoma expansion or patient outcomes? And then the definition was of hematoma expansion. There's no universal definition, but the one that they used was not one that was routinely used in practice. But why do we care about this now? If you actually look at the previous studies that got the Kcentra and idarucizumab approved, they were no better. So the INCH study for Kcentra, the primary outcome was a lab. It wasn't even a surrogate marker. It was a lab of INR less than or equal to 1.2. And that's not even what the guidelines go for. For our ICH patients with on warfarin, we go for less than 1.4. So why did they do this? They know that FFP couldn't get to 1.2. It's really hard because once it thaws, the factors start to thaw or start to lose activity. And so they set themselves up for success. And then when you look at Praxpine, no better. They had no comparator group. And the funny thing about it is that they actually included ICH patients, but they did not even evaluate hemostasis in them because they said, well, I know that you can use it as a surrogate marker, but it's not mandated, so we're not going to do this. So if you look at Anexa, their study wasn't that bad. So why do we care all of a sudden? Well, the FDA, I guess maybe they got a lot of slack for what had happened previously, but they said, you know what, we're not going to approve your accelerated application. But the director stepped in. He's like, you know what, I can see that there's a utility and a place for it. And there's an unmet need for, a reversal for DOAC. So I will approve this, but you have to provide additional evidence, which brings us to Anexa-I. Now, before we get to Anexa-I, which actually just recently wrapped up its study, late 2023, there's a lot of interim retrospective analysis looking to see whether or not andexanet alpha is going to be better than what we're currently doing, which is PCC products. Shown here are some of the, snippets of the articles that I could find, some of the bigger ones. And one thing that I want to point out is that there's a lot of bias. So you can see color-coded the authors that are sometimes duplicate on various articles that are shown here. And lo and behold, you'll see that a lot of these are actually going to be either funded or these authors are associated with the drug manufacturer of andexanet alpha. There are only a few that aren't necessarily overtly biased, and that's just based off my evaluation of, the conflicts of interest and things like that, but they're still a little questionable. The ones with stars are the ones that I have deemed to be questionable. So they call this real world data, and it can be broken up as to whether or not the retrospective studies looked at hemostasis versus just mortality. For hemostasis, Barra and then Costa and colleagues, they looked at hemostasis and they found that andexanet alpha was better than PCC. Of note, Barra actually looked at 24 hours hemostasis, and that's typically what we would do in terms of our CT and past imaging, but it's been pretty consistent in terms of 12 hours. Now, on the flip side, Stevens, they actually found that andexanet alpha had worse hemostasis and I'll go off track for a second. I have no time, but it's funny because AstraZeneca actually did a poster abstract and they did bias studies, and they actually found that this was the most biased study, which I thought it was actually the least biased study. But I will say the study in terms of composition, it wasn't great. I don't put a lot of stock into this personally, pro or con Andexa. I think the groups were definitely uneven, and their hemostasis did not translate to mortality. Mortality was better in Andexa all the way through. Then you go to the real world data, of big, larger studies that were some were database-based studies, and you'll see that they had better mortality with andexanet alpha compared to PCC, and some very substantial differences in terms of mortality. Now, notable issues with andexanet alpha versus PCC up to this point. They're listed here, but the one thing I really want to harp on is that the patients in both groups, the andexanet alpha and the PCC groups, they are not equal. No matter how many logistic regressions you do or propensity matching you do, there are factors that were not accounted for. So all the things that make up the ICH score, they didn't control for those. Or there's just things that we can't see in terms of a study or retrospective analysis, such as criteria for uses. We have a criteria for use at Indexa. And technically, it should be following what, the Indexa 4 use, which is those not very critical ICH patients. Everybody else gets PCC. So they're by itself, the groups are different. The solution, well, that would be a prospective randomized control study looking at PCC versus andexanet alpha, which should be Indexa I, but womp womp, we got usual care. So Indexa I is andexanet alpha versus usual care. It's an open label, only ICH patients. Now, the one thing I want to point out, and I'm probably going to miss a few or lose a few people, but stay with me. They did a planned interim analysis at 450 patients. And in order to decide how many patients you need, you have to look at previous studies, look at the incidence of the outcome that you're looking at, and they do a power calculation. They did that based off a hemostasis rate of 80% versus 70%, which is a 10% difference. And they said that's a 33% relative risk reduction, which is clinically significant. And we decide that that's what we're going to use our outcome, but we're going to do a half analysis and just see what's going on in the middle. If it's significant, then we'll stop. So that's what they did. Inclusion, same, but they actually only included patients that had symptom onset within 6 hours, and notable exclusion is also same. Something that they did, though, uniquely, though, they changed their hemostasis definition. They included the same expansion definition, but then they added an NIHSS and then also whether or not somebody got rescue therapy. Of note, if somebody did not have something documented, then they just had poor hemostasis. Unless they decided it was administration error, then they just weren't evaluated. So at the interim analysis of 450 patients, they looked to see if they had a 10% absolute difference, and they did. So andexanet alpha had better hemostasis compared to usual care, but if you actually do the calculation, it's a 30% relative risk reduction. The patients in this cohort included patients that had a hematoma around 10 cc's, so definitely not getting close to that 60 cc limit. 87% of the patients received PCC, 90 of which were the 4 factor. And then if you looked at the symptom onset and the timing, it looks like when patients had the symptom onset to time being treated, it was round within 4 hours. And that's, I don't know our metrics, but that seems very quick. Now, what we really care about, okay? Andexanet alpha versus PCC. Andexanet alpha was better than PCC when it came to hemostasis. When you look at non-PCC patients, there's no difference, but this is likely because those patients, again, you got to remember it's usual care. The physicians are actually the ones dictating what the patients get in the usual care. So I would suspect that these patients maybe didn't need reversal or they are at high risk. And so they didn't get PCC. So that no difference, I wouldn't look much into at all. Shown here are additional safety analyses. One thing I want to point out is that the thrombotic events, 10% similar as the Nexa 4, but it's still higher than the usual care, and the mortality, it was higher, but no difference. So notable limitations, it was unblinded. No reason why it should have been unblinded. Rampart, VA cooperative trials, very crazy and like in-depth studies. They were blinded, no reason they couldn't do it. Actually might have even hurt them because if our providers give somebody an Indexa, we're looking to see if they're having some kind of thrombotic event. So for all we know, it actually hurts Indexa. Power calculation. Now, the calculation was weird, and it's because they didn't use the same definition of hemostasis, but they did meet power if you do a post hoc analysis. And then I really wonder what they mean by that 33%. Does that 33 versus 30%, does that matter? I don't know. And then why did they do an interim analysis? It's not like it's not out. We're using the drug. What's the rush? And then hemostasis. So where did they get this definition from? It's actually a guideline definition, but it's quite, I guess, different. So the one thing I want to point out is the rescue therapy. The definition, they actually say that it's after 48 hours and then they get additional blood products, whereas theirs is within 3 to 12 hours. But the biggest problem I have at all is they are not publishing this study, and it is driving me crazy. It's actually doing us as a medical community a huge disservice. There's so much information that we don't know, and they actually have the audacity to go to other, locations and actually or conferences and present the data instead of actually publishing the data. And we need to know this data because we don't know where the ICH is. We don't know if it's trauma. We don't know how their blood pressure is managed. We don't know why they got poor hemostasis. If somebody is thrombocytopenic and they get platelets, were they technically poor hemostasis? And we just don't know a lot of these things. But regardless of all the bad things I've said, one thing's been held consistent, and that's that andexanet alpha has consistently met hemostasis no matter what the definition was. Sure, it's associated with thrombotic events, and in this scenario, it wasn't associated with improved mortality. And the other studies, they did show significant mortality benefits, but that's probably because the patients, they weren't on the same level field. This is the better evidence here. So the big and last little thing we got to talk about is the thrombotic risk. Jason's already alluded to, it is going to put you at a prothrombotic state. But if you look at the previous studies, you'll actually see that indexing, it's kind of in the middle. And there's a few things that we just don't know. One is we're looking at thrombotic events from 30 to 90 days. Is that really from the drug itself? And then the DVT prophylaxis resumptions. The rates are horrible. So for us, after 24 hours, the patients were asking, can we start DVT prophylaxis? And for some patients, not even to get sick, almost half of the patients didn't get DVT prophylaxis. Why? This is something that we could potentially be preventing. So now I say all this. Does it matter? Because at the end of the day, it really doesn't change the effectiveness of an andexanet alpha, and it does not make PCC a better product. Let us not forget PCC was developed for other disease states, not this one. Kcentra itself was developed, or I guess approved for warfarin, and then it's dosed in factor IX. So whether or not you actually are using it for factor 10 or the other factors, if you actually look here, there's a wide range of factor products within each for each factor. And just looking at factor 10 itself, you can see the wide range. So say you're doing a 50 units per kilogram dose for a patient, you'll actually see that the range is almost 3,000 units off. So with that being said, we don't know what dose to give. We don't even know what factor of content we're going to be giving the patient. And we don't even know if it actually works, but it's cheaper, but you may actually be wasting money. Does that even make sense? So my argument is this. With andexanet alpha, it's better than PCC because when you use andexanet alpha, you know what dose you're giving. You know that the patient is getting the dose. You know what the risk is, and you know how to prevent it, DVT prophylaxis. And you know that you're reducing drug levels, and you know that you're reducing anti-10A levels, and that you have the potential to improve hemostasis. And you know that every CC matters, and that's why you should choose andexanet alpha.
Getting hot in here, guys. All right, so who's sleeping on the couch tonight? Do we have some votes? So who's Kcentra? Can I see hands up in the air? Jess, this is looking good. All right, and who's going to give Andexa? Wow.
I will say that
I think they're in the exhibitor hall, so
I
please
know,
don't.
right? Not here. I was going to say earmuffs, but I will say I do think that there should be resource utilization. So really thinking about who you're giving it to and whether or not they can benefit, as opposed to just giving it to everyone. I think that would be inappropriate. I would continue to follow kind of the studies and when they present last dose, things like that.
Excellent. Do we have any questions? We probably have time for one or two. All right.
You spoke fast.
Huh?
I said you spoke fast.
I try to.
Oh.
You took up all my time.
So people with the 10A and they're trying to treat that, they're probably are going to be prothrombotic already. That's why they're on the medications to begin with. So does the increased risk for thrombotic events when you're reversing it, giving it the Indexa, match the same risk factors as if they were already not taking it to begin with, which is why they're on a drug?
I think that's always a risk benefit that we're always thinking about. I mean, when our physicians are thinking about whether or not they want to reverse them, say with a mechanical valve, are they going, sometimes they come in, they don't even give them Kcentra because they know that they're at a higher risk in terms of like risk of thrombosis versus expansion. I think expansion, that's something that you have to take in mind because that's, for me, what we're ultimately trying to prevent. And even though I go back and forth, I hate using the surrogate markers, but we are essentially trying to prevent that, right? We're not trying to, you know, allow for any progression. So for me, I probably didn't answer your question. It depends. It's a patient-specific factor. If you know that they have a high burden, or say if their bleed gets any bigger and you know that they could go downhill. I mean, it just kind of depends, right? It's always going to be that.
Yeah, I think it's an interesting question. And I mean, I think that's always the $1 million question. I will say that with IndexNet Alpha, the one big thing that I will caveat, and we've discussed this a little bit, yes, it will put you back to that thrombotic risk. I think at baseline, that's the answer to that question is you're reversing it with the expectation or the acceptance that you're throwing somebody back into that thrombotic condition. Again, it's the argument of, is the insult worse than what you may cause? Which I think we have to weigh based on who your population is. I'll say the one caveat with IndexNet Alpha is, if you look at the literature, particularly when it comes to pathologies like antiphospholipid syndrome, one of the working theories that come along with that pathology is sequestration of TFPI, throwing you into that prothrombotic state. Now, for those of you who may or may not know, those are those conditions that we actually recommend against the use of 10A inhibitors solely because it's ineffective at therapeutically anticoagulating those populations. So I'd argue that not only are you flipping them into that prothrombotic state that they were on that agent for originally, but you're making it tenfold worse. That's my personal opinion, because if you start compounding other pathologies, it becomes infinitely worse of a pathology. So if you cannot, or you are in a situation where you cannot anticoagulate them, you're putting yourself into a very difficult situation. But that would be my 2 cents on that one. And, you know, putting another argument for poor factor or PCC, but
yeah.
So Alex, they are here, the people that represent, other than Jessica. And that's the argument that they'll say, is that these are patients that are already prothrombotic and then you're taking away their treatment. But feel free to stop.
To an extent, which to extent is true, but I do think that because when it first came out and still owned by Portola, they were actually arguing that there was no thrombotic risks whatsoever. Because again, the TFPI inhibition was wildly undervalued. And I think as they started studying it more, they started to see a lot more of the thrombotic complications. So those are things that, again, I think we just need more evidence for.
All right. Well, thank you very much. And we'll continue to look forward to the release of Indexa I's formal.
Yeah.
I don't think it's
one day.
And we'll transition now into something a little bit different. We have some of the OGs from this 10-year-old program here. I'm not aging you. I'm telling you how wonderful and experienced you are. So we have Margie Donnelly, and then Jen Clark will be coming to speak. And then later, if caseload allows, we'll be joined by Dr. Nima to talk about some of the complications in stroke management.
Hey, thank you for having me. So I go green for forward. Let's wait for it to load here. Maybe. Okay, I guess I can. Is my mic on? Can you guys hear me okay? No. Oh, there we go. Okay, so I am here today along with Jen. We're going to talk about like the immediate post-stroke complications. So we start with growing hematomas, pseudoaneurysm, hemorrhagic transformation, malignant cerebral edema, and herniation syndromes. So I'm going to cover a few of these, and then Jennifer's going to come up and finish us up, and then Dr. Nemi will join us. So what is a growing hematoma? Everybody know? I know some of this is basic, but okay. So it's a loss of blood directly under the skin, and it's a result from arterial and venous injury, okay? It's not just a bruise on the skin. It actually forms a lump and it hardens, okay? Potentially there's something bleeding still underneath there, okay? And I think I have a picture there. I don't know if you can see the little yellow arrows that shows it underneath the skin, what the hematoma looks like, okay? What are some of the possible causes? Oops, let me go back one. Oop, there we go. Increased blood pressure, ineffective closure device that was done after the angio, or ineffective hemostasis from manual pressure. You can have increased abdominal pressure. The patient needs to urinate or have a bowel movement, and they're trying to sit up. We have that a lot, patients coming back to the ICU wanting to sit up and stuff, so they're putting pressure on their abdomen. Obese patients, antithrombotics, self-explanatory, and then advanced age. They have a decrease in their vascular or vessel elasticity, so they're at risk for growing hematomas. So what are some signs and symptoms of bleeding? Anyone? What'd you say? Pain? Yeah. So we've got pain at the growing site, lower back pain, swelling at the insertion site, numbness, tingling of the legs, and loss of pedal pulses. So what interventions are we going to do for these? Okay. We can apply manual pressure, try to push out that hematoma. It's 1 to 2 centimeters above where that puncture site is. Assign somebody to call the nurse practitioner or the physician to let them know what's going on and that you're holding pressure. You can mark the boundaries around that hematoma, just so you can monitor if it's expanding or not, okay? And then, of course, you're going to monitor the vital signs because you don't want this patient having some drop in blood pressure, becoming tachycardia, because then you know you have a real bleeding problem. Okay, pseudoaneurysms. Who can tell me what a pseudoaneurysm is? Okay. So this is a leakage of blood from an artery into the surrounding tissue, okay? So it's bulging out. I don't know if you can see the picture there. So you got the normal vessel, then you have a true aneurysm where blood flows in and blood flows out of that aneurysm. A pseudoaneurysm, you've only got blood going in it. So it's growing and growing and growing, okay? More rapidly. So if you've got a femoral puncture, that's heavy flow of blood flowing through there. So that's a lot of blood being pushed through that large artery. So why is this so dangerous? Okay, you got the buildup of blood, can damage the circulating tissue around that, and it can cause tissue death. There could be a possible retroperitoneal bleed, hemorrhagic shock, like I said earlier, and then you can have loss of limb or loss of organs due to that lack of oxygen to that area. Okay, so what are some interventions that you as a nurse should do for these patients? That's right. First, what you want to do is you want to get a stat CT of the abdomen, pelvis area. Sometimes they want an ultrasound, but we don't get ultrasounds very quickly at Baptist. It takes at least an hour or two to get somebody up there to do it. So in Weaver 10, we've got the stat CT right across the hallway for us. So we'll run over there, do a stat CT. We want to do blood work. We want to see what their hemoglobin is. We want to get a type and cross just in case these patients need blood. Transfuse blood if we need to, monitor vital signs. Again, the hypotension, the tachycardia means that this patient's most likely bleeding a lot. So, and then if there is a pseudoaneurysm present on that CT scan, we can urgently consult IR. Sometimes they'll come up to Weaver 10 and inject that pseudoaneurysm with thrombin and cut it off or stop it, okay? Sometimes they'll have to go down the IR to do it, but recently we've had the IR physicians come up to the unit to do it for us. So next is hemorrhagic transformation. I know Shannon touched on this a little bit, and a few things are going to be repeated that she had said. But what is hemorrhagic transformation? Hemorrhagic transformation is a hemorrhage that occurs when the blood, peripheral blood is extravasated across the disrupted blood-brain barrier and into the brain and into that ischemic stroke area, okay? There's a picture of one up there. While reperfusion therapies like mechanical thrombectomy and TPA, they aim at restoring blood flow and salvage ischemic tissue, they can also increase your risk of hemorrhagic transformation. Preventing the hemorrhagic transformation post-thrombectomy and TPA, it's extremely important because if this happens, it's going to worsen your stroke outcome and increase the mortality of the patient. So what happens, I know this slide is really busy, but what happens in the brain during an ischemic stroke? Well, ischemic stroke injury triggers an inflammatory cascade, which these inflammatory cells contribute to the tissue damage and blood-brain barrier disruption. The inflammation further compromises the vascular integrity and promotes hemorrhagic transformation. Ischemia-induced blood-brain barrier allows for the inflammatory cells, the cytokines, and the neurotoxins to enter into that brain parenchyma, exacerbating tissue damage. And ischemia and reperfusion lead to endothelial dysfunction, causing microvascular injury as well. The MMPs, I can't say that other word, metalloproteinase, they're enzymes that are involved in the breakdown of extracellular matrix components. And during ischemic stroke, these MMPs are upregulated and they can degrade the tight junction proteins in the basement membrane of the blood-brain barrier and lead to increased permeability. So all these things work together and one affects the other. So the ischemic stroke just continues to build. Okay. So hemorrhagic transformation encompasses two types. You've got your hemorrhagic infarcts, your HIs, or you have your parenchymal hematomas, which are your PHs. The HIs, they're characterized by petechial hemorrhaging within the infarcted tissue itself, while the PHs involve a more extensive bleeding. So the HIs, most likely patients probably won't have any symptoms or you won't even know unless you're doing like a dual energy CT scan afterwards and you could see the petechial bleeding inside that infarcted area. Move on here. So what clinical features associated with an increased risk of hemorrhagic transformation in the acute ischemic stroke patient? Well, there's a whole list of things. Advanced age, NIH score, hyperglycemia, hypertension, poor collaterals, early infarct that you can see on this CT scan already, low platelet count, self-explanatory, antithrombotic drugs, and your reperfusion therapies. So I'm going to cover a few of these, not all of them. We don't have time. I've only got 15 minutes to talk here, so I'll try to get through some of these. So your age-related changes in the cerebral vasculature and your increased prevalence of comorbidities contribute to your risk of hemorrhagic transformation. And a lot of elderly patients have cerebral amyloid angiopathy and they have no idea that they have it. So that contributes to a risk of hemorrhagic transformation. Your severity stroke, patients with more severe strokes as evidenced by their NIH stroke scale are at increased risk of hemorrhagic transformation. So in the direct MT study, it showed that independent predictor of symptomatic hemorrhagic transformation were a baseline NIH score as well as glucose level at hospital arrival. So those two things were predictive of hemorrhagic transformation. So uncontrolled hypertension is a well-established risk factor of hemorrhagic transformation due to its detrimental effects on the vascular integrity and the predisposition of vessel rupture. The Enchanted trial showed that intense blood pressure control potentially reduces your risk of major intracranial hemorrhages in patients with acute ischemic strokes receiving intravenous thrombolytic therapy. Observational studies have shown an increased risk of hemorrhagic transformation in patients with high blood pressure and high variability of blood pressure. They suggest a close relationship in the hemodynamics and hemorrhagic transformation. So the American Heart Association, we know that the blood pressure following the delivery of thrombolytics is supposed to be 180/105. And in regards to mechanical thrombectomies, that is actually dependent on how the thrombectomy went, the TICI score on the patient, and surgeon preference. So they're the one doing the procedure. They know how much flow the patient's had, and they know the risk of the patient. So it varies after post-thrombectomy. So patients with diabetes have an increased risk of hemorrhagic transformation due to the microvascular alterations and impaired cerebral autoregulation. So listed here, the high glucose levels exacerbate the disruption of the blood-brain barrier. It can cause cerebral edema, which then increases your ICP. It impairs the fibrolytic system. It exacerbates neuronal injury and cell death, and it leads to larger ischemic strokes. Early infarct already seen on CT scan. The size of the stroke definitely affects the correlation of hemorrhagic transformation and ischemic stroke. Okay, reperfusion therapy. The aim of these two, intravenous thrombolysis and mechanical thrombectomy, their aim is to restore the blood flow to the affected area of the brain and decrease the extent of brain damage and improve outcomes. But sometimes the blood flow is restored in the ischemic tissue. It can lead to reperfusion injury, and the sudden reintroduction of this oxygen-rich blood can cause an oxidative stress to the brain and damage the blood vessel walls, leading to a hemorrhagic transformation. So according to the American Heart Association, the risk of symptomatic hemorrhagic transformation after TPA is about 2 to 7%. And we tell patients that when we are giving the TPA or TNK down, well, TPA, that's the risk, the 2 to 7s for TPA. So mechanical thrombectomies can provide a more rapid recannulization of the large vessel occlusion, which may reduce the severity of ischemic brain injury and thus reduce the risk of hemorrhagic transformation. Multiple randomized control trials have been studied, and they've shown that mechanical thrombectomies have a superior efficacy and safety without showing an increased incident of clinical relevant hemorrhagic transformation in comparison to exclusive conservative therapy. Both of these therapies are time sensitive, and we know that you got to have the TPA delivered within 4.5 minutes, and it's about 24 hours that we've been using for the mechanical thrombectomies. So if they're done in a timely manner, it improves outcome. The earlier you can do them, you have better outcomes. So what do we do if our patient deteriorates neurologically during or after the IV TPA? What's the first thing you're going to do? Nope, you're going to stop the infusion, right? Yeah, if it's TNK, it's already been given. Yeah. So you stop the infusion. You're going to monitor vital signs, get that GCS score, look at their pupils, call the doctor, perform non-invasive ICP measures or lower an ICP measure, head midline, so you know something's going on up there. Get a stat head CT, do some stat labs, coags, fibrinogen, type and cross the platelet because they're going to need something. What we usually give is cryoprecipitate. Okay, consider platelet transfusion and consider an antifibrolytic infusion as well. Oh, there they all are. Sorry. So what do you do if your patient has a neuro change after a mechanical thrombectomy? I got a few hints there. Yeah. So you're going to Vocera. We've got Vocera in the ICU, and most thrombectomies come back to the ICU. You're going to call the doctor. You're going to call the APP, whoever it is that your patient's had a neuro change. You're going to check your ABCs, make sure they're breathing okay, do non-invasive measures again to reduce ICP, prepare the patient to go to CAT scan, taking that monitor off, getting hooked up and ready to go. We love to scan everybody, so you know that patient's getting a scan. And make sure your blood pressure's in the prescribed parameters. Okay, most likely less than 160 is where you're going to be at with those patients. So. And that's all I have, guys. Thank you. And Jennifer is on her way up. Sorry, Marcia.
All right. I'm Jennifer Clark, a nurse practitioner in the neuro ICU. I'm one of the 10-year APPs that have been there. Next month, I actually get to celebrate my 20-year nursing anniversary. So that's exciting. Thank you. And it's very nice to see so many familiar faces in such a beautiful location. This background kind of reminds me of a rock wall. I kind of feel like jumping off a cliff, but just for cliff diving. So I'm going to continue to talk about complications of ischemic stroke that we treat in the neuro ICU. I think they need my presentation as well. JC. Let's see, move up my microphone. Can you hear me? I'm naturally soft-spoken, so I apologize. Okay. All right. Okay, good. So again, I'm talking about complications that we see in the neuro ICU. This includes large hemispheric strokes. Despite our best efforts, giving T&K rapidly, doing thrombectomy, we do not always prevent stroke, and many patients suffer from a large ischemic stroke. It places them at risk for malignant cerebral edema and cerebral herniation. And I always say stroke is like real estate. It's all about location, location, location. Patients can suffer a small stroke in the brainstem and suffer devastating effects from it, or you can have a larger stroke in a less eloquent area and have a decent recovery. Additional complications that we see are perfusion-dependent ischemia, seizures, and cardiac dysrhythmias, as well as morbidity and mortality. Stroke remains the second leading cause of death worldwide and the third leading cause of death and disability combined. So malignant cerebral edema. Cerebral edema after a stroke is an important cause of malignant progression of the stroke. It's a very high mortality with limited treatment options. Early prediction is critical. These patients typically progress over 2 to 5 days. They're at very high risk for herniation, and it's the leading cause of death within a week after stroke. And even in patients with non-life-threatening strokes, the severity of cerebral edema is an important risk factor to look at for poor prognosis. The pathophysiology of malignant cerebral edema is very complex. There are many factors that can affect the process. There's often intricate interactions among them. The blood-brain barrier is disrupted, and
Cytotoxic edema occurs rapidly after a stroke. It's followed by ionic, vasogenic, and then mixed edema. Cytotoxic edema and vasogenic edema are interdependent. The prolongation of cytotoxic edema induces vasogenic edema and vice versa. It's a vicious cycle. So it's important to remember the Monroe-Kelly doctrine. It underscores the delicate balance within our skulls, where changes in one component affects another. The skull is a rigid structure that contains, of course, the brain tissue, the blood, and CSF. And any increase in volume within one of these components causes an increase in pressure. So you can see a small change in volume leads to a significant increase in pressure. And just as a reminder, normal ICP is less than 22. So who's at risk for malignant cerebral edema? Patients that are younger, if they have a high NIH on presentation, if the infarct at presentation or post-op is greater than 50% of the MCA territory on CT. Poor collateral circulation also increases your risk for a larger MCA stroke. And revascularization actually reduces your risk because of having a smaller stroke volume. The following slide that I'm going to show is very busy, and it shows a lot of different variables that go into creating risk factor scores. I show the MBE score, Kastner index, edema score, and DASH score, which you can't read. Collateral circulation can be thought of as, the interstate roadways and smaller roads. If you are in a city with multiple different routes and a large interstate, if there's a backup on one road, there's alternate routes to take. But if you're somewhere or maybe on a bridge, and that's the only route available, it will cause much more damage, much more delay in blood flow. The circle of Willis helps protect the brain by providing multiple routes for the blood to perfuse the brain. The extent of collateral circulation is largely determined as embryos. However, it can be modified throughout a patient's life by several different factors, including aging, that causes the number and diameter of the collaterals to decrease, and there's also an increase in vascular resistance. Other vascular risk factors include hypertension and diabetes. They lead to poor collateral circulation. Smoking has actually been associated with better collaterals, which is felt to be due to ischemic preconditioning. Exercise improves collaterals as well as statin use. The top picture here is an example of a fast progressor. This patient presented after 90 minutes. You can see the purple area, they already have a core infarct and meaning they already have a stroke. Whereas the second photo, they have more collateral circulation. They presented after 2 hours, but no core infarct and still a decent sized penumbra. So how do we recognize malignant cerebral edema? We depend on nurses to do this with their frequent neuro exams. We see blown pupil or pupils, new anisocoria, altered mental status, posturing in your patients, increased ICP. Most of these patients don't have ICP monitors, but other subtle signs include headache, irritability, photophobia. Some non-neurologic signs include hemodynamic instability, or Cushing's response, which is elevated systolic blood pressure with a widening pulse pressure, bradycardia, irregular respirations, nausea and vomiting. Also, we do serial CT scans, which to monitor patients that are at risk for malignant cerebral edema. So you've identified your patient as herniating, they have malignant cerebral edema. Now is our brain code. Of course, first we focus on our ABCs, and then I'm going to go through the rest of these as well. So our ABCs, a GCS less than 8, we intubate. A GCS of greater than 8, sometimes we also intubate if they have impending neurologic doom, if they have severely increased ICP or malignant cerebral edema, and we want to target their CO2 goal of 35 to 45. Some of these patients have irregular breathing patterns, ataxic or Cheyne-Stokes breathing, which is alternating apnea with hyperventilation. The goal for circulation is to preserve cerebral perfusion during this critical time. So what are our nursing interventions? Of course, the ABCs, head of bed greater than or equal to 30 degrees, neck midline, minimizing neck compression. You don't want your ET tube, hanging down. You're going to call your provider for reinforcements. You're going to call your charge nurse. You're going to have the whole team ready. We're going to target normothermia, normal blood sugar. We're going to get a stat head CT, anticipate hyperventilation in our patients, and hyperosmolar therapy. I had mentioned this already, but we want to decrease the cerebral CO2 to promote vasoconstriction, decrease our ICP. We don't do this for a prolonged amount of time because it can, in fact, cause cerebral ischemia, but it's used as an emergent bridge to OR. Hyperosmolar therapy. We use mannitol and hypertonic saline. Mannitol is weight-based, 1 gram per kilogram. It can be repeated every 4 to 6 hours. We're trending our sodiums, our osmolality, and calculating our osmolar gap. We hold for an osmolarity greater than 320 or a gap greater than 20. Complications with this include hypovolemia and hypotension. Generally, anytime we give mannitol, we're giving a fluid bolus with it as well. Our hypertonic saline, we give in various concentrations, 23.4% to all the way to 3%, can be given as a bolus or a continuous infusion. We are able to give hypertonic saline through PIVs now, which is great. We target our sodium level up to 160. We have to monitor for hyperchloremia. Here are some examples of the different herniation syndromes. You can have subfalcine, central herniation, uncle. There's tonsillar herniation and upward herniation. So some of the patients that have large ischemic stroke or large hemispheric strokes, they're candidates for decompressive hemicraniectomies. This reduces mortality and improves outcomes for these patients. And the surgery itself is a removal of a portion of the skull to allow for the brain to swell outward, relieving the pressure. And you can see the decrease in ICP, increase in perfusion and blood flow to the brain. So when we're talking about decompressive hemicraniectomies, the patients that are candidates, they have large MCA strokes, malignant cerebral edema, refractory to medical therapy. It's within 48 hours of onset typically, but again, we're monitoring these patients frequently. Neurosurgery is generally always aware of which patients are at risk. They used to consider dominant versus non-dominant hemisphere as to being a candidate or not, but they say we should no longer allow that to play in decision-making, because even patients with dominant hemisphere, typically aphasic patients, there has been some anecdotal evidence that they support, they're pleased to have their lives saved, basically. There is a general age cutoff. The patient should be younger than 60 years old. However, it's all patient dependent. There's a significant decrease in mortality, 29% decrease with patients with surgery versus 78% the control group, and an increase in favorable neurologic outcomes as well. Again, when we're talking with families about this, they need to realize that this is a life-saving procedure, doesn't reverse the damage from the stroke that's happened, and the patient is likely to require a trach peg and prolonged nursing home stay. There are some complications. Of course, infection is always a complication. There can be sunken flap syndrome. These patients, if they come in with sunken flap syndrome, they need a cranioplasty done quickly. Cerebellar stroke and suboccipital craniectomies. These patients, they can worsen quickly. They can experience sudden clinical deterioration from the cerebellar swelling. Their procedure can happen more urgently, not only because of the small space in the posterior fossa, but oftentimes they develop hydrocephalus. So these patients generally do well, but placing them at risk for poor outcomes is a lower GCS on admission, delay in surgery, or a prolonged intubation prior to surgery, and any brainstem strokes. Posterior circulation strokes, I know Lena went into this, but we need to monitor these patients for bulbar symptoms. They tend to have dysphagia, reduced gag reflex, dysarthria, tend to have a nasal speech, which to me, it sounds more like a thick tongue speech, but it's very distinct, as well as facial weakness. These patients tend to benefit from an early trach peg. Perfusion-dependent ischemia. These patients tend to fluctuate a lot. These are the ones that we're going to target a higher MAP. We use Levophed to titrate to meet our MAP goals. It's also important to remember that the ischemic penumbra has impaired autoregulation. One of my favorite neurosurgeons likes to say that neurologists love to call everything a seizure. Turns out the neurologists are right about 2 to 23% of the time. But it is important to have seizure on our differential for these patients. Status epilepticus is uncommon, and we do not prophylactically treat these patients with anticonvulsants. Cardiac dysrhythmias are also common. AFib does place you at risk for having another stroke while you're in the hospital. Infarctions of the right hemisphere, particularly involving the insula, can have an increase in cardiac complications, and EKG changes secondary to stroke include ST depression, QT inverted T wave. Also, these patients often have an elevated troponin too. And just to summarize the rest of this with the blood pressure, elevated blood pressure and low blood pressure are associated with higher rates of death after stroke. And then our neuro ICU. This is a picture taken while they were still building. It shows the rainbows. And this is a photo from our 10-year anniversary. And of course, Dr. Naval. That was actually done on Christmas of 23, not 1977. And I like this quote that hope is the only thing stronger than fear. And our job as nurses and providers is to be there for our patients and their families as they're taking this roller coaster ride after a stroke where they're fearful and continue to be hopeful for these patients. And next is Dr. Nima.
Hello? Is this thing on? Yep. Hello, everyone. Thank you. I'm running a bit late. So what happened was I decided not to have any cases for today so I can come to the conference. But guess what? as our job is, stroke is, it's unpredictable. So I had 5 cases. So I apologize. I also couldn't put a nice shirt like Dr. Naval had that red. So I came in my scrub. So second apology. It's great to see everyone here. Thank you for coming. I'm just going to talk about stroke and basically the stroke journey when it happens and it comes through the ER. If you can put my presentation whenever it's ready. One thing about the stroke is, as you guys know, stroke is #1 cause of disability in the United States. And I see, people who are very dedicated in stroke because either they had a personal interaction with a patient with stroke or patients or whatnot. And the fact that we actually have the ability or possibility of lessening that disability is a great thing that we can offer to our patients. So that's what we do. I mean, that's why I wake up in the morning. And stroke is unpredictable, preventable, unpredictable, but now, thanks for technology, is treatable. We're at Baptist very lucky to have great technology to treat stroke. And when it comes to stroke, I always like to say the stroke team, right? A very important part of the stroke team is the APP providers, the nurses, and you guys provide such a great care to those patients, which sometimes goes unrecognized. You're on the ground, you do take care of these patients. So I do also want to appreciate and say thank you for all you do. With all said that, I guess my presentation is not coming. So any questions? Good. Thank you for asking. Thank you. So let's just go. So anybody here knows different ways EMS communicates with ER or with the stroke team about severity of stroke? Can you guys send some phrases out? Meaning when when the EMS brings the stroke patients, have you guys heard of some scores that they may send out? Lambs, good. What else? Cincinnati, very good. Cincinnati is good to recognize a stroke, but Lambs is the one that we have adopted. It's easy to do, and obviously they cannot do NIH in the field. Race, they're different scores. The reason that's important is because that helps differentiate a severity major stroke from a more smaller stroke. You guys know the cause of stroke, right? If you want to really start from the stroke journey, you got to really start in the heart, right? Clot forms there, very common. AFib, is a very common problem that sends a clot up north. Then you have carotid disease. So really the stroke journey starts there. So if you want to prevent a stroke, you better address those risks. But when a stroke happens, before we go there, sorry. So terminology is very important. You guys know about the LVO. Whenever you hear LVO, what does that mean? Large vessel occlusion. What is MEVO? Some people have heard this talk before, so you guys cannot answer. But what's MEVO? Huh? Medium-sized vessel occlusion. Very good. And we are, treating more medium-sized vessel occlusion because, we, again, have the ability to get there relatively safe. We have to be careful, though. Those are a little more selective. So yes, LVO and MEVO. Now, why are we talking about this? Because these are the more disabling ischemic stroke, right? So these are the ones that cause significant disability, and we have treatment. So it's important to recognize if a patient presents with LVO or MEVO. And as you know, we have thrombolytics up to 4.5 hours, standard of care. And thankfully, due to certain trials, including Dawn, which we at Baptist were included, American Heart have changed or had changed at that time, treatment of thrombectomy up to 24 hours. And we do it beyond. If there is a large vessel occlusion and there's a mismatch, brain is salvageable, there's no reason to stop at 24 hours. You cannot just say, oh, 24 hours, now we have 1 minute past it, so I cannot do a thrombectomy. It doesn't work that way. For thrombolytic, we're a little more strict due to the risk of bleeding. So stroke starts, as I said, at the field. The patient, somebody notices it or the patient notices it, you have to call 911. EMS plays an important role because they're the first medical contact for most acute stroke. They can recognize severity scale is important, treatment, initiation, and they have to triage. Not every hospital is equipped to deal with a stroke. So triage for a stroke is very important. And obviously, you guys know the importance of time, right? Anybody has any question about the importance of time in stroke treatment? Did you know that even every second matters, right? You've heard of time is brain. Well, each second delay for treatment can be associated with 2 hours of healthy life loss. Okay, is that important? I don't know. How about each minute lessens the chance of that patient's healthy life? So, if people want to like, live longer, healthier, well, guess what? Once you have a stroke, that clock starts ticking. And not only time is important when the patient gets to the hospital, when they get to the door of the hospital, by the time they get, for example, access for treatment, that time by itself is also very important and translates into better outcome faster you start treatment. This is what we do. We have we're a comprehensive center at the downtown. Obviously, we cover other campuses that bring patients to us. We can start treatment there, obviously with TNK if needed, and then thrombectomy at downtown. All right, I'm just gonna go over this briefly, but importance of time, like I said, is to initiate treatment as fast as you can and work in parallel. So as nurses, as providers, what does it mean to work in parallel in the ER when a stroke hits the door? Can somebody give me an example of parallel work when a stroke patient comes to the ER versus sequential work? I will not put anybody in spot, but anybody wants to say anything about what does that mean? Okay, let me ask you a different way. How many NIHSS score do you need by how many different providers to treat a stroke? How many NIH score do you need? 1. Anybody, any question about how many NIH? 2, 3, 4. How about the physician? ER physician does NIH, nurse does NIH, stroke team does NIH, interventionist does NIH, and then the OR nurse does NIH. How long does it take? Not that long, but just add them up together. That's a parallel process. How about you get the patient, get the Foley catheter, get 2 IVs, right? Labs, EKG, make sure they're stable, right? That's fair. And then get the scan, call the stroke team comes, evaluate the patient, then decide treatment. That's a parallel process. How about do it in, that's a sequential process. How about doing it parallel? So the stable patient comes to the ER. Instead of doing all this stuff, everybody meet in the scanner preferably and do all that in the scanner one time. You save time. So, by doing simple things like that, we have improved our time. And thankfully, I am very proud of our time because, our time has improved and has maintained improved. And I think that's very important. So you can see that, how do I go back? Yeah. So door to needle for thrombolytic is now on average about 30, 32 minutes. And door to puncture is around 40 to 50 minutes. And, we do quite a bit of thrombectomy. Our number have decreased. Sorry, this is an older slide. I need to update this to 2023. We have up to 300. So a year for thrombectomy, which is a significant number. So we're busy, which is a good thing. And what does all this mean? You guys heard about stroke and all that. What does that mean? Well, if you work together, stroke team, and increase collaboration with different care, I really believe that we can translate that into a better outcome for our patients. And that's what matters, right? I can bring you a fancy device and be like, oh, this is so cool. At the end of the day, what matters is how that patient does, right? All right, so how does it work? Well, you have an 88-year-old present with right gaze, left-sided plegia, Lambs of 5. Where's the stroke? Oh, it's a stroke talk. This is a stroke. Right, very good, very good. So NIH 18, Lambs of 4, Lambs of 5. Lambs of 4 or 5 are about 70 to 74% predictive of large vessel occlusion. So this patient, I don't remember the thrombectomy or thrombolytic part, but this is basically a simple way of showing. This patient had this blockage form. So this is looking right at the patient. The dye is injected in the carotid artery. How do we get access there? Well, we go to femoral. It's compressible and also it's relatively straight. We put a sheath. Through that sheath, we put another sheath. So we need the support. Support system goes here. Through that, with the wires and catheters, we're able to navigate that into the carotid artery and basically aspirate or remove that blood clot. And you can see the picture of the blood clot. All the clots are different. I'm still fascinated by the shape and color of the clots because really no clots is the same. And that's the stroke process. Now, does it stop here? And do we all high five and go home? No. As Jen mentioned, there's a lot of things that can happen. And thankfully, again, we have a great team who can manage this patient post-op. Blood pressure, secondary prevention, issues can happen. So all that care is very important, which I'm not going to get into. Some of that you already heard. I'm going to show a video of an actual patient, which I do have a consent. Sorry, it's a little older video. But other than that, if you guys have any question, you want to talk about anything else about the post-stroke, let me know. Could you put the video on whenever you can? And I think this is the end of the day, so I'm sure everybody's tired. Thanks for your patience and not being sleeping and staying here.
Okay.
Oh,
Open your eyes wide again. Good, good.
Yeah,
Okay. Lift up your left arm.
Sorry.
Left arm. Can you lift up your left arm? Okay. Lift up your right arm there.
If you could just pause in I'm going to ask you to pause it pretty frequently. So, sorry, the video is obviously not the best. I'm still learning how to become a photographer and an actor. But this is the actual patient. Again, patient presented to the ER. What happens when the patient gets to the ER? We have the stroke team, hopefully they're available. See the patient, evaluate, we get a imaging, CT, CTA, CT perfusion. CT, obviously, to rule out a bleed. CTA to look for LVO or MEVO. You don't necessarily need perfusion, in my opinion, except I really like perfusion for MEVO. I think that's helpful because sometimes it's hard, to be honest, to look for these little distal blockages. Then the patient, if it has a blockage that can be open, taken to an angio suite. The other important thing is communication. So send a pre-notification to the OR. Hey, we have a possible stroke, getting a scan. So that way the OR gets ready. And you don't want to wait. And I really am proud that everywhere I work, from the fellowship until now, hopefully it'll still be like that tomorrow, we all have agreement among different services. We do not wait when there's thrombectomy. Think about it. 10 years ago, or, I think Dr. Hanna was here. Obviously, he's older than me. But when I started doing this, this was still not a standard of care. So anesthesia would say, well, whoa, can you wait? No, let's have an understanding you don't wait. So once I have a stroke thrombectomy, I don't wait. And you know what makes me not upset, but I mean, that's unfortunate. If anybody tells me to wait when there's a stroke thrombectomy, that's the time that I'm like, no, there's no waiting in stroke thrombectomy. So you take that patient after the scanner up to the angio suite. Now, having said all that, there's an exception, right? We're talking about stable patient. If the patient hemodynamic problem, cannot breathe, those are all different. Once the patient goes to the angio suite, we take him right to the table, get access, and this is what you're seeing. So the patient is on the table, and remember that parallel work. So anesthesia is hooking up their stuff. Our techs are getting the patient ready. So everybody's working at the same time to get access. Could you play, please? Oh, sorry, before you play, one more thing.
Good.
You cannot appreciate here, but this patient has a gaze preference. I'm not going to tell you which side yet. And other than that, I'm doing a quick exam. Go ahead, play.
Is that left arm not moving?
No.
Yeah, I'm going to lift it up for you, okay?
Okay.
Hold it up. Okay. All right. And then lift his leg up there.
Lift your left leg up, sweetie. Hold it up there.
Hold it up. Okay, lift up this leg. The right leg.
Hold it up there. Keep it up
Good,
there.
good.
Keep it up.
Okay. All
Can you
right.
pause, please? So, gave the answer. So the patient has a right hemispheric stroke, right? Left side is plegic, right gaze. So this is the actual event. So that we got access. Obviously, you didn't see the access. From the access, we put the sheath under the sheath. So now we're in the right carotid, injecting dye to identify the blockage. And when the dye comes in, you can see the dye comes through. And it's interesting. I kept saying, oh, there's a blockage. And someone once told me, can you point out the blockage? I'm like, yeah, it's right there. But if you don't look at these images all the time, you don't appreciate it. So when you inject dye, it comes, and then you see right there, the dye just stops. So it's a tube, and something is preventing the dye to get to the brain. So that's where the blockage is, right M1. Could you please play, please? Pause. Anybody knows what are the methods or how many different ways we get that clot out? So there are way different ways, techniques, but two simple ways. You either put a nice big tube in there, and remember you have to go through this bendy stuff to get there, and literally suck or aspirate it, or you can go past the clot with a small wiring catheter, deploy a stent retriever, which is connected to the wire, and then bring that tube in, basically lock that clot and pull it all out. Here, you can see a stent. So it goes from here to here. The stent is a little far in. And then the clot is sitting right here. And there's another tube, which is aspiration catheter, which is brought right here, connected to a pump. Start the pump, and then you basically remove it as a unit. Stent retriever, and then another aspiration catheter. Press play, please. Pause.
Okay.
Okay. You have to see it very quickly. So that blockage is now open. Are you able to just go back for like 2 seconds? If not, don't worry about it.
Open your eyes wide as you can. Good. Look all the way to your right.
Okay. Yeah, right there. Nope. Back. Yep, stop right there. Perfect. Thank you. So you remember I told you there was a blockage right there. And after removing the blood clot, obviously that opens up the channel and the dye and oxygen is getting to the right side of the brain. So everything that we try to do is to try to get that clot out as fast as we can. And that is a very, very effective treatment. Go ahead, press play, please.
Okay. Open your eyes wide as you can. Good. Look all the way to your right. Look all the way to your left. Good, good.
On the
And what I
table,
want you to do is I
lean
want you to
and
lift
squeeze
up your
right
arms,
after
okay? Both arms. Good, good. Now left arm, bring it up a little higher. Now, both of them. Good. Now hold them like that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's great. Open and close your hands. Good, good. You can put your arms down. Great job. Now lift up your left leg. Bring it up, bring it up, bring it up, bring it up. Bring it up, bring it up, bring it up. Perfect. The other one. Good, good. Okay, you're doing better.
Very good. Look all the way on that way. And
Same
all
day,
the way
ice.
this
Is Alma
way.
here?
That's perfect. You can relax there. Lift your arm up here. Like you're catching raindrops.
Put both arms there.
Both arms.
Yeah, like you're holding something.
Like a good push up.
There you go.
Maybe, if you can. Like you're holding a big box. There we go. Close your eyes. Get the 9, 8, 7, 6, 5, 4, 3, 2. Good. Touch your nose with this finger. And the other side also. Very good. All right.
pause,
Lift your, don't lift this leg.
Perfect. So not obviously everybody recovers that fast, but this was an actual event that happened for this patient's life. Now, this patient could not move the arm and was weak on the leg. Is that a disabling condition? Of course. You cannot dress yourself. You cannot do anything. Now, right after the procedure, she's able to lift up the arm. So that disability, obviously the patient also went home in a day or so. So we basically, we as a team reversed or took away that disability. I think that is amazing, and the fact that we can do this for our patients. But it's not just the procedure, it's the whole team that respond and take care of this patient, all the way from the ER, EMS, to the OR, post-op, to the ICU, again, to outside of the ICU. So again, I want to thank you guys for what you do and what you contribute. And my time is up. You guys are tired?
You're on.
Any questions? I don't know if I have time for questions, but anybody wants to ask any questions? Oh.
Dr. Nima, that is a spectacular, presentation. But what happens when we fail to take the clot out? Because we've all been talking about, good things about the entire team. But what about stories of failure? Like, what happens when we cannot get it out?
That's a great question. Not everybody does well, and not all the clots can come out, and not all the strokes are the same. So thanks for asking that question. I think that, thankfully, our rate of recanalization, meaning opening up the blockage, is pretty good. It can improve, but it's pretty good. And actually, if you look at the data, cardiology suffered initially before my time, but then they were able to get the blockage open in the heart, same as us. We suffered through different trials back in the older times, but then once we're able to get the blockage open, you can see the graph kind of pick up. I would say up to about 90% of the time, a little higher than 90% of the time, we are able to open up the channel. So are there cases where we cannot open up channel? Of course, but I think opening up a channel is we have good device. The problem is some blockages are not due to just a blood clot. Sometimes you have the blood vessel that's diseased over time. Those are intracranial atherosclerotic disease. Those are the tough ones. We still can open it up by placing a stent. The risk goes a bit higher. Sometimes a little blood clot can go a little far inside the brain, and that can cause a problem. I think the challenge here is develop better techniques and different methods, right? For example, we are part of this trial where we're trying to answer that question. What do you do if you have a little distal blood clot goes up, we cannot get to after you do a thrombectomy? Well, how about if you do nanoparticles, inject it, and have a magnet suck that nanoparticle through the clots multiple times, and you get the blood flow back? We're trying that. So neuroprotection. Because the other big challenge is this. You open up the blockage, the patient still does not do well. Why? Well, the brain already is damaged or a fast progressor. So neuroprotection can help. And I think we have some good hope for neuroprotection. So I think the answer to your question is, I think we're good at opening up the blockages. The answer now is, what are the adjunctive therapy we can do to lessen the stroke burden? Question.
Ready.
That's it? Got me off the hook pretty easy.
Do you have a clicker? You want to pay a clicker?
We'll do that when we're done. How do we get up there? Okay, guys, I know everybody's tired. We're almost done, I promise. I promise. One more. We saved this one. We were going to do this one this morning, but had a little change in plans. You ready?
I'm ready. Are you ready?
I'm ready.
It's great to see a full house. Thank you for the team for putting this together. You know who you are. I'm not going to say names. I gave a version of this talk. I'll let Wendy stay there because
I'm short.
We're at
Yeah,
eye level.
got it. Thanks.
Nima just called me old, so
My 13-year-old
pay forward.
So
I gave a version of this talk last year in a meeting in Paris. So this guy asked me to talk about the future. This is where we were, where we're going. This is where we are, and naturally, this is hats off to the team. A lot of you are represented in this room. I think it's super, super cool when you're asked to talk about the future. And I wish I had that car and I was as cool as Michael Fox to go back and change the numbers of the lottery or change outcomes and things I bought this book when I was asked to give this talk, and I started studying and looking at the eclipse that happened this week, how that influenced the future of stroke. I tried to buy a crystal ball. It came broken. I could not see anything. And then I asked this guy, ChatGPT, what is the future of neurointervention? And then I paused and got enlightened by one of the greatest men that this country, I'm American by choice. The best way to predict the future is to help build it. So I think I'm proud of being where we are. Naturally, we always look at our shop. This is our 10th anniversary, but for thrombectomy, December 2024 is 10th year anniversary of the first positive trial. Mr. Clean is turning 10 on December 2024. So I'll never forget December 2014, New England Journal of Medicine, first positive trial. A month later, another 4. So in a couple of months, we had 5 positive clinical trials, and that changed the past and definitely shaped the future. And we are part of that. So next 20 minutes here, Wendy and I are going to tell you guys how we think this is going to play in the next 5 years. Somebody asked, what happened if you fail? I think the odds is we're going to continue to get better and hope we're going to fail less and less, always with the best of the patient in mind. So Wendy.
Take it away. All right, here we go. So I'm going to skip, wait a second. What happened? Maybe I'm going to skip that one and go to this one. So talking about, we're kind of going to go back in history a little bit. So I started here at Baptist. This is my 15th year at Baptist, and I started as a neuroscience nurse practitioner on the inpatient service. So I saw a mixture of general and stroke patients. Michelle Silver, who's sitting over here, was one of the A&Ms on the stroke floor on Tower 7A before Weaver Tower even existed. And, you know, we didn't do a lot of code strokes at that point. And I went back and pulled some data. I think our door to needle was somewhere in the 100-minute range. Does that sound about right? And obviously we weren't offering thrombectomy at that point. We actually were enrolling in Mercy trial at Baptist with the help of our neurointerventional team from neuroradiology way back in the day. And so we enrolled a couple of patients. I remember doing that with Dr. Jarvis. And then, you know, fast forward a couple of years, I'd been working on the inpatient unit and in the clinic actually. And I heard rumors that we were getting an endovascular service. So 2014, March 17th, 2014, we hit the ground running. What was that?
Who's counting?
Who's counting, right? Yeah. So I think it was Dr. Hanel, Dr. Sauvageau, Murley, and myself kind of started rounding that day. And a couple of weeks later, we had Margie and Jen and a whole complement of other neuro ICU nurse practitioner team members, most of whom are still here, I think, except for one of the original. Yeah. So we started offering thrombectomy at that point, and then a whole bunch of things happened. So those trials were released in 2015 at ISC that year. I don't think I've ever seen a bunch of neurologists stand up in a chair and wave flags and scream and clap before. So that was pretty exciting. That was really incredible. I mean, it was really incredible to witness that. And then things have continued to evolve, right? So in 2018, you know, we started doing extended window trials. We had already extended our window to 24 hours, but our volume started increasing pretty significantly about that time as well. And then 2020, we had some, I think we hit 200 cases officially in 2020. And then last year, we actually exceeded 300 cases for the first time. So thrombectomy is clearly here to stay. We've got data that's coming in the next couple of slides to kind of show you this isn't going anywhere, right? We've got sick population. We live in Northeast Florida. The population here is fairly unhealthy. In addition to increasing numbers of strokes, we're also seeing the number of patients that we can intervene on is actually changing, right? So we just talked about extended window. We've got large core trials, then we're looking at medium vessel occlusions. So the number of those cases that we can treat is actually increasing. So next slide. This is some SG2 forecasting data. So this is looking at, I believe, up until, is that going through 2027? I can't read. Yeah, so you can see that thrombectomy and endovascular volumes are, there's still a lot happening, guys. So we've got, you know, there's patients coming, whether we want, you know, whether we like it or not. They have to go somewhere. So obviously lots of other things are happening in the world, right? We've got Apple Watches. We have, better AFib detection, better treatment for AFib. We've got GLP-1 receptor agonists that are, hitting the market and really impacting outcomes for those patients. Stroke detection is improving. Hopefully we'll have some really cool stuff coming with Apple Watches. Dr. Handel might know more about that than I do. Who knows, maybe ChatGPT will get smart enough to detect stroke for us pretty soon. I think Dr. Freeman could give us a whole talk on that. Maybe he will at some point. That'd be really cool. AIS treatment, neuroprotection. So there's a lot of research looking at how we can protect the brain in the middle of a stroke, even before we can intervene. So things that EMS can do en route for those patients, and even other things that we can do once they hit the hospital doors. So more to come on that as well.
I'm just gonna pause
Yeah.
here. Go back one, Wendy, if you
See if I
can.
can-
So we finished Neuronatide. We're part of phase 1. We finished phase 2. And Neuronatide is one of these drugs that you don't need a CAT scan. So they have a study done for patients with intracranial hemorrhage. They have done a study for patients with ischemic stroke. So it could be that in the next couple of months, couple of years, we'll have a drug that the paramedic, okay, my Cincinnati Lambs is this, push the drug on the field, TPA, TNK, we need a CAT scan. So there could be a drug that will be giving people, another one that Dr. Nima's former mentor, Tudor Joving, is heavily involved, very simple, uric acid. It's a phenomenal. So NIH, national money, they put together a whole cascade of preclinical testing in 5 big universities. And they gave this university, okay, I want to test all these agents for neuroprotection. And uric acid, super simple, came back one of the top 3. So there will be a clinical trial using uric acid as a neuroprotective agent. And on all this, again, from rats to from non-human primates, this seems extremely positive. So we will have something so we are testing right now this carboxyhemoglobin oxygen carrier. Basically, our red blood cell carry the oxygen at a certain level. This carries the oxygen at 5 to 10 times more concentrated. So if your collaterals get a red blood cell there, it's going to take 10 times more oxygen to that cell that is starving. So this is a huge potential. So phase 3 is coming on that. If you go back, go forward to anyone for us. So this is the result of the phase 1 that's called Escape NA1. Canadian neurosurgeon Mike Timiansky, that is also a chemistry guy, developed that. So unfortunately, they didn't forecast the interaction between TPA and the drug. So on this study, some patients got TPA and medication before thrombectomy. Other patients got no TPA and medication, Neuronatide, and thrombectomy. The patients that got TPA, the study was not positive, but on the patients that didn't get TPA, this study showed a 7.5% absolute risk reduction in that, and the patients did much better. So the second study that we finished, and we're waiting to see the results, is just for patients without IV TPA. We are on the verge of going through this. When Dr. Nima came to us many moons ago, 7 years, if I'm not mistaken, when Dr. Nima came to us, we took a look at this. What happened for a thrombectomy that comes straight to the mothership, come to Baptist downtown? What is our door to puncture that? What happened if this patient comes from Baptist South? We knew there that we save about 40 minutes of brain time at the patient in hospital because all the work was done outside the ER. So somebody in Spain, a guy named Mark Ribó, to be precise, around Barcelona, Catalonia, that area of Spain, said, why we're doing all this testing? Somebody comes with a chest pain. Do I get a CTA to see if there's a coronary occlusion? No. Go straight to the cath lab and go open the vessel. So we got so much better at opening the vessel. And we got so much more liberal in who to open the vessel to. We start with, okay, up to 6 hours, up to 24 hours with very, very controlled imaging. Okay, let's regularize now. We do patients that have large vessel occlusion and large strokes. So I can do a very good CAT scan on my table, on the CAT lab. And there I'll say, there's no bleeding, puncture the groin, I'll get the clot out. So that's what we're doing right now. We're the first center in the United States to be doing that. We do have a study for that. It's called We Trust. Have many patients enrolled in Argentina, in Istanbul, in Spain, in Germany. So the idea here is, if this patient comes, pre-notification, I'm bringing to you a LAMS of 4 or 5. So we're working with EMS on that. When this patient is arriving at the ER, there's a group of people waiting for this person right there. And if this person qualifies, the machine is available, this person is being randomized, half of the group is going to get formal CT, CTA, CTP. The other half is going straight to the CAT lab, CT on the table on the CAT lab. We did 3-4 patients now. We know we're saving 25 to 30 minutes, and this will get better because the whole team is going to get facile with that. Go forward. And this one, so this is Philips. Siemens is working something similar to this. Dr. Lopez Dimitrios is working with the Siemens on this. So this is coming. Go forward. We know acute ischemic stroke intervention in 2029 it will be different than it is today. It will be better than it is today. We're going to have better tools. We're going to have medication. Maybe we're going to be using more 2B3A agents. You guys are going to hear tomorrow Dr. Hill, Michael Hill from Canada, talking about different quote-unquote thrombolytic agents. We study a lot the clot over these last 10 years, and we came to learn, okay, we used to think that a red clot that has a lot of red blood cells was easy to break with a thrombectomy or thrombolytic, and a white clot that first we said, oh, it's a white blood cell, then we said, no, it's platelet rich, then we said, no, it's fibrin rich, and now we're learning that is a net, is a little tray of DNA that got denaturated, they got old on that clot that makes that hard. So there's a new drug coming that wipes those DNA connections. So this is called a DNase, a DNase that is going to break that clot, and maybe is going to save my next 20 years, because it's not easy as a professional. A lot of you in the room are involved with that. 300 times a year plus the negatives that you got to go there, fish a clot out. And I'm hoping that Dr. Nima, the other stroke neurologist, can give a shot and say, bye-bye, you don't need to come fish the clot out. So this is coming. This is a joke. Naturally, size always matters. No, it doesn't. But in this case, it does. Go, Wendy. We start with the catheters that were 5 French in size. And you see that we went, from 41. You see now we're stopping. This is a slide from a dear friend, Quill Turk, that was the first guy to describe aspiration, called the ADAPT. Go forward, Wendy. So we are in a race, race for bigger catheters. So Penumbra goes up to 72, Microvention 88. So this is outdated. There's a new Sophia 88. Medtronic has a 72. Stryker has a 74. Cerenovus has a 71. Imperative has an 88. And those are here at the bottom. So Zoom 88 is missing that. But you see, there's a small little startup. I bump into this engineer in one of our meetings. This kid pulled up and said, would you like to see a nice catheter? This guy has a catheter that has an idea of a 106 that goes exactly to the same catheter that I can put my 88 through. So again, this is a 29-year-old engineer. He alone on his back door in Minneapolis found a way to design a catheter that gets to 106 with the same OD of an 88. So yes, we're getting better. We just start with the Capel, Cheetah, and Hippo, that the catheter does expand a little bit. We're about to start clinical trial with Anaconda. We're about to start a clinical trial with Millipede, that is another 88. We are learning more with the clot. So this is coming our way. I love the names. Sansom is the company. And for Brazilian, Clotilde is a very funny name. I don't know exactly why, but every time I see Clotilde, want to make me laugh. And the box is Clovis. So it's Clovis and Clotilde working together. What these guys did, measure bioimpedance of the clot. You can go and say, okay, I'm starting. Is there a pointer on that thing?
Yeah.
So you go with this little wire, it's just like your micro wire. And when you pass the clot, this will change the bioimpedance. It's going to say, okay, this is the end of the clot. This is the beginning of the clot. And you're going to measure the bioimpedance of the clot. That's going to tell you, is this a red clot? No, it's not a red clot. And then maybe based on that, you can measure the length of the clot. If you need a stent, what's the length of your stent retriever? Is that a better clot for a stent retriever? Is that a better clot for aspiration? So all the things that will come from that. And they are running a clinical trial in Europe. Another cool one, I work with this. For me, it's totally back to the future. Michael Fox on his machine. I work in an angioscope when I was a younger person, younger than Dr. Nima, in 2001 in Buffalo. These guys from Canada developed, we have balloon guide catheters that go here. They have a balloon guide catheter that goes inside the brain. So this balloon goes to the carotid, and then you can flush the blood out. And literally, you can run a little camera there. This is the side of this. Vina is the name of the company. So this is a micro angioscope. And maybe in the future, you can go there and take a picture. Dr. Nima loves pictures. You're going to go there, and this is a Vina picture of a red clot, of a white clot, and you can see plaque. So you can take a picture of the vessel from the inside, and that may change what we do. We'll live through this. You're going to hear this. Dr. Pedro Lilik should be with us tomorrow and Friday. They did the first case in human in Buenos Aires and in Toronto. I had a chance to be in Toronto. We're involved on research for that. We have this machine at Baptist waiting for FDA approval so we can start learning with that. You can see up to 10 nanometers. You can tell, okay, there are macrophages on the wall of the vessel. This is plaque. This is calcium. So we're going to be able to do live histology with optic coherence tomography. And that's a picture from a live case from Dr. Lilik. And I'm sure he's going to show you guys that. Oh, I don't have control of that. Let me try see if I can play that again. Can you play that video again, sir? So this case, they didn't know if this patient had atro or if it had. Can you try to stop for me when I tell you stop? You got to click on the screen, right in the middle one. Let me see. I'm going to go. Yeah, go. Let me see. Here, it's going to play. So here you see the run, you're going to see something different. It's hard without control. But what you see, we thought it was atro, is a sticky clot. So we're going to learn a lot that this is not atro. And if there's a clot, you can dissolve that with a medication. So, or you put a stent there anyway. And I think this is the last one, is robotics for neurointervention. We went through a little spike of interest on that with a company named Corindus that got acquired by a company named Siemens. They had clinical trial approval in Australia to run a robotic neurointervention for stroke in Australia, and then the support disappeared. Dr. Vitor Pereira, that unfortunately could not come, he's ready to do this in Canada. A patient from North Canada can take up to 24 hours or longer to get to Toronto during winter time in Canada. Too bad Eric's not here to describe to you how that feels. In Brazil, we don't have that. But this is going to happen, guys. Again, what level, what country, what location, this is going to happen. This is possible today to do a stroke sitting from here 500 miles away. You can make the robot move and do the thrombectomy. Dr. Nima talked about the impact. 1 in 3 we save. More than that, we help. and I'll bet the robot on the first generation is going to open 70–80% of the vessels. And if you fail, okay, now unfortunately we fail. Now we're going to invest 24 hours of your time to drive to Iceland, to get to Toronto, to get intervention. That's going to happen. And Nima talked to this about that. We're about to start this. There are two types of nanoparticles, one that is injectable IV and one that you deliver more. So we are on the infusion on the microcatheter nanoparticle. Those are very, very fine particles, don't cause a stroke in all animal models showing that. What this does is you put a magnet here and you think about your rotor-rooter, but in a very, very small version. This makes this metallic particles rotate in all different directions, and this macerates through the clot and carry the medication through the clot. So you're getting your TPA where it needs to be. The trial is on pause right now, but one case done at MUSC, and we're the second center in the whole world to be approved to do this. No question for me that the future is really bright. My crystal ball here. World Cup is here in 2026. This guy is killing it. If you guys watch Man City, Real Madrid yesterday, he's doing really well. And this is where the 6 star is going to go. So I know you guys don't know much about soccer, football. We have 5 stars here, right there, 5 stars right there. And just so you didn't pay attention, sorry, Wendy, 5 stars right there. This 6 star is going to go right there. This is already on sale on Amazon. I'm kidding. This is my wish. Thank you guys. A great, great first day. If you guys have any questions, comments.
Questions from the crowd? We are going to do the drawing really quick, but if you have any questions, we'll take those.
I'm going to have to repeat those slides to Dr. Lilik tomorrow, so I apologize if you saw already. Make sure you laugh again tomorrow. I said, I thought Argentina was the champion, so let's rehearse. And
yeah.
Where is Colombia in 2026? Colombia is going to have to be there maybe second.
Where? Who's
That's
talking about Colombia?
Susanna.
Oh,
Right over here.
it's a fair game.
There is 2 Colombians against 1 Brazilian right now.
Luis Diaz is fantastico.
That's right.
Oh, yeah, bring me your cards. Anybody have a card that they want to toss in this basket here while I mix them all up? No? Okay. All right, guys. Well, here it comes. Oh, there's more coming. Oh, my goodness. All right, guys. Pick that one. Okay, I'll fold the corner.
If you put a card at $100,
wow.
Wendy will pick that one.
Right.
May I say something really quick before you draw that?
Yes, ma'am.
Don't forget your evaluations. You guys can just leave it at the table. I will pick them up, or you can put them at the front. Just please make sure you guys complete it as part of your CEUs for the nursing. I know for CME and, I'm sorry, for the providers and ARMPs, you guys can scan the barcode, but we are still old school. So I need the paper in order for me to turn it for CEUs. So don't forget about me, because I get in trouble if I don't turn them in. Thanks.
Okay, guys. There's no drum roll. All right, here it goes. You ready? I promise I didn't look. Lori Vaniski. Awesome. Okay.
Lori, do you guys, was that you guys exchange masses?
No.
I do. Always. Maybe. You get the selfie?
Okay, guys, reception is open. It should be in the room where Abby, which room is it in? The vendor room. Sorry, my hands are free.
Hello, guys, is that it? Oh, I'm muted. Thomas muted me. Okay. Thomas, can anybody hear me? Oh, someone can hear me. Oh, okay, okay, Chris, is that it, Chris? I guess you can hear me. Oh, okay, so I'll see you tomorrow, same time, right?